And we are happy to call her that way. And without wasting much of your time, may I now invite her to deliver this talk, and I'll come back for the announcement on how our day will be. So welcome, Mother Superior.
Please don't use that word, Mother Superior. Deans and directors present, distinguished guests, and ladies and gentlemen, a very good morning to you all. I am not going to bore you with a long and lengthy story about the MUHAS Scientific Conference, but I'm going to try in maybe 5 and 10 minutes give you just a bird's eye view of what has been going on, because unfortunately I started and they won't let me retire. I don't know why they won't let me retire, but I'll find out later. So the main purpose of this short presentation is to showcase the success, the opportunities and the challenges and the lessons we've learned from 10 years of MUHAS Scientific Conference. This conference was an initiative to implement the MUHAS 5-year strategic plan of 2014 and 15 to 2018 and 19 that had the objective of improved capacity for research and consultancy. So when they looked at it, so how do we improve research and consultancy? The chiefs of MUHAS decided, let's establish a series of scientific conferences. And the purpose of these conferences was to make MUHAS more academically visible, for people and other institutions to recognize its name, become familiar with its work, and recognize MUHAS' scientific contribution in improving lives, national growth, and academia. With your permission, may I provide what a short historical synopsis of the conferences, where we came from, where we are now, and where we intend to go. The first conference was held between the 2nd and 4th of May in 2013 at Colucci Hotel. It had the main theme, health research towards poverty alleviation. At that time, that was the theme to be, as all countries, including in Tanzania and in other developing countries, were implementing various strategies at alleviating poverty, including the National Strategy for Growth and Poverty Reduction. Our first conference, we had high officials officiating, and I'm proud to say the first conference was officiated by Dr. Mohamed Gilad Bilal, the former Vice President of the United Republic of Tanzania, and our keynote speaker was Dr. Ahmed Salim, the Prime Minister, former Prime Minister and Secretary of OAU. So we started really high level. Unfortunately, like our any first venture, we had a shaky start in terms of academia. At that conference, we were not really well known. We had no experience in establishing scientific conference. So we only covered 4 sub-themes. And we only had 221 participants. We had only 96 abstracts, in contrast to today. 70 we presented orally, 20 as posters, and 6 we had to say no to because they were not of the quality we expected. But even then, at the first conference, we had international delegates, and I'm pleased to say we attracted people from Gambia, the United States, Zimbabwe, Denmark, and Sweden. Despite this status shake, we continued, and I'm pleased to announce that MUHAS has never stopped holding its annual scientific conference. Even amidst COVID, we still had a conference, if you all remember. And it was a challenging time, but this taught us a lot of things. It taught us how to innovate and how to change structures. We have gained competencies over the years, and now we're probably trying to produce and hold more impactful conferences than before. And we still are attracting international and local and international presenters, but we also are attracting more keynote speakers from abroad. We were supposed to have somebody from Sweden, unfortunately it fell in, but we have had keynote speakers from as far as Japan to come and officiate keynote speakers from conference, and we're very proud of these. As the conference has grown, we've increased the number of sub-themes from 4 to 10 to accommodate new science avenues like artificial intelligence. The conference has grown to have panel sessions, parallel sessions, and now we have satellites, and even have in some conference innovation hubs. Our oral presentations have increased from 70 to over 106, and from 20 posters to over 100. And I think we are growing stronger and stronger, and we will increase the conference to 3 days. We have changed the format. Before, the conference was only physical, you had to attend. Now we have changed into a hybrid format. And this transition has allowed us to increase participation from a maximum of 503 to now 1,200, because we're live on Zoom and YouTube, and we're very proud of this innovation. As we progress, the MUHAS conference has become more of an acceptable avenue that is reputable for international and local researchers to present their findings. The findings that have been presented over the years have presented solutions to health gaps, identified new research areas, fostered changes in policy and practice, supported strengthening health system and education system, and resulted in innovation and invention. Many of the research findings presented at this conference have been published in peer-reviewed journals, been drafted into policies that we've heard yesterday, but all of this has made MUHAS more visible academically, locally, and internationally. And this has provided MUHAS the opportunity to be called on more and more by the government to support their activities in health-related matters. But moreover, it has helped us to become an increasingly formidable leader in research. It has increased our collaboration and research and consulting portfolios. Now we have over 100 collaborative networks as a result of findings presented at this conference. And that has made us very, very proud as we're getting more and more research grants from the findings we present. Distinguished delegates, if you will indulge me, let me give you a bird's eye view of what has been taking place at the previous conferences. For example, the findings of the HIV, mother and child transmission research groups have impacted policy. They have findings have promoted WHO gold guidelines on mother to child transmission, including the use of option B+ from the MITRA studies and all the studies that followed. The malaria group findings have brought to light that intermittent preventive treatment in pregnancy with monthly dihydroadenosine piperacin, IPT-PT, is safer and better than the original ITP-SP. The sickle cell group has helped us to identify that hydroxyurea, that was originally a cancer drug, can be used for sickle cell patients and is now part of the essential national list of drugs. The NCD researchers have shown us that diseases like chronic kidney disease is becoming more common in children, and that stroke is more common in people of a younger age between 40 and 55, and therefore interventions must target these populations. The infectious disease researchers have shown that not all fevers in children are due to the malaria, hence changed the syndromic approach to fever and helped coin the term sicular homa ni malaria. The pharmaceutical and traditional medicine research group were able to formulate chewable albendazole with improved dissolution rates and developed a number of traditional medicine products for asthma and COVID. Health systems strengthening group have showed us that there's a maldistribution of healthcare workers in Tanzania that we need to rectify, and that we are underutilizing community health workers in reproductive health. And even more important, that we need to strengthen our health system in terms of surge capacity to handle pandemic outbreaks for Ebola and COVID. Ladies and gentlemen, I would also like to point out that one of the major achievements of MUHAS conference is the inculcation of a culture of research and innovation, not only to our academic staff, but more importantly to our students. The annual conference has made it a deliberate practice to support and mentor undergraduate and postgraduate students to showcase their research and innovations. And I'm proud. My other name is Bibi. Bibi Mother Superior. I'm proud to say that our students have taken up research like fish to water. Their research ideas presented at various MUHAS conferences have informed policy, and some have converted into practical inventions that have won national awards like Mkanda Salama, Saratani Ayai, Daktari Mkononi, and Afya Tools, just to name. And I think they deserve a big hand of applause. Regardless of these many achievements of MUHAS Scientific Conference, for the conference to really translate research into practice for national growth in the future, MUHAS needs to be empowered. First, to inculcate the culture of research translation within institutions. We're still an institution who publish and puts it on the shelf. So we need to change and take our publications and turn them into inventions and innovations. Secondly, we need to provide adequate infrastructure, particularly for basic and clinical research, so the science that will be presented here in the future is of cutting edge, and we can compete with the international community. Thirdly, we need more avenues for local funding and establishing and nurturing innovation. If all of this takes to root, research presented at MUHAS Scientific Conference may be transformed into market-ready products, innovations, or services that will enable Tanzania to attain the SDG goals. Conducting research for the purpose of innovation and invention will surely enhance MUHAS' leadership role. May I quote the founder of Apple, the late Steve Jobs, at this juncture: "Innovation distinguishes between a leader and a follower." And MUHAS definitely wants to be the leader, not the follower when it comes to cutting-edge research, innovation, and invention. Ladies and gentlemen, as I approach the end of my talk, may I take this opportunity to thank again our ever-dedicated development partner, Sweden, through SIDA, for supporting this conference 10 solid years, in person and in financial. There was a lot of talk between the two Ingas. I was so confused, but they made this possible. May I also thank all other development partners, collaborators, and funders of MUHAS research activities. I may also thank all researchers, students, and the general public for either submitting abstracts or just attending. Without you, there is no MUHAS conference. Thank you for being here. Lastly, as part of the organizing committee, may I thank the university management for supporting the organizing committee to mount this conference. We had a lot of help, a lot of commitment, and we thank the MUHAS management for that. With those few words, I wish you all a continued second day of fruitful deliberations. Asanteni sana.
Thank you very much. our very own. Thank you. Yeah, thank you very much, our very own Mother Superior. You have heard herself as testified. You may take your seat. I think the way she has given it in a very organized way, the round of applause was not organized. So we'll reward her by clapping 3 times, then pause, 2 times, then pause, then 1, then pause, then you finish like this. So 1, 2, 3. So some were not following. So thank you very much, Mother Superior Bibi. That's another appendage. Because she has given me some few more minutes and I have been given mandate by the chairperson, I invite anyone who would like to ask her any question regarding to what she has presented. Just raise up your hand, then we'll give you a mic. Maybe you want to understand something more.
Okay, thank you very much, Mother Superior Bibi, for a brief overview concerning the 10 years of MUHAS Scientific Conference. And you are the person of being engaged for all these years. I just want to know specifically what are burning challenge which you think we need to pull up to make sure coming conferences might be better, or what a very big challenge you've been experiencing in organizing these conferences for these years in concerning to the support from the country and the commitment from individual person and an institution MUHAS being involved.
Thank you. Yes, another one. I'm taking 3 questions. So yeah, the second one.
Thank you very much. So my question is, what is your dream MUHAS Scientific Conference?
Have you ever dreamed? Oh, now hands are coming up. Okay, I'll take 4. That one, then this one. And then I provide another one, a special one for a female. So I think I'm not becoming biased, but I'm trying to bring equity.
Yes, I'll go direct to the question. What do you think that you failed? What do you think that you failed in your activities concerning the MUHAS conference, the scientific conferences?
Have you ever failed anyway? Yes. And then I said I'll do another one.
Thank you, Madam Bibi, for a nice presentation. So my name is Sam Mashaka. My question directly to you is, how do you think, what is the strategies you plan to maintain this legacy for the next maybe 50 years to come?
That means you'll be the longest living person in this world. So I have not seen a lad raising a hand for that special opportunity which I gave. So I take back the mic for your responses.
Thank you for the wonderful questions. If I'm going backwards, if you allow me, I will not be here in 50 years. I'll be dead. They would have retired me. So in 50 years, I definitely will not be here. They're about to kick me out soon. Trust me. But what I envision in 50 years' time is this conference to be a huge international regional conference. I am speculating this conference should be so big, like the AIDS conference, International AIDS Conference, where you have 4,000 delegates and you get lost trying to find your venue. So this is my vision for this conference. Let me start with where I failed. As human, we always fail. Sometimes I think the infrastructure, we have not built sufficient infrastructure to accept and review abstracts. We lose them in the emails, we lose them in the portal. And one of my biggest challenges for 10 years is the portal. And we need to have a high sophisticated portal that can accept contracts, abstracts, help us review them and respond in a timely manner to the people that represented. This is one of the areas that I have really failed, and I'm still working on it. And the capacity to accept abstracts, I think it's an ICT technical issues. Once it's too full, the server just collapses. So this is an issue. Also, where I failed is to disseminate the information. Some people find out 2 days before that we're having a MUHAS conference. We need better at organizing, providing time enough for people to prepare and submit abstracts. Sometimes we do it too late, and we apologize for that, and we will try and improve in the future. So those are one of the challenges. The other challenges that I see is mentorship. At this conference we are getting more and more young researchers coming, but as seniors, we have an issue of mentoring. Many of the juniors come with very good ideas, and that is where the term BB came from. They come with an abstract. Of course, the reviewers would never accept it. But if you mentor them properly and help them to write, they have wonderful ideas. And I think at our institutions, we're missing the mentoring element. We want to shine as seniors and researchers, and we forget that we need a legacy and somebody has to carry us forward. So I pray on you to please mentor your juniors. First, what I've learned, they are more intelligent than I am, but they just don't know how to write it. So please mentor them, and then we really have cutting-edge science. The other thing that I said in my speech that was a challenge is that we don't have the infrastructure to do cutting-edge science. We always have to go abroad to get a PCR machine, a sequencer. We have limited. We have quality control issues. But the other thing is for government institutions that is a challenge is procurement practices. We have good brains. People wait 25 years to get reagents to do science. So we must make it easier for scientists to get infrastructure, to get reagents, to be able. There were some wonderful presentations here. I wished I was 20 years younger and doing vaccine research, but all of the work was done abroad. We have good scientists, we have good molecular biologists that could mentor these students, but we don't have the infrastructure, and the government is not funding cutting-edge science. The funding is donor-driven. So that, I think, is a challenge. So I think we should try and find local avenues that would support young scientists, to do cutting edge, to do innovations, to do inventions, and to support them. But what we also need is the government to support us, to link us with industry. This conference has no industrial partner. I haven't seen anybody from SIDO. I haven't seen anybody from Mo Ibrahim. Those are the people that should give us money, should give us ideas that we could innovate as research scientists. But we're not looking and we're not linking private practice into our research. It's still many government funded. And I think this is a shortcoming. So my dream, I think my dream was there. My dream is to retire. Play with my grandchildren and not be chair of the scientific. My boss, Dr. Kidya, did you hear that? But he's always on deaf ears. He never listens. So my dream is really for this conference to continue, but not maybe as MUHAS alone. Let's collaborate with other institutions and make it a MUHAS plus something else conference. So it's bigger and it's better and it's of the highest quality. I think I've answered. Thank you.
Thank you very much. Is that how you reward people who are organized? So we use the same formula. 3, 2, 1, then you finish by standing there, your feet. So 1, 2, 3. Thank you very much. Now it has been more organized. And you can actually say exactly who has just come after I have said. So thank you very much. Now you can take back your seat. So you will agree with me that it was very important to ask her some few questions. Thank you, Mwenyekiti. So after this, we are going to have 4 parallel sessions, which in each session you will also be in 2 pairs. The first will start from 10 o'clock to 10:50, where we'll have a 10 minutes break. Then we'll start the second pair in the very same venue. So we are going to have the first parallel session in LT5, that is where we are, which is on communicable and non-communicable diseases, epidemiology and interventions 2. The second will be on lecture hall 4, that is the room adjacent to us, cross-cutting issues, technology and health, environmental and occupational health. And the third one will be in Chipe main hall. Chipe is the other building that you have to go out and go to your right-hand side. If I use my geography properly, I think that is to the southwest. And, the other one will be on seminar room, which is to the north and east from this side, which is the other building there, which is formerly known as Mloganzila. And then we'll come back to this after those parallel sessions, which will end at midday. We are going to have poster session and lunch, which will take us to 12:50. And from 13 hours to 16 hours, we'll be having satellite sessions, which will be happening in 3 different places. One will be in this hall we are, that is exploring MUHAS innovation ecosystem in the past, the present, and the future. So you can actually explore your future in this room in the afternoon. And the other one will be in Chipe, which I have just said. It is on the southwest, diabetes in Tanzania, a 360-degree overview. And the other one will be on the adjacent side, the LT4, which is on key populations, status of HIV epidemic and ongoing innovation to address the epidemic. After 16 hours, we will come back to this room for closing ceremony. And in a very special way, we will have a summary of the recommendations from the presentations that happened which will be presented by the chair of the governance organized committee. And then we'll have award giving ceremony. We'll have a series of awards today during the closing ceremonies from the presentations that has been happening. And of course, it will end by closing remarks from the guest of honor. Without continuing to bore you more, I wish now to invite you to go to the different rooms as I have explained the geography. Thank you.
Hi, good morning, conference organizer. Sorry. I have a question. Could you kindly send in the chat the Zoom link for the no?
But this is very good.
Okay. Okay, we'll do that. We'll do that in a minute.
Boston Shedura, who will present his topic on seroprevalence and factors associated with HIV infection among pregnant women living with HIV/AIDS in Twara. Boston, you'll have to introduce yourself briefly so that people know where are you coming from.
Okay, thank you, Mr. Chairperson, for the warm invitations. My name is Volstan Shedura, a resident from the Department of Epidemiology and Biostatistics, MUHAS. My presentations will be on seroprevalence and factors associated with hepatitis B infections among pregnant women living with HIV/AIDS attending PMTC clinics in Twara region. So, as we know, HPV infections continue to be a public health problem, and it goes up to 80% of all cases of hepatocellular carcinoma worldwide. And the global health sector strategy on viral hepatitis aimed to achieve 90% reductions on the new cases of hepatocellular carcinoma or of hepatitis B infections, and a 65% reductions on the cases on the mortality associated with hepatitis B infections by 2030. So worldwide, as of 2019, there were 354 million people living with hepatitis B infections, and out of these, 296 million were chronically infected, leading to about 820,000 death yearly. So looking in Africa, the seroprevalence of HB infections ranges from 5 to 7 in the general population, and 0.8 to 11.8% among the pregnant women population. In Tanzania perspectives, the seroprevalence ranges from 5.5 to 20%, and the general populations, and 3.8 to 8.03 among the pregnant women population. So what's the problem? Despite efforts that have been done globally and even nationwide to reduce the hepatitis B prevalence, the burden is still high, and we know the vertical transmissions remain the major route of risk of transmission. The hepatitis B, the HIV-infected mothers who are co-infected with hepatitis B, from different literature have shown that those mothers who are infected with HIV and co-infected with the hepatitis B have higher rate of having their children also infected with the hepatitis B. And those children have higher rates of failure to respond to the vaccine. And people including pregnant women who are co-infected with hepatitis B have higher levels of anemia, and progression to chronic hepatitis B is approximate to be 5 times higher as compared to those with hepatitis B monoinfection. And also they have a high risk of liver cirrhosis and hepatocellular carcinoma. So several studies have shown the burden among the blood donors, and this is because hepatitis B is one of the pre-transfusion testing that is done in Tanzania and many other countries, but also in the general population. But there is scarcity of studies that have been done among the pregnant women population, and especially those who are living with HIV. So the finding from this study will help to guide for further interventions, including the instituting routine screening program at PMTC clinics, but also to institute hepatitis B prophylaxis among the infected mothers and hepatitis B birth dose to neonates who are born from the infected mothers. And also this will help us to align with the global health sector strategy on viral hepatitis and the national strategic plan for control of viral hepatitis by 2030. We aimed to determine the seroprevalence among the hepatitis B infections among the pregnant women living with HIV, attending PMC clinics in selected health facilities in the region from February to April 2022. And also the factors associated with these infections among the study participants. So it was a health facility cross-sectional study that were done from February to April 2022, and it was conducted in 4 health facilities that are found in the Mtwara region, found in 4 districts, that is Mtwara Municipal Council, the Masas District Councils, Masas Town Council, and Nanyumbu District Council. And this is because this facility contributes about 63% of the total people living with HIV in Mtwara region. And we included all HIV-infected pregnant women at least 18 years old who are attending PMTC clinic of any gestation age and on ART, and who consented to participate in the study. And those who had a prior history of hepatitis C vaccination, we did not involve them, and those who have a confirmed diagnosis of HBV. We use a systematic probability sampling approach with a sampling frame, with sampling fraction of 2, and the sample size was 225 participants. So looking at the data collections and laboratory procedures, a written informed consent was obtained from 220 eligible participants at the PMTC clinics, and from this a structured questionnaire was administered, which consisted of social demographic informations, economic informations, and clinical information. And also some information was obtained from the CTC2 cards and the CTC2 database of the study participants. And then the 4 ml of blood was collected from the participant using a plain tubes, and sample was prepared at the local laboratories in each facilities, and initial screening was done at the local laboratories where hepatitis B was screened, hepatitis B surface antigen was screened. And also those who had no previous results for syphilis was also screened for syphilis rapid test. And then sample was temporarily stored at the facilities, and were transported into the referral hospitals and national blood transfusion laboratory for confirmation and further testing. So the tests that were done at the referral laboratories involved the hepatitis B surface antigen, E antigen, and total and hepatitis B co-antibodies and so looking at the results, so most of the participants were from Commander Hospital and they had primary level school of education. They were, and majority, all of the participants were on antiretroviral treatment and majority of them were in first line and for more than 12 months. And those who had positive results had normal ALT levels. So the prevalence obtained were 10.5%, and in that, those who had chronic infections were 10%, and acute infection was 0.5%. And the distribution of serological markers as seen, most had hepatitis B surface antigens and total and hepatitis B co-antibodies. Looking at the factors associated with hepatitis B infections, we conducted a logistic regressions, and the result for multivariate logistic regression showed that those who had, those mothers who had HIV viral load of at least 1,000 copies per mil were 16 times more likely of being infected with hepatitis B compared to those who had less than 50 copies per mil. Again, we also saw that syphilis was associated with hepatitis B infection, whereby those who tested positive were 27 times more likely of being infected with the hepatitis B compared to those who had no syphilis. Again, we also saw that the multiparous women were also associated with hepatitis B infection, whereby those who had 4 children and above were 11 times more likely of being infected with syphilis as compared to those who had only 1 child. For this, seroprevalence of 10.5 indicates high endemicity according to WHO criteria, and the finds are considered with the different finds done in Cameroon and Ghana with seroprevalence of 9.3 and 14.9. But again, we have seen that B multiparous is associated with HB infection, and this could occur since these women may have been subjected to issues like unsafe sex, multiple sexual partners, and surgical procedure, which may escalate the transmission. But again, syphilis and HIV viral load was also associated with HB infection, and this could occur since the immunity of these participants may have been declined, so that to allow other opportunistic infection, including syphilis. So by wind up, we have seen that by winding up, we have seen that the seroprevalence is 10.5 among the pregnant women living with HIV, and children are more than 4 and having higher viral load of at least 1,000 copies per mil, and being infected with syphilis are significant factors associated with hepatitis B infection among the pregnant women population in Tura region. And for this, we recommend scaling up of screening program and instituting HB vaccine ambassadors among the neonates born of the infected mother. Thank you.
Thank you very much. So may I remind the presenters that the presentation time is 10 minutes and we will be strict on it. And so you have to make sure that you present very fast, but we must understand you as well. And I'll stop you when the time comes because we have so many presenters. So may I call forward the second presenter? Dr. Valeria. Yeah, karibu.
Yeah.
So, habari za asubuhi. I'm Valeria Silvestri. I'm in the Master of Science of Parasitology and Entomology here at MUHAS in the second year. And the topic of my presentation is subclinical cardiovascular damage in schistosoma endemic regions. So we are discussing the findings from a recent project that we implemented in Kome Island here in Tanzania. Okay. So we know that in patients with schistosomiasis, cardiovascular damage may occur, and this can be due, can be secondary to direct damage to vessel, to the inflammatory burden due to the disease, and to exceeding of the vessel wall. And aneurysms, which are a loss of shape, of normal shape, physiological shape of vessels, with an increase in diameter may occur and have been described in literature in sporadic case reports. The true prevalence of this issue is unknown in this setting. The aim of our study was to describe and to assess the prevalence of subclinical cardiovascular damage in this population endemic for schistosomiasis through the assessment of different parameters such as the study of intimal medial thickness in carotid arteries, the measurement of major aortic diameters and prevalence of aneurysm in population, and the prevalence of carotid artery stenosis as a damage in the carotid vessels. And to check if there was an association with a history of schistosomiasis or with actual infection by the parasite. So we designed a cross-sectional study among participants aged 18 years living in and above, living in Kome Island, which is known to be endemic for schistosomiasis. We assessed several, we collected data related to anamnesis of patients, such as smoke, alcohol consumption, previous anamnesis of schistosoma, some physical examination parameters such as weight, height, body mass index, and systemic artery pressure. And we also studied participants with the color ultrasound examination, especially in carotid vessels and abdominal arteries. Assessing specifically the intimal medial thickness, so the thickness of the layer inside the artery, the presence of carotid stenosis, the diameter of aortic vessel, and the presence of abdominal artery aneurysm. Furthermore, we analyzed stool and urine samples to assess prevalence of schistosomiasis, both hematobium and Manzoni in our participants. So we had a total number of 264 participants. The majority were female. We see there in the graph. So 165 female and 98 male. The mean age was 50 years old, and with a range from 18 years to 93. And here we've got the prevalence of hypertension, which was 44.3. Which is still lower than data from Europe, for example. A history of alcohol intake, which was significant of 32 and 22% of overweight people. Here we've got finding according to carotid arteries. So we've got 12.9 participants had an increased intimal medial thickness. 8.3% had actually plaques, but the important thing to notice here is that they weren't, there was no association, we found no association between these findings in carotid artery and a previous history of schistosoma or positive findings in the samples collected from the participants. Instead, when we went to analyze the findings in the abdominal aorta, which is more interesting here, we found that the lateral maximum aortic diameter was increased values of this measurement were found in participants with a previous history of the disease. Here we can see that the range of the measurement of aortic diameter went from 10 millimeters 0.3 to 27.8. And if we see on the graph there, the cutoff for diagnosis of aneurysm is 30 millimeters. So we didn't find any aneurysm in the abdominal aorta. But we found, according to box plot, this difference according to anamnesis in participants. Okay, also here we've got the table, it describes better this concept. So the measurement in abdominal aorta wasn't different among participants with a positive or negative investigation in stool sample for schistosoma manzoni, but it was significant according to a previous history. So likely to be more, the association is likely to be related to a chronic exposure to the condition, even if the actual stool sample is negative and we can't find the parasite now. Here, we conducted a multivariate logistic regression analysis and confirmed this result. So the association with an adjusted odd ratio of 1.15 between the maximum aortic diameter and a previous history for schistosoma. Additionally, we found an inverse association between diastolic pressure, and instead the laboratory positivity was, as we know, inversely associated with age, but this we know because prevalence decreases according to age. Okay. One of the objectives of our study was to assess aneurysm lesions. Of course, we didn't see any abdominal aortic aneurysm, but there was a limit with the probe we used, which was a portable ultrasound color machine, which didn't have the function for Doppler. So it was difficult when addressing, for example, visceral vessels or overlapping of structure between venous and artery to detect whether it was an overlapping of structures or actually an increase in diameters of the vessel. And this was a limit of our study. Here I summarize some of the doubtful findings, but none of them were a very huge thing. I reported the picture of one of the case reports. We got the poster outside, which was actually a shunt in a portal hypertension, related to hepatosplenic schistosomiasis. We go to conclusions. So we've seen that we found a significant difference in maximum abdominal aortic aneurysm in participants with a previous history for schistosoma. It's important to note this at this regard that even though no aneurysm was reported, a very recently published paper on cardiovascular risk, according to aortic ectasia, has observed that there can be an increased risk in cardiovascular, risk also in participants with abdominal aortic ectasia. So this could mean that we should check this population better for cardiovascular risk in order to better plan prevention. So further investigation are also needed on aortic damage in order to also assess the situation in upper segments of aorta, which could be more prone to the effect of infectious disease such as the thoracic due to the histological composition of the aortic wall in this segment. And this wasn't performed in our study because, of course, the thorax is more difficult to examine, and we need more advanced tools rather than ultrasound. This could guide, of course, policymakers in addressing the issue of cardiovascular morbidity management in schistosomiasis, which is one of the goals for the future. Asante, And yes, I would like to thank all the departments for the support continuous that we have.
Thank you, Valeria, for being in time.
Yes,
thank you very much. I now invite the next presenter, Dr. William Mawala.
So good morning. My name is William Mawala. I'm the final year resident in hematology and blood transfusion. Today I will present a preliminary result of a bigger ongoing study known as IRL study. And the title is Clinical Pathological Characteristics and Factors Associated with poor response in children and young adults with lymphoma in Tanzania and Uganda. So lymphoma is a diverse group of lymphoid neoplasms, and the presentation is highly variable, so you cannot. Lymphoma is a huge blanket for that. But basically, we have malignant lymphoid cells and their precursors causing all the pathology. And the trends in sub-Saharan Africa are on the rise, and we expect they will double by 2035 from the prevalences in 2022. And again, as I highlighted, patients present with all set of symptoms, and the symptoms are mostly constitutional, so they resemble other chronic infectious diseases that are prevalent in our settings, such as tuberculosis. And this actually is one of the causes of delays. However, in our regions, we mostly see patients presenting with abdominal distensions or abdominal lymphomas, but also gonads and also nodular disease. But it can literally affect or infiltrate any tissue. And so the main way of actually deriving to a diagnosis of lymphoma is mainly through tissue diagnosis and immunophenotyping. So a pathologist has to sort of confirm the diagnosis of lymphoma before we can actually institute treatment. And the good thing about lymphoma is if caught early, the outcome is really, really good with the current available therapies. However, in our setting, we still are losing a lot of kids to lymphoma, and partly is because of inadequacies in early diagnosis, and also still patients actually came late to the treatment centers. So for an effective interventions for any malignancy, not just only lymphoma, early presentation to treatment centers is key, and that would actually inform, would help after the patients have actually received, arrived at a treatment center. We need a timely and accurate diagnosis, and that would help with effective treatment and monitoring. So the three components actually would work for any type of malignancy. But for early presentation and to a treatment center, clinicians at the referring centers, they really need to have high index of suspicion that the patient perhaps they might have lymphoma and not just maybe a tuberculosis, as we see. So a well-defined clinical characterization of lymphoma needs to be out there. But also for timely and accurate diagnosis at the treatment centers or even referring centers, we need our pathologists and also the clinicians to be well conversant with the pathological presentations And also we need to have reasonable time to diagnosis and make sure that our pathology systems in the lab are working. And also for effective treatment and monitoring, assessment of treatment responses is key as well. So this was actually the center of our problem, and we set out. We believe our study could actually.
Dr. Mawala, you have 4 minutes.
Oh, okay. Would actually answer that. So the aim was to characterize the clinical lab features and treatment responses of these children in our setting, in Uganda and Tanzania. And I say this is part of a bigger study that involved 3 sites, but currently we have 4 sites. And what we did is we started the retrospective cohort of the patients that were already enrolled in the mother study. And the study ended up enrolling, by the time that we were doing analysis, 153 patients with confirmed lymphoma, and we ended up with 111 patients who we actually followed up and assessed the treatment outcomes. So this is a table trying to show the characteristics across the study sites, and you would see most patients actually young, except for KCMC where they had a median age of 17, and this would be explained by because most of the patients there had diffuse large B-cell lymphoma, the type of lymphoma that we usually find in patients, in much older patients. Another thing that is key here is also the time to diagnosis. You would see that the local turnaround times is usually 14 days, but more than half of the results actually came. Actually, the delay was more than 14 days. Another key findings that I wanted also to highlight here is association with the aggressive tumors would have unexpectedly high levels of LDH, and again, the rate of first-line treatment failures actually affects. There's a significant association with the type of tumor. I would quickly go to the responses. You would see here that we had to divide our patients based on whether they failed their first-line treatment or not. And you would see here that still we have only 50% complete remission rate at the end of induction in patients who actually kept on first-line treatment alone. And also the figure on the right shows that Hodgkin and Burkitt's lymphoma actually registers good response. However, we still need to have the 90% rates that we were not able to actually see here. And this is at the patient who failed the first treatment line, and again, the responses were not very good. So we were not able to do the factors because of the limitations in, because we had, after viewing that the outcomes are very different when you look at them according to the type of lymphoma, so we had to, the power was not adequate to actually assess response by the lymphoma subtypes. And again, the advantage of this study is that at least it's one of the few multi-center studies that integrates time delays and response to treatment. Take-home messages here is one, failure to respond to first-line treatment actually also could hint outcome later on. Because of time, I think we need, in conclusion, we need to strengthen diagnostic capacity at the referring center because we see still the time to diagnosis is delayed, but also more effective treatment protocols perhaps needed across all the lymphoma subtypes because we're not registering the outcomes that other studies in Europe and in other parts of the world are registering. And this, our study forms the basis for a long outcome data studies that would actually look at the long treatment outcome. So thank you for you. Thank you very much. I think this marks the end of my presentation.
Thank you, Dr. Mawala. You are worried. Yeah, thank you. May I welcome the fourth presenter, Dr. Liberata Mwita. Is Liberata around? All right. So if she's not there, then Nasib Eid Sadiq, can you please come forward? Nasib Eid Sadiq. He's not there also. Okay. So we can move to question and answer session for the first presenters. So may I call forward all the presenters so that we ask questions. Karibuni. The audience is welcome for the questions. I know you have questions for the three presenters.
Thank you. Thank you very much. My name is Dr. Joseph, and I will direct my question to Dr. Shedura. So you did different serologies for hepatitis B, surface antigen, antibody, co-antigen. So how did you define the positive hepatitis B that you included in your analysis? Thank you.
Okay, thank you. My name is Victor Mezakiarosi, and I'll project my question to Dr. Mawala. You said you are assessing the clinical pathological characteristics that attributable to treatment response. So I was asking, how did you assess the treatment response? I mean, were you considering the pathological complete response, and which criteria, which means were you using in your study to determine the pathological complete response? Yes.
Hello. I'm Ashu from MUHAS in Oxford. I have a question for the second speaker. You probably said it, but I didn't get it. The schistosomiasis, obviously you're saying can induce changes in the aorta, but there were, from recollection, a lot of the people were overweight, were smokers. How are those confounding factors play a role? Did you look at that?
Anyone else with a question? So maybe my question goes to Dr. Shedura. You were looking at the seroprevalence and factors associated with HBV infection among women, pregnant women, HIV-infected pregnant women. But in your exclusion criteria, you excluded those who were known to have hepatitis B viral infection and those who were vaccinated. Can you tell us why?
Okay. Yes. Yes. And so we adjusted for those facts. We analyzed if they could confirm the findings, but there was no association between age, sex, because of course we know that age, sex can like affect the aortic diameter. So there was no, it was not significant for those. Thank you.
So thank you. I think the question to me was, how did we assess the response criteria? So depending on the type of lymphoma, patients usually are being started with chemotherapy. Then after 2 to 3 cycles, they are assessed to see if they've actually attained a good response. And that would actually say if they're failing on the first-line treatment regimen or not. Then at the end of, let's say, 6 cycles or 4 cycles of their chemo, then a tumor board panel would actually sit again for assessment. So we're using the RESIL 2007 RESIL criteria for lymphoma to assess how much the tumor has shrunken. And this is usually being done using imaging. So, yeah. But, yeah.
Okay, thank you for the question. The first question was about the criteria did I use to define positive in my analysis. Okay, for the because the presence of hepatitis B surface antigen, it's the one we call hepatitis B infection. So those which were detected positive for hepatitis B surface antigen were regarded as positive, and it's the positive that we are using for analysis. But other serological markers like hepatitis B co-antibody or IgM and total hepatitis B co-antibodies and hepatitis B E antigen were used for further categorizing the hepatitis B infection into acute and chronic infection. And the other questions was, in my exclusion criteria, why did I exclude those who had a confirmed diagnosis and those who had a prior history of hepatitis B vaccination? Because our study based on our study was a cross-section study, and we based on those who have who had no hepatitis B status. So we just based on those who were not tested for hepatitis B, but those who had already confirmed diagnosis, because that's already known. So we looked for the one which is unknown. Thank you.
Okay, thank you. But Dr. Shedura, when you're looking for seroprevalence, seroincidence, you want to map a burden of a disease in a locality. So leaving aside those who are infected, we underestimate your prevalence or incidence. And so likewise, when somebody is vaccinated, it doesn't mean that somebody is protected and can yet be infected. So in your study limitation, you have to address this, that your seroprevalence is underestimated because you have left aside these people. Yeah. Thank you. So let us, I thank you all for good presentations, and let us applaud them. Thank you, guys. Now we go to the second phase of presentation, and we have one Dr. Gwambegu, Dr. Antimon Tibus, Dr. Diane Umulisa, Leonard Mroso, and Everest Wilson. Are you all available? Dr. Gwambegu, are you there? Okay. Dr. Antimon, Diane Umulisa. kabisa. Leonard Imbroso. Leonard Imbroso. Okay. Everest Wilson. Okay, so we are missing Leonard. So we'll start with Dr. Gwambegu. You're reminded that the time is 10 minutes and we'll stop you in between if you are not up to time. Karibu.
Good morning. My name is Alice Gwambegu from the Department of Internal Medicine. I'll be presenting to you the results of a study titled Incidence, Predictor, and Outcome of Hyperglycemia Among Critically Ill Patients Admitted in ICU at Muhimbili National Hospital. About 17 to 68% of admitted in our ICU develop stress hyperglycemia within the first 48 hours. And long-term stress hyperglycemia has been linked to poor clinical outcome, which includes increased morbidity and increased mortality. In Tanzania, there is positive data on stress hyperglycemia among critically ill patients who are admitted in the ICUs. However, a study by Musere et al. Has reported stress hyperglycemia among patients with TB to be 17%. Our study aimed at determining the incidence of stress hyperglycemia as well as the predictors of stress hyperglycemia among critically ill patients who were admitted in the Muhimbili National Hospital ICU. And it also aimed at comparing the 30-day mortality rate among these critically ill patients, those with stress hyperglycemia and those without stress hyperglycemia. It was a hospital-based prospective short-term cohort study where 270 patients were studied. We defined stress hyperglycemia as fasting blood glucose of about 6.1 millimole or more, or random blood glucose of 7.8 millimole per liter or more, or glycated hemoglobin of 6.5% or more. And this had to be within the first 48 hours of hospital admission. If the same happened, but that was after 48 hours of admission, was defined as secondary hyperglycemia. To determine the predictors of stress hyperglycemia, logistic regression was used, and Kaplan-Meier mortality curve were used to compare the 30-day mortality rate of patients with stress hyperglycemia to those without. More than half of our patients were males, and they were not on steroid use. They had no comorbidities, and more than half again stayed for less than 5 days in the ICU before they had developed stress hyperglycemia. Now, the findings of our research found that incidence of dysglycemia among these critically ill patients who were admitted in the ICU were 44.4%, of which 29.2% had developed stress hyperglycemia, while 15.2% had developed secondary hyperglycemia. Steroid use was found to be associated to development of stress hyperglycemia significantly, and this was found to be protective during the acute phase of the illness, where about 67% protection was observed in steroid use, but this was not the case for secondary hyperglycemia. And time of ICU stay for less than 5 days, as well as comorbidities, was also significantly associated with the stress hyperglycemia. This is a Kaplan-Meier curve depicting 30-day mortality rate among critically ill patients who were admitted in the ICU. And the curve here, the blue curve represents patients who had stress hyperglycemia. The green curve represents the patient who developed secondary hyperglycemia, and the brown curve is representing those who had not developed stress hyperglycemia while in the ICU. And from the graphs, we see that patients who had stress hyperglycemia, the blue curve, had more cumulative hazard ratio of 2.5, and majority of them, all patients actually with stress hyperglycemia, had died by 15th day. And this was followed by secondary hyperglycemia, whose cumulative hazard ratio was between 2.2. In conclusion, incidence of stress hyperglycemia is high in our ICUs, and the presence of comorbidities and steroids are significantly associating with the stress hyperglycemia. It also contributes to higher mortality rate among these critically ill patients, and therefore we recommend a long-term follow-up study to determine how many patients with stress hyperglycemia will end up developing type 2 diabetes mellitus, which is a long-term complication of stress hyperglycemia. I thank God to have come this point, but I thank very much my supervisor, Dr. Grace Chayo, my co-supervisor, Professor Nag, and all other who made this possible. Thank you.
Thank you, Dr. May I call upon the next presenter, Dr. Antimon.
Good morning. My name is Antimon Tiburus, resident from internal medicine. I'm going to present to you the result of research titled Polypharmacy and Health-Related Quality of Life among older adults living with HIV who are attending CTC clinic at Muhimbili National Hospital, Mloganzila and Upanga. Globally, we know the data from Global in 2020, it was found that around 37.7 million people had HIV and around 28 million people were accessing antiretroviral therapy. And about 1.5 million people became newly infected in that year 2020, and about 700,000 died from AIDS-related AIDS-related conditions. And 67 of these patients are coming from sub-Saharan, where Tanzania is also among the countries. In the year 2019, Tanzania, we had about 1.7 million people who are living with HIV. So we can see this is still a burden in our community. So what is our concern? Accessibility to ART does not only have positive impact on the society, it can have some positive and negative impact at the same time. It increases life expectancy among this group who are vulnerable to AIDS-related and also age-related comorbidities. And these comorbidities will lead to increased susceptibility to using of concomitant medications, which will lead to a risk of polypharmacy and hence drug-drug interaction, which can lead to poor quality of life. So in Tanzania, we are lacking enough data with regard to magnitude of polypharmacy, its associated factors, and its effects on treatment together with quality of life among these individuals who have now living longer than it was prior to the invention of ART. So what we wanted to know is prevalence of polypharmacy in HIV-infected older adults on the ART in our locality, and also to determine the risk factors for polypharmacy and its impacts on quality of life. So we conducted this study, and polypharmacy in this study was defined as concomitant use of 5 or more medication apart from ART, on top of the ART. And older adults were defined as those people aged 50 years or older according to WHO. So we conducted a hospital-based cross-sectional study, which involved 287 older adults who were living with HIV on ART, and they were attending care and treatment clinics at Upanga and Mloganzila campuses for the Muhimbili National Hospital. So we collected the social demographic and clinical characteristics, whereby we used a standardized tool, WHO tool, to assess quality of life. This is a special for HIV, and a score of less or equal to 50 meant a poor quality of life, and a score of more than 50, this was a good quality of life. And this WHO tool had got 6 domains: physical health, psychological, level of independence, environmental and social relationship, and religious. So health related quality of life and polypharmacy were presented as proportions and were compared using a chi-square. We also used a Poisson generalized linear regression to assess for the association between baseline characteristics and polypharmacy and quality and/or quality of life. A p-value of less than 0.05 was considered statistically significant. So patient characteristics, majority of the study population were aged between 50 and 64 years, and more than about 2/3 of the study population were females, and majority were coming from Dar es Salaam as their residents, and having no formal or primary education contributed about more than a half of the study population. And majority of the study participants were attending clinic at Muhimbili National Hospital Upanga campus. So what we found, polypharmacy is prevalent among people living with HIV, older adults aged 50s and above, and it was prevalent by 18%. So determining the predictors of polypharmacy, we found having comorbidities increases a chance of having polypharmacy by 18, and this was an independent determinant of polypharmacy as compared to those who have no any comorbidities. With regard to quality of life, out of 287 study participants, 14% had poor quality of life as an average quality of life with regard to all the 6 domains of quality of life. And having no formal education or primary education was an independent determinant of poor quality of life among this study population. All the mean score for all the domains were above 50. However, the most affected domain which contributed to poor quality of life was the social relationship. And the best score was in spiritual health, which is scored about 90. So what we can conclude from this study is polypharmacy is prevalent among older adults living with HIV on ART. Comorbidities and attendance to clinics other than CTC was associated with increased risk of polypharmacy, and having no formal education or primary education was associated with poor quality of life, and social domain was the most affected domain. We recommend increased social support and synchronization of treatment and care for both HIV and other comorbidities in order to minimize the risk of polypharmacy and hence improve quality of life. I would like to acknowledge Dr. Candida Moshiro, MUHAS biostatistician, Muhimbili National Hospital Administration for giving me permit to conduct this study, internal medicine academic staff for their support, and fellow residents and all the participants. Thank you.
Thank you, Dr. Tibus. May I welcome the next, Dr. Diana.
Morning, everybody. My name is Diana Mulisa. I'm a third year resident in med hematology and blood transfusion. I'll be presenting to you my research, which is about myelotoxicity in patients with colorectal cancer who are treated with FOFOX, which is a combination of treatment. We'll be seeing it furthermore. And those patients were treated at Ocean Road Cancer Institute and Billy National Hospital. This work is also co-authored by Dr. Nasser and Dr. Clara Cham from Department of Hematology and the blood transfusion at MUHAS. Non-communicable disease is a problem for currently it's a large and increasing challenge for the disease of worldwide currently. And cancer, among those four main types of non-communicable diseases, is also a challenge. Among the cancer patients, colorectal cancer is the third most commonly diagnosed cancer worldwide. And so it is in Tanzania as well. Particularly in Tanzania, the study which have been done show that there is a remarkable increase in incidence of colorectal cancer in young patients, which are less than 40 years old. This makes it a big challenge for our population. FOFOX, it's a combination of three drugs, which is recovering fluorouracil, mostly known as 5-FU, and oxaliplatin. And when it's given 6 months, is a standard treatment for those patients with a colorectal cancer who have locally advanced metastatic colorectal cancer. It has shown a tremendous change to those patients in terms of improving the quality of life of those patients who have colorectal cancer. But it has also been documented that it is associated with myotoxicity. And among those myotoxicity, we have, with toxicity in general. And myotoxicity is among those common side effects of that treatment. And several studies which was done showed again that there is also other factors which are associated to the contribution to myotoxicity of those patients. As I was going through the literature, I have seen that we don't really have those studies have been done in industrial countries, and we really don't have those data about not only to colorectal cancer patient, myelotoxicity in colorectal cancer patient, but myelotoxicity in general in patient who receives chemotherapy. And this is a big limitation to those patients to continue receiving the chemotherapy or completing the treatment. And among Africans or in Tanzania, there is no data about that. And this may be in the first ones. As I mentioned, those studies being done outside or in white population we can find different factors contributing to that in our population. So that was our aim to see what really contribute to myrotoxicity in our population. The aim of our study, as I said, it was to look at the prevalence of those patients who have myrotoxicity from the treatment, which is FOFOX, and also to see the associated factors to those who have myrotoxicity. What was the associated factors? In our study, we defined myrotoxicity as the presence of anemia, which was hemoglobin less than 12 grams per deciliter, and having also the presence of neutropenia, which we looked at absolute neutrophil count, which was less than 2,000 cubic millimeter, and you could have one of those or you could have both combined. So that is how we defined the myrotoxicity. And we went on and graded the myrotoxicity using the common terminology for cancer adverse event, version 5, and we see how we graded those ones. For our methodology, it was a cross-sectional study. We did this study, we conducted the study at Ocean Road Cancer Institute and Muhimbili National Hospital, both in Dar es Salaam, Tanzania, and we covered those patients who were diagnosed and treated with the treatment from 2016 to 2021. And we enrolled 260 patients who were histologically confirmed to be colorectal cancer and were also treated by FOFOX. We used a simple random sampling to enroll our patients who were eligible, and to collect data, we used a data extraction tool that we had designed for collecting the data. As to manage the data management analysis, the categorical variables was analyzed as proportional, and chi-square test was used to assess the association between the categorical variables. And also we did multiple binary logistic regression to look at the predictors of the myrotoxicity. And the p-value, which was less than 0.05, was considered statistically significant. We obtained the ethical permit from the institutional review board of MUHAS, and we also had further permission from the authorities from the respective institutions that we conducted the data. Coming to the results for the social demographic characteristics of our patient, the mean age of our patient was 53.5%, and we found that a majority of our patient was in the middle age, 51 to 60 years, and the predominant with more than 50% were male. And in our population, more than 50% had a normal BMI. In comorbidities that we assessed in this patient, we found that HIV was the most comorbidity, followed by hepatitis and hypertension. We evaluated the performance status of those patients using ECOG, and we found that most of our patients had ECOG less than 2 or equal to 2. The tumor site was, most of our patients had colorectal cancer, more than 50%, and it was stage 4 cancer, most of them. We found that also most of them had surgical as part of the treatment, and they were in that category that we categorized as those who had more than 4 cycles of chemotherapy. In general, when we did we analyzed our data, we found that at the baseline, this is full blood count, which was taken before the patient goes to the start treatment. So we found that myrotoxicity was 11.5, and anemia was just 1.5, 4.5 neutropenia, and those who had combined was 5.7. If you can see, there is a big increase of myrotoxicity after starting treatment. This is patients who started on treatment developed myrotoxicity, and you can see a tremendous increase of myrotoxicity from 11.5 to 66.9. And you can see respective also anemia and neutropenia has increased remarkably. And when we took those ones who had myrotoxicity and tried to see which was predominant, we found that more than half of those patients had anemia. And this is actually different from other studies from the industrial countries where they found that their patients develop more neutropenia than anemia. As I said, we graded those patients to see the severity of the myrotoxicity, and we found that if you can see the blue representing the baseline when they had not started on treatment, and when the red with where they started treatment. If you can see, there is for instance, on anemia, you can see that almost half of the patient went into myrotoxicity. Even though a big number of those patients were graded in 1 to 2.
Dr. Can you give us your conclusion? Your time is up.
Thank you. So we found that there is association between age, surgery, and having surgery as part of the treatment, and also to have had more than 4 cycles of chemotherapy. And when we did multivariate analysis, we found that as the age increased, also the chance of getting myrotoxicity increased. And so it is in the number of cycles. We found that those who had surgery was protected, had 40% less chance of getting myrotoxicity. So we concluded that our population had more myrotoxicity than other study which was done, and having age and number of cycles and surgery as part of the treatment was contributing to have myrotoxicity.
Thank you very much. May I call Dr. Evarist Wilson?
Hello, good morning. So I'm Dr. Evarist Wilson from School of Dentistry, a resident in second year. And this study is part of SICO Pan-Africa Research Consortium Fellowship, titled Oxygen Saturation in Primary Teeth of Individuals with Sickle Cell Disease and Sickle Cell Trait. So we know sickle cell disease is a genetic disorder following inheritance of a mutant hemoglobin, which is due to substitution of glutamic acid in the beta chain of hemoglobin by valine. And when these erythrocytes erythrocytes with mutant hemoglobin, they are normally distorted, they are rigid, and they become more adherent to the vascular endothelium and easily polymerize, especially in low oxygen tension. And this precipitates most of the complications related to sickle cell. Another issue is they also block capillaries and also restrict the blood flow to different tissues and organs, especially the microvasculatures. These are also inefficient in carrying oxygen through the microcirculation to the peripheral tissue. And so they lead to different sequelae. So it was of our interest to start the dental pulp because of its unique features. First, it is the soft tissue or the neurovascular tissue in the center of the tooth, which is surrounded all around with hard tissue. So resilience of the tissue around is little, but also the fact that it's surrounded by hard tissue, it may be more sensitive to any changes to the oxygen saturation. And there is little collateral blood supply as compared to other vascularized tissue in the body. So we know of recently that there are almost 12,000 single cell births per year in Tanzania. And the available modality are sort of expensive. They are invasive and not really available to majority. So this modality for diagnosis, screening, and therapy monitoring. So pulse oximeter in dentistry has been used to assess vascularity and vitality of the dental microvasculature. So this study investigated the oxygen saturation in the dental microvasculature of primary teeth of individuals with the sickle cell disease, and here HBSS, sickle cell trait. And we compared them with those with the HBAA. The aim was to establish the usefulness of sickle cell oximetry in sickle cell screening or monitoring of sickle cell therapy. So this was just to provide a baseline information on the pulp oxygenation in sickle cell disease and sickle cell trait, but also to find out the relationship of oxygenation in the teeth, but also against the general body oxygenation with this easily affordable, non-invasive, and legally available tool, which can play as an adjunct screening and therapy monitoring tool. So we had to determine the oxygenation in the pulp, both in sickle cell disease, sickle cell trait, but also explore the correlation to the general blood flow, or rather general blood oxygenation. So specifically, we determined the oxygen saturation in the pulp of primary teeth of individuals with sickle cell disease, sickle cell trait, but also we explored the relationship of the pulp oxygenation against general body oxygenation. So this was a comparative cross-sectional study of individuals with sickle cell disease, sickle cell trait, and I would call healthy individual, but not to discriminate anyone. These were 30 to 60 years old, and we used a handheld pulse oximeter to take oxygen on 6 anterior maxillary teeth and from index finger of each participant. And we used a universal sensor or probe to take, which is a small size, so it can easily adapt to the teeth, to take oxygen saturation from the teeth. And it was adapted, the light emitting diode was adapted in the facial surface of the teeth, and the receptor in the lingual surface held perpendicular to the long axis of the tooth. And we also recorded age, sex, and hemoglobin levels of the participants. We excluded those participants who had HB below 6, those who had dental caries of the candidate teeth, who had deep restoration, severe periodontal disease, tooth mobility, developmental defect, and those who presented with severe sickle cell disease symptoms and chronic pulmonary disease and heart disease. This one was ethically approved by the Research and Ethics Committee of the MUHAS. Our analysis of data was done using SPSS version 20.0, And we generated mean oxygen saturation for a group of teeth, central incisor, lateral incisors, and canine. And then we generated group mean for the study groups, the sickle cell disease trait and HBAA. Then we ran post-op analysis in one way and another to find a bone. This was a bone ferron test to compare means across the study groups. Then the Pearson correlation coefficient calculated for mean oxygen saturation on finger and teeth, and level of significance was set at 0.05. So we studied 93 children, 53% of which were girls. Their mean age was 46 months. Only 3% of participants with sickle cell disease were on hydroxyurea, and on 88.8 were on either folic acid or penicillin or both. And that is a summary of distribution of our study participants. These are teeth, because we examined the 6 teeth from each participant. So generally we found when you group the teeth, we have 2 central incisors, 2 lateral incisors, and 2 canine for each individual. So when we ran the mean for a group of teeth, we found the trend is generally individuals with sickle cell disease had low oxygen saturation, and canine showed a little bit a trend of high oxygen saturation across the group. Then we ran a mean as well for the study groups, and we found individuals with HBSS had low oxygen saturation below 80 as compared to the rest of the group where there was no difference. So the difference between those who had sickle cell HBSS and the rest of the group was statistically significant. However, when we also ran the same graph shows data for index finger, there was no difference across the group, regardless of HP phenotype. So several other studies have reported low mean oxygen saturation from permanent teeth, because most studies started from permanent teeth in HBAA, but our study found low mean oxygen in primary teeth of HBSS, and this agrees with several other studies. The low oxygen in permanent teeth of HBAA is attributed to diffractive effect of the LED and infrared light of the oximeter by enamel and dentin. However, in HBSS, the even lower oxygen saturation may be additionally explained by the fact that there is a reduced resilience and oxygen carrying capacity of erythrocytes through the microcirculation, thus low oxygen delivery. So the dental pulp may be sensitive to such changes due to its hardy tissue confinement and lack of collateral blood supply. This suggested by the finding that finger oxygen saturation remain unaffected regardless of HP phenotype.
Can you give us the conclusion?
So the conclusion, thank you. So the conclusion is the dental pulp is more sensitive to minor changes like what we see in sickle cell disease. So it can be a potential tool to be used to do a screening and possibly to monitor therapy for therapy that are targeted at improving oxygen delivery to the periphery, including hydroxyurea. But we recommend further studies like those which uses Doppler fluorometry to benchmark our findings.
Thank you.
Thank you very much.
Thank you very much. So Dr. Ambroso has arrived. So Ambroso, please come forward for your presentation.
Thank you, Chairperson. Good morning, everyone. My name is Dr. Ambrose Leonard, a third-year resident in the Emergency Medicine Department. Today, I would want to share with you my study results on pre-referral stabilization and timeliness of referral as a predictor of adverse events among adult medical patients referred to tertiary hospital. It is a custom in the emergency medicine department worldwide that whenever one hospital wants to refer a patient to another hospital, a phone call is made to notify the receiving hospital about their intention to refer the patient and the status of the patient. And it has been a practice here in the emergency medicine department of Mwembili. Critical ill patients are often transferred from outlying low capacity hospitals to be stabilized at the emergency medicine department and for continuum of care in the intensive care unit. We noticed that there are patients who are referred from other hospitals, and on their way to Mwembili National Hospital, they get adverse events, and some they arrive with advanced physiological deterioration that leads to poor outcome, and some they even get adverse events in the emergency medicine department. And the adverse events that I'm talking about here, they are cardiac arrest, death, or organ failure like brain death. So we wanted to look into the problem. In developed world, studies have shown that appropriateness of stabilization done at referring hospitals and timeliness of referral influences the occurrence of adverse events after arrival at the emergency medicine department. However, in our settings, the appropriateness of referral stabilization by the referring centers and the timeliness of referral is not known. So we come up with an idea to do a study to evaluate the appropriateness of referral stabilization and timeliness of referral as a predictor of adverse event among critically ill adult non-trauma patients referred to the emergency medicine department of Mwembili National Hospital. Specifically, we wanted to describe the clinical profile of critically ill non-trauma adult patients referred to Mwembili National Hospital to determine the appropriateness of peripheral stabilization among patients referred to Mwembili National Hospital, to determine the timeliness of referral of non-trauma critically ill adult patients referred to Mwembili National Hospital, and to evaluate the predictors of adverse events among critically ill non-trauma adult patients referred to Mwembili National Hospital. So we designed an observational prospective study to be done at the emergency medicine department of Mwembili National Hospital in the period from December 2021 to June 2022. A consecutive sampling technique was used. We enrolled the patients based on new score to score of 5 or more, and a structured questionnaire adopted from the Advanced Cardiac Life Support Manual and the Standard Guideline of Tanzania 2021 edition was used to assess the peripheral stabilization done by the referring centers on compromised airway, breathing, circulation, and disability. Timeliness was calculated as the time from the decision to refer the patient, which was marked by the time the phone call, notification phone call was made to Mwembili National Hospital to the time the patient arrived at the emergency medicine department. During the study period, we managed to receive 1,223 medical patients as a referral, and among them, 430 met the inclusion criteria but we excluded 79 of them because some were missing important referral notes and some refused to participate into the study. We managed to enroll 351 patients, equivalent to 28.7% of the patients we received during the study period. Our patients had compromised on the airway, breathing, circulation, and disability, and our patients had more than one system compromised. Descriptively, majority of patients were male with the median age 52 years, and majority were coming from the regional referral hospitals of Dar es Salaam, and this can be explained by our Tanzania referral system. And the commonest chief complaint was altered mental status. We speculated probably because of the severity of illness, and the commonest comorbidity was hypertension. We used the checklist to assess the very basic interventions that could be done at the referring center on the airway, breathing, circulation, and disability. And among those who had airway compromise, one of the cause of compromise was secretions. And we found that and these patients, they only needed suction, but 86.5% of them who had secretions, suction was not done. And on the breathing, there are patients who were hypoxic and they needed just oxygen, but 53.6% of them did not receive oxygen. And on the circulation, patients were hypotensive and they only needed intravenous fluid or inotropes depending on the pathology, but we found 60% of them, there was no intervention that was done. And the last but not the least, those who were hypoglycemic and they needed intravenous glucose, only 16.7% had received intravenous dextrose from the referring center. We went further to look on the association between these predictors and the adverse events, and we found that the timeliness, the time, those who arrived in more than 4 hours since the call was made was associated with occurrence of adverse events, and those who had unstabilized breathing and circulation as well was associated with occurrence of adverse event. We went further to do to control for the confounders, and we did multiple logistic regression, and unstabilized breathing was found to be an independent predictor of adverse event. So we concluded that more than 3/4 of our study participants have adverse events, and the time passed from the decision to refer the patient to the time of arrival and appropriateness of peripheral stabilization on the breathing was an independent predictor of adverse event. Therefore, we recommend Muhimbili National Hospital to strengthen the feedback mechanism to the referring centers about the status of the arrived patients, and peripheral stabilization checklist should be adopted by the referring facilities to help assessment of appropriateness of patient stability before departure. And we recommend further studies to be designed on evaluation of transport resources and the personnel involved. I would acknowledge the help and support I got from the heads of department, Dr. Said Kilindimo, Professor Henry Sawe from the MUHAS Emergency Medicine Department, and Dr. Juma Finanga and Dr. Beita Muhanos from Muhimbili National Hospital Emergency Medicine Department, and all the staffs of Emergency Medicine Department. Thank you.
Thank you, Dr. Mboso. We have one more presenter who was supposed to present in the first part, but he was doing his exams and he's in the room. I welcome Dr. Nasib Eid Sadiq. Please come forward.
Morning, everyone. My name is Nasib Eid Sadiq, a student from Muhimbili University of Health and Allied Sciences, pursuing bachelor degree in medical laboratory sciences. So first of all, I'd like to thank the chairperson for her hard work since the beginning of these presentations. And second of all, I would like to invite all the participants to this big event. I hope we are going to learn and we are going to add something on our skills according to our presentations. So I'm hereby, can you all hear me? Yes, I'm hereby presenting my literature review about the burden and complication of sickle cells, especially in pediatrics patient anxiety. I organized my review in different parts. As you have seen, I have introductory parts, aim and objectives, methods, results, burden of the disease, discussion, conclusion, and finally we have some of the recommendations. As an introduction, sickle cell is a combination of disorders, which is mainly characterized by abnormal hemoglobin, which tend to change the biconcave shape of the normal RBC to crescent shape, which associate with different complications when they are transferring oxygen throughout the body. Despite its complications, but it has birth onset as a genetic disease, but according to our systems and according to our context in Tanzania, we have no early newborn screening program, so we tend to diagnose sickle cell at a very late stage, which it was estimated by 6 to 8 months. So we need early management in order to combat the prevalence of the burden of sickle cell, especially in the pediatric population. Despite its severity and its complex complication, but the society is still lagging behind and aware of this complication because of lacking of the basic knowledge. So this literature review is one among the basic or the knowledge base to make the society be aware of how severe the sickle cell is and to take action when the programs, different programs initiated for elimination of sickle cell have been conducted. So more studies are needed to explain about the complications, to explain about different, to explain about the prevalence, the epidemiology of sickle cell in our country in order for the society to participate fully. Aim and objective, as I said, this is the knowledge-based. So the main aim is to explore the burden of sickle cell and its main associated complication, especially pediatric patients, so that we impart knowledge to the society, local community, especially pregnant women and other healthcare workers, in order to increase participation in different sickle cell programs or sickle cell educational programs, which will be initiated or already initiated in our country. Or in short term, we can call it as a sickle cell disease awareness. The methods of my literature review was a systematic approach. I was revised through different online databases, including Inari, Google Scholar, and PubMed, as well as some manual search would have been done. So I decided to include some of the reviews which describe about the sickle cell disease, its complication in pediatric patients, especially under 5 children, and some which were describing about the complications of sickle cell in Tanzania. After that, some of the descriptive or qualitative analysis was done, and a few quantitative was analyzed also. Result, a total of 22 literatures, which is equivalent to 100%, was analyzed through the 2010 year up to 2022. And among them, only 59.1% was describing about the burden of sickle cell in different contexts, including the health systems, the treatment and care, as well as the epidemiology. Among them, 40.9%, which is equivalent to 9 literatures, were describing about different complications in which the newborn are suffering from. So according to the sickle cell program, which is at MUHAS, it was reported that sickle cell, Tanzania has a 3rd birth rate of sickle cell in East Africa. Out of 5 studies, out of 13 studies, 5 studies, which is equivalent to 38%, was describing sickle cell
complication localized in Tanzania, and among the facts that was described is that sickle cell disease account for death, estimated 50 to 90% of death in under 5 children, especially in Africa continent, and in general, 22 studies reveals that severe complications in pediatrics are the major causes of hospitalization as well as mortality in under 5 children. Some of the discussion was done, and it was estimated that sickle cell has been nicknamed as a silent public health problem because it comes, only few tend to note the sickle cell. Only few healthcare workers and local community is inadequate of knowledge of sickle cell. So we can term it as silent public health problems. And according to the study conducted by Professor Julie Magani, WHO itself report that sickle cell is a public health priority. So the society must work up, society must consider this non-communicable disease. It tends to wipe the base of our pyramid. It tends to wipe the mortality of infants, and we ignore them and we consider we focus about the adults only, forgetting the infants have been wiped by non-communicable disease like the sickle cells. So, according to a study conducted by Dr. Sian Ankia in 2015, was the test of the efficiency of a newborn screening program during to the improvement of quality of care in sickle cell. It was stated that when we employ newborn screening program, it will improve our quality of care up to 70%. So we recommend to use this method as a one among the implementation of eliminating sickle cell in our country. Some of the complication which was analyzed in my literature review is silent cerebral infarct, but the most common complication and frequent complication is pain crisis among these children, which account about 60% of children suffering from sickle cell disease, and followed by acute chest syndrome, which is the frequent and a killer about first year of age to third year of age in pediatrics. And some of them, they tend to manifest neurological problems, kidney dysfunction, as well as vaso-occlusive crisis. The short summary of the burden of the disease: Africa, 50% to 90% of children are expected to die with sickle cell before 5 years of age. And it is estimated in Tanzania, we have approximately 10,000 of children suffering from sickle cell, which make us at the 5th position globally. So the situation is critical. And when we are going to the death contribution of sickle cell contributes about 7% of childhood mortality, which is equivalent to 10,700 children are dying per year. And when we are talking about mortality, even 0.1%, it really matters. It can wipe a lot of children, and over 300,000 children are born with sickle cell disease, which is approximately 75%. And if our system remains the same, our mode of care remains the same, it is estimated to increase up to 80%, which is equivalent to 400,000 up to 2050. In conclusion, sickle cell disease is the life-threatening. Sickle cell disease, it tends to wipe the infant at a very fast rate. And the manifestation, if we have no any screening program during the birth of a child, we're going to always diagnose the sickle cell at a later stage when some of the manifestation and complication already start or already begin. So local community knowledge is highly recommended. We can't implement anything about sickle cell disease if the communities are aware of what is the sickle cell, what is the severity, what is its complication. So policy management, policy implementation in terms of government, we can employ or we can insert the system of newborn screening throughout our country, and strategy of continuous education in sub-Saharan Africa are suffering from consistent knowledge. We must employ the consistent education and enhance sickle cell as a public health problem, and as well as lifelong management is highly needed for the patient with sickle cell. And In terms of scientists, we have to conduct studies more about molecular aspect of sickle cell. As a genetic disease, we can tend to cure or reduce its severity by the method like gene editing. We can design or we can think about something for editing the defective gene of sickle cell so that we can replace it with the normal gene to reduce the complications as well as the severity of the disease. My references are all stated in the study by Siana Nkia.
Thank you, thank you.
And thank you, the audience.
Now it's time for questions. May I invite all the presenters to come forward? I think we are missing one chair. We have 6 presenters. So the 6th one may sit there. Okay, welcome audience for questions. I know you have questions. I can see Professor Mbogi is raising up his hand.
First of all, I congratulate the presenters. I comment for their presentation, which were excellent. But my first question goes to antimony. You said the comorbidities increased by 18 polypharmacy. What is 18? I didn't get you 18 polypharmacy. But the next question to Wilson, in your exclusion criteria, you ruled out the 6 milligram concentration of 6 milligram HB. Why? But the other question for Nasib, after your good presentation, you in your analysis you got 59.1%, and you termed it only. What were your expectations? You wanted 100%? Then to all, I think because of time limit, this is a comment to all. Because of time limit, I think when you are presenting, don't base much on the background, like sickle cell is a disease, that is known. So go straight to what is key issue, then you will save time and you will not rush at the end. Thank you. Okay, thank you for the presenters for all those comprehensive findings. I have a question to 3 presenters, actually. The first question goes to Dr. Alice Kwambegu. You say that in defining the criteria for stress-induced hyperglycemia, one of the criteria is you were looking for fasting glucose and the time duration of 24 hours, if I got right. I was thinking, when you say stress-induced hyperglycemia, these are the patients who are not non-diabetes, but on acute illness, then they develop hyperglycemia. So how did you rule out that, how did you establish that these patients are not diabetes and maybe they're not diagnosed with diabetes prior to admission to ICU? Did you consider doing a glycated HB maybe? Yes. Next question is to Nasib Idi Sadiq. I can see we have 2, Nasib Idi Sadiq, but the one who presented on the oxygen saturation for sickle cell diseases in dental. So, in your analysis, one of the variable, you are correlating the peripheral oxygen saturation and oxygen saturation on on the teeth. But then when you are giving the results, you just correlated the two groups, the one that they were not having sickle cell pathologies and those who had, I think, sickle cell trait. So I didn't hear the correlation, the Spearman correlation, and how significant was it for peripheral oxygen saturation vis-a-vis the one on the teeth. What was the correlation value and how significant was it? And the next question goes to Nasib Idi Sadiq again, the one that has just immediately presented on the burden and the complications. You conducted a systematic review and meta-analysis. In your analysis, I didn't hear which guideline or modality did you use to conduct this meta-analysis. Did you use a Prisma, or which criteria did you use to select the papers? Thank you.
So thank you. My question goes to Everest, I think. So you were studying pulse oximetry in patients with sickle cell anemia and the other group who had traits. So we know the normal pulse oximeters follow the oxygen dissociation curve of normal individuals. So it's not a good, in patients with sickle cell, the curve is actually shifted to the right. So a patient with sickle cell would come with a lower pulse oximetry value, but then the oxygen partial pressure is normal. So we don't usually, it's not recommended to use pulse oximetry as a basis of measuring the actual partial oxygen partial pressure in the circulation, because they don't usually correlate because of these differences. So on your objective, you're actually trying to screen and monitor treatment. So how did you factor these two things? Because we don't usually rely on pulse oximetry, especially for patients who have sickle cell disease.
I also have a question. One goes to Leonard also. Out of more than 1,000 patients whom you were referred, you only picked 430 and you said the rest did not meet the inclusion criteria. I think I missed the inclusion criteria, because to start with, you said you were taking in all patients who were referred in critically ill condition and were non-trauma patients. So what were these criteria which left so many patients back? To Nasib Said, maybe this is not a question, but rather a comment. When you reported about the sickle cell disease from your literature review, you say that sickle cell disease is a great cause of under 5 deaths in Tanzania. First, I'm worried about it. I'm not sure if you really mean it, that if you take all under 5s in Tanzania, sickle cell disease is a great. First, what does great mean in this scenario? Is it the most common cause, or it is among the most common, and what is its rank in Tanzania? And is it in all under 5s in Tanzania, or is it in under 5s with sickle cell disease? So that was not clear. Okay, that's all.
Thank you, Madam Chair. I have also two questions to different two presenters. The first question goes to Diane. You explained that the commonest mild toxicity that you found was anemia, and you pointed out that different from other studies in industrial countries where they found neutropenia. So my question is, can you speculate what was the reason for this difference? Yes, another one is a comment to Sadiq, who talked about sickle cell. And maybe let me make it a question. Would you now recommend like parental screening as a strategy to reduce sickle cell rather than newborn screening? Yes, can you comment on that?
Thank you. Now I welcome the presenters to respond to the questions.
Thank you, Professor Mbugi, for the question. I said that table displayed an adjusted prevalence ratio, and those patients with HIV who had comorbidities, they had 18-fold increased chance of having being on polypharmacy. So if you take if we take those patients who are having more than one having comorbidities out of HIV, they have an 18 increased fold of having HIV, because that was a adjusted prevalence ratio. Thank you. Yeah, of having polypharmacy, sorry.
Thank you, my professor and my teacher, Professor Mbugi, for a nice question. 59.1% when I said only. First of all, I did not need 100%, but as in an interpretation, out of 100%, only 59.1% was attributed to burden of sickle cell in terms of epidemiology, health care, and health systems. No, no, it's according to my literatures, 22 literatures, it's high. According to my 22 literatures, I don't know about when someone will conduct above 22 literatures, but according to my 22 literatures,
so the best figure
say 59.1%. Yes. Thank you for your comment. And about a systematic review and meta-analysis, in my approach of reviewing these literatures, I used a systematic method, and because of the 22 literature which I have been using, I didn't conduct a meta-analysis. Thus I stated that quantitative, qualitative, and sum of quantitative analysis was done. That sum of quantitative is a statement for excluding a full meta-analysis or a meta-analysis in my review. So I would like to, when I'm continuing conducting this literature reviews, I would like to employ a next review a meta-analysis for the correct description of my data. About how the great cause of death in under 5 children. So, according to my literature review, sickle cell disease was attributed to 7% of all mortality of NCDs, first, NCDs, non-communicable diseases, and in under 5 children, which are suffering from sickle cells, not all under 5 children. If you have no sickle cell, you are not in the risk of dying because of sickle cell, because it's a genetic problem. It's formed during the formation of embryo in the pregnancy stages. So it's among sickle cell children.
So you wrongly presented. We confused.
Yes, thank you for your comment. And about parental screening. Yes, it's among of the recommendations. And I was, when I was analyzing the reviews, I saw it, the parental screening, but the response of parental screening. First, the society doesn't know about the complications, the severity of sickle cell. So if we recommend first the parental screening, you will not get them. And according to our situation now, that we have already high number of sickle cell children. So we must first screen the present sickle cell, or screen the present couples now, or the present pregnancies, and at the same time to educate people on how parental screening will prevent these risks of sickle cell. In short, I can recommend both of them to be conducted because the severity is high, at the same time the society need to be educated. Thank you for your question.
Thank you, Dr. Victor, for the question. Before I answer the question on how I established the diagnosis and excluded the patient with diabetes, just a point of correction. Stress-induced hyperglycemia, according to the literature, is regarded up to within 48 hours of admission and not 24. And this is what I reported. So back to the question, how did I establish the diagnosis of diabetes? So first, at the point of admission to the ICU, these patients were checked if they have ever had the diagnosis of diabetes established in their lifetime, whether they are taking anti-diabetic medication from the history, or if they are known to have diabetes, if they really knew by themselves. That was number one, so from the history. But another thing, at the point of admission, we took samples for glycated hemoglobin to check for undiagnosed state of diabetes in these patients. And if these patients were found to have elevated level of glycemia, of HbA1c, these were excluded. And also at the point of admission, we checked it for a point of care, a random blood glucose. And if it was more than the values, the range value for the diabetes, this was again excluded. That is more than 11.1 millimole per liter. And we now started following up those who were confirmed to have no diabetes from the history, but also from the laboratory parameters that we tested them and found them to be negative for diabetes. And if a patient had also admission due to any hyperglycemic complications such as diabetic ketoacidosis and HHS, they were excluded. So they were purely those who were not known to have diabetes or diabetes-related complications, whom we started following them up during the time of our admission for up to 30 days. And when they developed stress hyperglycemia, then we followed them up for the outcome in terms of mortality and the duration of stay in the ICU. Thank you.
Thank you for your questions. It was about why in our population we found that anemia was predominant than neutropenia, which was found in industrial countries. And to be honest, I thought of maybe it was because in those industrial countries, they tend to use maybe more hematopoietic growth factors to their patient. Maybe they respond or they prevent them from getting anemia, which is a common presentation actually to those patients who undergo chemotherapy. I also can say maybe it's also due to, it can also be accounted to the variation of how the dosage of the treatment of the chemotherapy that is administered to the patient, or can also be also the modality they use to administer the chemotherapy. They can give infusion or bolus. It can also contribute to that. However, as I said also genetic variation can also contribute to how different population can also respond to treatment, to different treatment differently. So I think those all factors can contribute to have different findings in our population. Yes. Yes.
Yeah, so thank you very much, Professor Mbugi, for your question. You asked why did we use 6 gram per deciliter, below 6 gram per deciliter HB level as exclusion. Because this was a comparative study of 3 groups. Most of patients with sickle cell disease tend to have HB even less than 6. And we wanted to get a clear match between the groups so that it doesn't influence too much of our results. Yeah. Then I didn't hear a mention of a name, but there was a question on correlation of the general body of blood flow and teeth. So generally we had a weak correlation, like 0.8, which between teeth and general blood flow, so general body oxygen. And that is explainable because the teeth are sort of different. So it's the body, but structurally they're different. So, and this is also agreeing with other studies which are done on patients, but mostly in normal individual, those who have HbAA, correlating teeth, blood flow, and general body blood flow. Then Dr. Moala asked about how reliable is the tool oxygen saturation in sickle cell. The fact that we got oxygen saturation on fingers using the same tool in the normal range of other tools that we use in the clinic, like we have seen on fingers 97 from the fingers regardless of sickle cell status, but then a little bit lower from teeth. That may tell us if someone has sickle cell and is reading 97 from the finger, but 88 from the teeth, then it can tell us that the instrument may be used because it's taking normal range as with other tools, but just different from teeth may be explained by the 2 things that I've said, that the teeth are mineralized, but also they lack collateral blood flow. But again, our recommendation is to do further studies to benchmark our findings. So we are open to further studying to see how reliable is our findings. Thank you.
The correlation still is not clear because if you say 0.8, it is Spearman rate or Pearson correlation. The rate of 0.3 is positive. That is the rate. But if you score 0.8, that is almost approximate 1. That is a strong correlation. I don't know how does your scatter plot show, but that's a strong correlation. So it's not good.
Thank you.
Unless you are just looking at the value, but if you are looking at the Spearman rate correlation, 0.8, that's a strong correlation.
Okay. Thank you for that. I think I will have to, I didn't include the graphs because of time. So maybe you can read it from my publication because soon it's going to be published and the graph is also there. So I'll take my time and go through it again. Thank you.
Okay, thank you. I think you have asked all the questions you had. And you haven't answered yet? Oh, go ahead, Imbroso. Sorry.
Thank you, Chairperson. It's true that during the study period, we received 1,230 patients, medical patients, and only 430 met the inclusion criteria. The study was on the referred patients, so they should come with an ambulance as an inclusion criteria with an escorting medical personnel, so that we will be sure that the personnel knows if the patient is deteriorating, what to do, and knows that stabilization is an ongoing process. As well, the call has to be made before the patient was brought to Muhimbili National Hospital so that we can mark the time. And the patients had to score. We used a clinical decision tool, then used to score. That is used to classify the severity of illness in the emergency department and in the ICU. So the patients had to score 5 points or more to be included.
Thank you very much. Okay, so I would like to thank all the presenters and let us give them a hand of applause. If you look at all of them, there is one who is an outlier, if you have noted. They are all master's students except one. So I would want another round of applause for him. No one else but Nasib Eid Sadiq. Congratulations, and we encourage you to keep it up. Asante sana.
Haya, hongera. Iko YouTube, itakuwa YouTube. Iko live.
had the opportunity of staging annual scientific conferences. For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared to many stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS scientific conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, and the solutions that we think should be pursued in order to address them. The policy makers, for example, have been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
My focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, and on the treatment strategies. So by doing so, we've been conducting a number of studies which are informing the National Malaria Control Program and the Ministry of Health of the best treatment options and also the best diagnostic options which can be used in the country. Over time, at our department, we have developed collaboration with the other research institutions, but we also have strengthened our working relations with our local institutions. So throughout this period of 10 years, we have been able to contribute in teaching at MUHAS, but we have also developed research infrastructure. We have been able to provide the opportunity for students also to learn on molecular techniques.
For the past 10 years or so, it has been a great opportunity and a transformative time. We have shifted the paradigm to make other colleagues understand that it is not only the quantitative that matter, but also the voice of the people, which is important. So in the other way, we are telling the policymakers, you don't need to change the regime because scientific results have shown no additional benefit in changing the regime. Weak capacity of the health system management as a function of governance contributed to most of the challenges we had. So in that matter, when you strengthen the governance component, we are empowering decision making in the health system. We have a specific master's program, which is a day program, Master of Arts in Health Policy Management, which has trained many people in this country. It is the only Master of Arts in Health Policy Management of this university. But again, perhaps the more specialized in this country when it comes to issues related to health. If you conduct research and it is not disseminated in a proper way to the people who make policy decisions, is as good as if the research was not conducted. Our department has been working collaboratively with the Directorate of Continuing Education and Professional Development of this university, where our role is to translate the difficult scientific language into a popular science and write policy briefs and make them available to the policymakers. You may have heard about this sickle cell disease. One of the policy briefs that has been written was in making the hydroxyurea. Although it is classified as a cancer drug, sickle cell is not cancer. And this medicine can properly work to relieve some of the complications that are related to sickle cell. If we make it available only cheaper to our population, we will relieve the complications and will help our people. So the National Health Insurance Fund included it in their package. It was not there before.
The scientific conference is one of the important platforms for undergraduate students because it gives us an opportunity to collaborate between students from different faculties. For example, as we studied Saratani AI, it was difficult for me as an environmental student to make it by myself, but we collaborated between different faculties, including students from medicine, students from medical laboratory, from nursing, and we come up with Saratani AI.
Saratani AI is the artificial intelligence-based system that uses artificial intelligence to do the cervical cancer screening and diagnosis. The problem of cervical cancer in our country is very huge, and it's due to late diagnosis together with the shortage of pathologists.
So through Saratani AI is going to make cervical cancer screening more accessible because it will not need the presence of specialists. Even a medical doctor can use it in order to have a screening of cervical cancer. So also Saratani AI is more accurate, is an accurate of about 95%, which is higher than a normal pathologist. And also, it has the ability to identify indicative feature for presence of cervical cancer within seconds. So, through Saratani, we expect to have wide accessibility of cervical cancer screening services, and also going to fasten the process of cervical cancer screening. Instead of waiting more than 3 weeks, we can use Saratani AI to make the screening service to be the result to be available even after 3 or 4 days.
The MUHAS Scientific Conference has been a very good platform for our students to engage ourselves in research and innovation activities. And it has been a very good platform for us because we have the chance to showcase our ideas.
It gave us an opportunity to showcase our innovations. And through that, we got a lot of input that enable us to improve our innovations.
We have got a lot of invitation to other big conferences, like we have been to Chair Innovation Awards, and we presented our idea, and we have got the sponsorship, which has helped us to develop our model and to succeed on what we're doing. On 2021, I won an award during the Tanzania ICT conference, the 5th Tanzania ICT conference, and I was awarded as the best innovative student in ICT, and it was awarded because of the innovation Saratani AI.
So the last MUHAS scientific conference helped me to understand the real problems that are facing the community because of the findings that were presented by different researchers and scientists. We are working in the project called Mkanda Salama, and the Mkanda Salama is the project that came immediately after seeing that the major cause of maternal death is PPH, postpartum hemorrhage, that caused about 28% of death of women in Tanzania. So after seeing this problem, we designed an local device called Salama that is wrapped around the stomach of women, and then it can help to reduce bleeding immediately after delivery. So this mechanism of Salama is that is doing aortic compression by compressing the aortic so that reduce the blood flow after delivery, but also is doing the massaging to contract the uterus. So this device was tested at Ifakara Institute, where we found that 80% of women that used Salama were saved, and we will present the results at Tanzania Health Summit, and the results are published at the ENC journal. In May 2022, during the Innovation Conference of Tanzania held in Dodoma, also we emerged as the winner in the best innovation in the level of university. So far now, Salama is at a level where we just want to conduct a large clinical trial across Tanzania so that we can have the findings that will help us to test our product and to make our product be applicable in different healthcare facilities.
So, as we're celebrating the 10 years anniversary of MUHAS Scientific Conference, I am so proud of it. It has helped a lot, especially to us students, and it's a call to other students to engage in research and innovation because the platform is there. It's just a matter of themselves to engage, to go and show their capacities, what they can innovate in solving a lot of problems and issues that face our communities.
For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared to many stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission. For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared to many stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS Scientific Conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, and the solutions that we think should be pursued in order to address them, the policy methods For example, I've been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
My focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, okay, on the treatment strategies. So by doing so, we've been conducting a number of studies which are informing the National Malaria Control Program and the Ministry of Health of the best treatment options and also the best diagnostic options which can be used in the country. Over time, at our department, we've developed collaboration with the other research institutions, but we also have strengthened our working relations with our local institutions. So throughout this period of 10 years, we've been able to contribute in teaching at MUHAS, but we have also developed research infrastructure. We have been able to provide the opportunity for students also to learn on molecular techniques.
For the past 10 years or so, it has been a great opportunity and a transformative time. We have shifted the paradigm to make other colleagues understand that it is not only the quantitative that matters, but also the voice of the people, which is important. So in the other way, we are telling the policymakers, you don't need to change the regime because scientific results have shown no additional benefits in changing the regime. Weak capacity of the health system management as a function of government contributed to most of the challenges we had. So in that matter, when you strengthen the governance component, you are empowering decision-making in the health system. We have a specific master's program, which is a day program, Master of Arts in Health Policy Management, which has trained many people in this country. It is the only Master of Arts in Health Policy Management of this university, but again, perhaps the most specialized in this country when it comes to issues related to health. If you conduct research and it is not disseminated in a proper way to the people who make policy decisions, is as good as if the research was not conducted. Our department has been working collaboratively with the Directorate of Continuing Education and Professional Development of this university, where our role is to translate the difficult scientific language into a popular science and write policy briefs and make them available to the policymakers. You may have heard about this sickle cell disease. One of the policy briefs that has been written was in making the hydroxyurea. Although it is classified as a cancer drug, sickle cell is not cancer. And this medicine can properly work to relieve some of the complications that are related to sickle cell. If we make it available on a cheaper way to our population, we will relieve the complications and we will help them. So the National Health Insurance Fund included it in their package. It was not there before.
The scientific conference is one of the important platforms for undergraduate students because it gives us an opportunity to collaborate between students from different faculties. For example, as we studied Saratani AI, it was difficult for me as an environmental student to make it by myself, but we collaborated between different faculties, including students from medicine, students from medical laboratory, from nursing, and we come up with Saratani AI.
Saratani AI is the artificial intelligence-based system that uses artificial intelligence to do the cervical cancer screening and diagnosis. The problem of cervical cancer in our country is very huge, and it's due to late diagnosis together with the shortage of pathologists.
So through Saratani AI is going to make cervical cancer screening more accessible because it will not need the presence of specialists. Even a medical doctor can use it in order to favor screening of cervical cancer. So also Saratani AI is more accurate, is an accurate of about 95%, which is higher than a normal pathology. And also it is ability to identify indicating clinical presence of cervical cancer within seconds. So through Saratani, we expect to have wide accessibility of cervical cancer screening services, and also going to fasten the process of cervical cancer screening. Instead of waiting more than 3 weeks, we can use Saratani AI to make the screening service to be the result to be available even after 3 or 4 days.
The MUHAS Scientific Conference has been a very good platform for our students to engage ourselves in research and innovation activities. And it has been a very good platform for us because we have the chance to showcase our ideas.
It gave us an opportunity to showcase our innovations. And through that, we got a lot of input that enable us to improve our innovations.
We have got a lot of invitation to other big conferences, like we have been to Chi Innovation Awards, and we presented our idea, and we have got the sponsorship, which has helped us to develop our model and to succeed on what we're doing. On 2021, I won an award during the Tanzania ICT conference, the 5th Tanzania ICT conference, and I was awarded as the best innovative student in ICT, and it was awarded because of the innovations Saratani AI.
So the last MUHAS Scientific Conference helped me to understand the real problems that are facing the community because of the findings that were presented by different researchers and scientists. We are working in the project called Mkanda Salama, and the Mkanda Salama is the project that came immediately after seeing that the major cause of maternal death is PPH, postpartum hemorrhage, that caused about 28% of death of women in Tanzania. So after seeing this problem, we designed a local device called Mkanda Salama that is wrapped around the stomach of women, and then it can help to reduce bleeding immediately after delivery. So this mechanism of Mkanda Salama is doing aortic compression by compressing the aortic so that reduce the blood flow after delivery, but also is doing the massaging to contract the uterus. So this device was tested at Ifakara Institute, where we found that 80% of women that used Mkanda Salama were saved, and we will present the results at Tanzania Health Summit, and the results are published at the EMC Journal. In May 2022, during the Innovation Conference of Tanzania held in Dodoma, also we emerged as the winner in the best innovation in the level of university. So far now, Mkanda Salama is at a level where we just want to conduct a large clinical trial across Tanzania so that we can have the findings that will help us to test our product and make our product be applicable in different healthcare facilities.
So as we're celebrating the 10 years anniversary of MUHAS Scientific Conference, I am so proud of it. It has helped a lot, especially to us students, and it's a call to other students to engage in research and innovation because the platform is there. It's just a matter of themselves to engage, to go and show their capacities, what they can innovate in solving a lot of problems and issues that face our communities.
For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared to many stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS scientific conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, and the solutions that we think should be pursued in order to address them. The policymakers, for example, have been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
My focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, and on the treatment strategies. So by doing so, we've been conducting a number of studies which are informing the National Malaria Control Program and the Ministry of Health of the best treatment options and also the best diagnostic options which can be used in the country. Over time, at our department, we have developed collaboration with the other research institutions, but we also have strengthened our working relations with our local institutions. So throughout this period of 10 years, we've been able to contribute to the teaching at MUHAS, but we have also developed research infrastructure. We have been able to provide the opportunity for students also to learn on molecular techniques.
For the past 10 years or so, it has been a great opportunity and a transformative time. We have shifted the paradigm to make other colleagues understand that it is not only the quantitative that matter, but also the voice of the people, which is the content. So in the other way, we are telling the policymakers, you don't need to change the regime, because scientific results have shown no additional benefit in changing the regime. Weak capacity of the health system management as a function of governance contributed to most of the challenges we had. So in that matter, when you strengthen the governance component, you are empowering decision-making and the health system. We have a specific master's program, which is a day program, Master of Arts in Healthy Policy Management, which has trained many people in this country. It is the only Master of Arts in Health Policy Management of this university, but again, perhaps the more specialized in this country when it comes to issues related to health policy. If you conduct research and it is not disseminated in a proper way to the people who make policy decisions, is as good as if the research was not conducted. Our department has been working collaboratively with the Directorate of Continuing Education and Professional Development of this university, where our role is to translate the difficult scientific language into popular science and write policy briefs and make them available to the policymakers. You may have heard about this sickle cell disease. One of the policy briefs that has been written was in making the hydroxyurea. Although it is classified as a cancer drug, sickle cell is not cancer. And this medicine can properly work to relieve some of the complications that are related to sickle cell. If we make it available only cheaper to our population, we will relieve the complications and we will help our people. So the National Health Insurance Fund included it in their package. It was not there before.
The scientific conference is one of the important platforms for undergraduate students because it gives us an opportunity to collaborate between students from different faculties. For example, as we studied Saratani AI, it was difficult for me as an environmental student to make it by myself, but we collaborated between different faculties, including students from medicine, students from medical laboratory, from nursing, and we come up with Saratani AI.
Saratani AI is the artificial intelligence-based system that uses artificial intelligence to do the cervical cancer screening and diagnosis. The problem of cervical cancer in our country is very huge, and it's due to late diagnosis together with the shortage of pathologists.
So through Saratani AI is going to make cervical cancer screening more accessible because it will not need the presence of specialists. Even a medical doctor can use it in order to give a screening of cervical cancer. So also Saratani AI is more accurate, accurate of about 95%, which is higher than a normal pathologist. And also, it has the ability to identify indicating feature for presence of cervical cancer within seconds. So, through Saratani, we expect to have wide accessibility of cervical cancer screening services, and also going to fasten the process of cervical cancer screening. Instead of waiting more than 3 weeks, we can use Saratani AI to make the screening service to be the result to be available even after 3 or 4 days.
The MUHAS Scientific Conference has been a very good platform for our students to engage ourselves in research and innovation activities. And it has been a very good platform for us because we have the chance to showcase our ideas.
It gave us an opportunity to showcase our innovations. And through that, we got a lot of input that enable us to improve our innovations.
We have got a lot of invitation to other big conferences, like we have been to Chi Innovation Awards, and we presented our idea, and we have got the sponsorship, which has helped us to develop our model and to succeed on what we're doing. On 2021, I won an award during the Tanzania ICT conference, the 5th Tanzania ICT conference, and I was awarded as the best innovative student in ICT, and it was awarded because of the innovation Saratani AI.
So the last MUHAS scientific conference helped me understand the real problems that are facing the community because of the findings that were presented by different researchers and scientists. We are working in the project called Mpanda Salama, and then Mpanda Salama is the project that came immediately after seeing that the major cause of maternal death is PPH, postpartum hemorrhage, that caused about 28% of death of women in Tanzania. So after seeing this problem, we designed a local device called Mpanda Salama that is wrapped around the stomach of women, and then it can help to reduce bleeding immediately after delivery. So this mechanism of Mpanda Salama is that it's doing aortic compression by compressing the aortic so that reduce the blood flow after delivery, but also is doing the massaging to contract the uterus. So this device was tested at Ifakara Institute, where we found that 80% of women that used Mpanda Salama were saved. And we will present the result at Tanzanian Health Summit, and the result are published at the BNC Journal. In May 2022, during the Innovation Conference of Tanzania held in Dodoma, also we emerged as a winner in the best innovation in the level of university. So far now, Dar es Salaam is at level where we just want to conduct a large clinical trial across Tanzania so that we can have the findings that will help us to test our product and make our product be applicable in different healthcare facilities.
So, as we're celebrating the 10 years anniversary of MUHAS Scientific Conference, I am so proud of it. It has helped a lot, especially to us students, and it's a call to other students to engage in research and innovation because the platform is there. It's just a matter of themselves to engage, to go and show their capacities, what they can innovate in solving a lot of problems and issues that face our communities.
For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared to many stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS Scientific Conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, and the solutions that we think should be pursued in order to address them. The policy methods, for example, have been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
My focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, and on the treatment strategies. So by doing so, we've been conducting a number of studies which are informing the National Malaria Control Program, the Ministry of Health, of the best treatment options, and also the best diagnostic options which can be used in the country. Over time, at our department, we've developed collaboration with other research institutions, but we also have strengthened our working relations with our local institutions. So throughout this period of 10 years, we've been able to contribute in teaching at MUHAS, but we have also developed research infrastructure. We've been able to provide the opportunity for students also to learn on molecular techniques.
For the past 10 years or so, it has been a great opportunity and a transformative time. We have shifted the paradigm to make other colleagues understand that it is not only the quantitative that matter, but also the voice of the people, which is important. So in the other way, we are telling the policymakers, you don't need to change the regime because scientific results have shown no additional benefits in changing the regime. Weak capacity of the health system management as a function of governance contributed to most of the challenges we had. So in that matter, when you strengthen the governance component, you are empowering decision-making in the health system. We have a specific master's program, which is a day program, Master of Arts in Health Policy Management, which has trained many people in this country. It is the only Master of Arts in Health Policy Management of this university. But again, perhaps the more specialized in this country when it comes to issues related to health. If you conduct research and it is not disseminated in a proper way to the people who make policy decisions, is as good as if the research was not conducted. Our department has been working collaboratively with the Directorate of Continuing Education and Professional Development of this university, where our role is to translate the difficult scientific learning into popular science and write policy groups and make them available to the policymakers. You may have heard about this sickle cell disease. One of the policy briefs that has been written was in making the hydroxyurea. Although it is classified as a cancer drug, sickle cell is not cancer. And this medicine can properly work to relieve some of the complications that are related to sickle cell. If we make it available only cheaper to our population, we will relieve the complications and we will help them. So the National Health Insurance Fund included it in their package. It was not there before.
The scientific conference is one of the important platforms for undergraduate students because it gives us an opportunity to collaborate between students from different faculties. For example, as we studied Saratani AI, it was difficult for me as an environmental student to make it by myself, but we collaborated between different faculties, including students from medicine, students from medical laboratory, from nursing, and we come up with Saratani AI.
Saratani AI is the artificial intelligence-based system that uses artificial intelligence to do the cervical cancer screening and diagnosis. The problem of cervical cancer in our country is very huge, and it's due to late diagnosis together with the shortage of pathologists.
So through Saratani AI is going to make cervical cancer screening more accessible because it will not need the presence of specialists. Even a medical doctor can use it in order to give a screening of cervical cancer. So also Saratani AI is more accurate, is an accurate about 95%, which is higher than a non-pathologist. And also, it has the ability to identify indicative feature for presence of cervical cancer within seconds. So, through Saratani, we expect to have wide accessibility of cervical cancer screening session, and also going to fasten the process of cervical cancer screening. Instead of waiting more than 3 weeks, we can use Saratani AI to make the screening the result to be available even after 3 or 4 days.
The MUHAS Scientific Conference has been a very good platform for our students to engage ourselves in research and innovation activities. And it has been a very good platform for us because we have the chance to showcase our ideas.
It gave us an opportunity to showcase our innovations. And through that, we got a lot of input that enable us to improve our innovations.
We have got a lot of invitation to other big conferences, like we have been to Chi Innovation Awards, and we presented our idea, and we have got the sponsorship, which has helped us to develop our model and to succeed on what we're doing. On 2021, I won an award during the Tanzania ICT conference, the 5th Tanzania ICT conference, and I was awarded as the best innovative student in ICT, and it was awarded because of the innovation, Saratani AI.
So the last MUHAS scientific conference help me to understand the real problems that are facing the community because of the findings that were presented by different researchers and scientists. We are working in the project called Mkanda Salama, and the Mkanda Salama is the project that came immediately after seeing that the major cause of maternal death is PPH, postpartum hemorrhage, that causes about 28% of death of women in Tanzania. So after seeing this problem, we designed a local device called Mkanda Salama that is wrapped around the stomach of women, and then it can help to reduce bleeding immediately after delivery. So this mechanism of Mkanda Salama is doing aortic compression by compressing the aortic so that.
Good afternoon, ladies and gentlemen. Welcome to the satellite session this afternoon. You will be with me as your moderator, and we'll go through the innovation segment of the 10th Scientific MUHAS Conference. This year we'll be dealing with the theme of exploring the MUHAS innovation ecosystem, the past, the present, and the future. So in this session, we'll discuss what was happening in the past, we'll discuss what's happening now, and what we expect to happen in the future here at MUHAS, of course. Without further ado, I would like to welcome the introductory remarks from one of the students here at MUHAS. She's going to explain to us what the satellite session is all about. She's going to explain to us what we expect to learn in this satellite session and what we'll achieve at the end of the session. Allow me to welcome a student. Her name is Amanda Lema. She's very enthusiastic with innovations. As we know, she's one of the leading winners in one of the categories in this 16th Win and Learn academic event this year, as well as one of the organizing committee members of MUSSD, Muhimbili University Student Symposium for Debate. Ms. Amanda Lema, the stage is yours. Welcome, introduce to us the satellite session.
Good afternoon, ladies and gentlemen. As I have been introduced by Ms. Loss, I am Amanda Jubilant Lema, pursuing Bachelor of Midwifery here at Muhimbili University. I would like to express my heartfelt welcoming tone to all who have attended. We are delighted to have you with us and participate to this satellite session on exploring the MUHAS innovation ecosystem, the past, present, and the future. May I first appreciate and congratulate the organizing committee of the 10th MUHAS Scientific Conference, the organizing committee of this satellite session, the Directorate of Research and Publications under the guidance of Professor Bruno Sunguya, and all of you who generously helped us to make this session successful. Thank you very much. In recent years, Tanzania has witnessed a tremendous change in disease pattern and epidemiology, from predominant communicable diseases to predominant non-communicable diseases. According to WHO estimate, the mortality rate due to non-communicable diseases in Tanzania by the year 2017 accounts for 34% of all deaths in the country, with cardiovascular disease being the leading cause of death among non-communicable diseases, followed by cancers, chronic respiratory diseases, and diabetes. This comes as an addition to the already existing problem of infectious diseases. The changing pattern and trends of health-related challenges require unique and innovative solutions, which can utilize the available technology to come up with evidence-based interventions to address the prevailing challenges in health sector. We believe that through interdisciplinary collaboration among students from different fields such as medicine, biomedical engineering, computer science, and telecommunication engineering, a platform for health innovation will be created and thereby paving a way for development of innovative solutions that are urgently required to address the existing burden of diseases in the country. Ladies and gentlemen, what if we have no innovative minds between us? Innovation in health sector has been expanding the option to solve existing health problems. It promises a new way to prevent, diagnose, and monitor health problems. Increases the knowledge and transforming existing processes and business models to better serve the changing needs and expectations. In the past 10 years, MUHAS student has growing interest in the potential of new technologies and innovation in improving healthcare system. These MUHAS dedicated young innovators have been collaborative, finding new and better solutions to complex challenges, exploring the future with dozen inventions, and running the year startups to extricate the health system from the current situation in a remarkable pace. Our innovation ecosystem is made up of 4 main players: the student-led platforms, that is Muhimbili University Student Symposium for Debates and the Win and Learn academic event; student innovators, the Directorate of Research and Publication, MUHAS, and other external stakeholders. These key players organize the medical hackathon, innovation exhibition, and innovation boot camps, which creates rooms for students to brainstorm and innovate for digital interventions to address the health-related challenges in the country. Today's session will travel through the student innovation achievements, the year stages in innovation pipeline, the year challenges, opportunities in MUHAS innovation ecosystem, and obtaining insights and opinion from the key players of Tanzanian innovation ecosystem on how to design the MUHAS Innovation Hub and Incubation Center that best fits the nature of Muhimbili University. Ladies and gentlemen, we are expecting full participation and engagement in today's session. Welcome all and thank you for attending. Another round of applause, please. So far, we've discovered this satellite session will guide us into discovering more about the innovation ecosystem at Muhimbili University, as well as knowing the tactics on how to reach the milestones you've intended to reach. That will be soon discussed here with us. For the next part, allow me to bring forth a man, a student, of course from here, very enthusiastic with innovation, who wants to develop the innovation ecosystem and has devoted so much of his energy into it. I would like to introduce a person who's very well experienced in leadership. He has done a tremendously great job in leading the 16th Win and Learn academic event that also gave birth to the first innovation ecosystem. I bring forth David Joseph for the keynote speech. Allow me to present David Joseph. A round of applause, please.
Good afternoon. So I know Ms. Almanda has welcomed you to the session, but may I also take this opportunity to welcome you all in this wonderful satellite session where we are going to explore about our MUHAS innovation ecosystem and what our innovators at MUHAS do, but most importantly, discussing what are their experiences as innovators and to discuss the probable way forward so that we can more facilitate and foster the healthcare innovation, not only at MUHAS, but also in Tanzania. May I also take this opportunity to acknowledge the presence of our panelists Professor Maine Mushi. Thank you so much, Prof, for being with us. Mr. Jumanne Mtambalike, the CEO of Sahara Ventures, we appreciate your presence. And also Mr. Sangudi, who is the operational manager of Saratani AI. We are real humbled for your presence. In the recent years, we have seen a tremendous changes in the pattern of the global health challenges. And Almanda said that currently we have predominantly non-communicable diseases, which also increase the burden, keeping in mind that we also had infectious diseases in place. Now, these global challenges requires more innovative solutions so as we can address them. And that means in our healthcare system, we have to take into consideration the development and deployment of technological and innovative interventions so that we can address the different global challenges that is facing our healthcare industry. But also the development and deployment of these technological interventions and innovations requires very unique approach. And this includes the engagement and participation of young health professionals who are going to be the health practitioners, the policymakers, but also global health leaders in the future healthcare system. But the challenge with healthcare system is that the health sector is, in terms of adaptability, acceptability, and flexibility of the sector to adapt and use technological interventions, it's still challenging because of the the policy and regulations and other kind of challenges that is facing the sector. But we cannot deny the role of technology and innovation in transforming the health sector system, especially in developing countries where the adaptability and utilization of technological interventions is still very low. Now, after this realization, in the past 10 years, the MUHAS innovation ecosystem has been developing gradually, and then we have seen a tremendous engagement and participation and actively innovations by students from MUHAS in collaboration with other students who are studying computer science in other universities. Now, the MUHAS innovation ecosystem can be dated back in 2016 when we hold the MUHAS, the Mawazo Challenge. And I'm very glad Mr. Jumanne Mtambalike is here. This was launched by the then HDIF. It was aimed at stimulating ideas, inspire new innovators, and increase support to potential entrepreneurs. And it was co-organized by Tanzania Bora Initiative, Sahara Sparks, and Tanzania Medical Students Association. Now, among the top 10 winners in the Mawazo Challenge of 2016, 3 teams were formed by students from MUHAS. And it is very fortunate that all of these 3 teams are now disrupting the market in the healthcare system. Their products are being utilized by customers. These include FarmLinks, Jamii Medical Awareness, and Afya2. Now, after the results and the outcomes of the Mawazo Challenge of 2016, then we see a surge of innovators as well as startup founders that are found at MUHAS. Now, currently we have 4 main players in MUHAS innovation ecosystem. These include students innovators themselves, the external stakeholders, students initiatives, as well as the MUHAS Directorate of Research and Publications. Now, for the case of students initiatives, we have Muhimbili University Students Symposium for Debate. This is a multi-section debate symposium, which is aimed at increasing the awareness and engagement of youth health professionals on the deployment of emerging technologies in the health sector. Now, these initiatives conduct annual symposiums on emerging technologies It conducted a symposium on artificial intelligence in 2019, a symposium on the deployment of genomics in 2021, as well as a symposium on the deployment of data analytics technologies in 2022. And also it conducts medical hackathons, which create opportunity for medical students to collaborate with other students to develop digital solutions for different health challenges in Tanzania. And it has conducted 2 hackathons, one in 2019 and the other one in 2021. But also we are looking forward to conduct another hackathon this year so as to increase the number of students who are engaging in technology and innovation for health. This was the photo of the organizing committee with the judges of the last year hackathon, which was held at Boone Innovation Hub in Costec. And among the teams that were developed, they are currently under the Directorate of Research and Publication for their nurturing and mentorship. Another student initiative in the MUHAS innovation ecosystem is the Win and Learn academic event, which is an annual knowledge and experience sharing academic competition, primarily aimed at recognizing, valuing, and promoting students' activities in research and innovation. Win and Learn also conducted a medical hackathon in 2019 about the deployment of digital technologies in addressing non-communicable diseases in Tanzania. But also it conducted the first innovation exhibition at MUHAS, in which 8 health-based startups from MUHAS and outside MUHAS got a chance to display their activities. This was the photo that was taken during the first innovation exhibition, which was held on the 25th of June, 2022 at MUHAS. Another key player of MUHAS innovation ecosystem is the Directorate of Research and Publications under the supervision of Professor Bruno Sunguya. The Directorate has been closely collaborating with the students' initiatives to facilitate students' engagement and participation in technology and innovation. But also it has been connecting young innovators to mentorship, partnership, and funding opportunities through local and national platforms. But also the Directorate conducted the first innovation bootcamp in June 2022, which increased the number of students-based innovations within the ecosystem. But also we have external stakeholders like Sahara Ventures, Boone Innovation Hub, Costec, Adanian Hubs, and Tanzania Diabetes Association. These have been providing financial and moral support to support these students' initiatives. And the most important key player of MUHAS innovation ecosystem are the innovators themselves. These are students at MUHAS who are engaging in different technological interventions to address the different challenges that is facing the healthcare system. Currently, we have over 20 startups at different stages of innovation life cycle, and 3 startups have already exited to the market, the likes of Families, Yami Medical Awareness, as well as Afyatun. And 4 startups are currently at the initial market testing. And we expect that very soon they will also go to the market. Now, most of these startups and innovations are focused on antimicrobial resistance, sexual and reproductive health, pharmaceutical supply chain, non-communicable diseases, artificial intelligence, data analytics, maternal and child health, as well as mental health. But the development and the scaling of these startups is faced by a number of challenges that the innovators are experiencing. The experience is not easy, keeping in mind that they are students, they have academic schedules to attend, and yet they have their startups to take care of. So it's very challenging, but still very encouraging to see, despite the challenges that they face, they are still courageous enough to keep on developing digital interventions to address the different challenges in the healthcare system. Some of the challenges are the technical skills, the know-how, and exposure. Because most of our innovators at MUHAS are developing around technological interventions which require some expertise either in AI, machine learning, or computer programming. And most of these skills are not provided in medical curriculum or in their curriculum. So it's very difficult for them to develop the interventions, and that means either they have to collaborate with other students who have the skills and knowledge, or to hire or to outsource the skills from outside of their teams. But also we don't have a common platform for young innovators at MUHAS. If someone at somewhere comes at MUHAS and then wants to meet the innovators all at once in a common place, we have no such a place. So we still need a common platform to collaborate with all the innovators so that to make their journey very smooth in innovating for health. But also at MUHAS, we don't have a physical space for innovators, and that's why most of our hackathons are done outside, either at Good Innovation Hub, COSTECH, and other places, because we don't have a physical space for innovators to meet and develop their ideas. We don't have a clear financial model to support the already established startups at MUHAS, but also most of the teams and startups lack the go-to-market strategies so that they can commercialize their business ideas. We have also barriers to regulatory authorities such as TMDA, but also keeping in mind their students, the challenging of tight academic schedule also slow down their activities. Despite the challenges, in my personal opinion, there are a lot of things that we can intervene to ensure that we create a sustainability and scalability of these young innovators, not only at MUHAS, but also any other innovators, as long as they're innovating in healthcare system. We may probably need a MUHAS Innovation Hub or a medical innovation hub in which students will meet, collaborate, and then we can provide the technical know-how, the exposure, mentorship, as well as intellectual property rights to enable these innovators to make their things happen and into practice. But this MUHAS Innovation Hub can be in a collaboration with innovators under the Directorate of Research and Publication. Now, having a MUHAS Innovation Hub will increase students' engagement, will provide the space for innovators to do their activities smoothly. But also from the hub, we can develop Innovation Week as well as MUHAS Innovation Database so that we can have a common platform for all innovators at MUHAS. And then within the hub, we can have external stakeholders such as funders, investors, and other partners can provide resources to the hub, but also they can be connected to the MUHAS Innovation Week and MUHAS Innovation Database so as they can have access to young innovators, and these young innovators can have access to external opportunities. Now within the hub, we can also channel financing mechanisms from funders or from investors, as well as we can provide policy and regulatory measures to innovators before they come out with their innovations to be incubated at Incubation Center. Now within the Incubation Center, we can have a go-to-market products and then providing go-to-market strategies to these innovators so that they can go to the market. So this is a simplified model of how we can address the different challenges that is facing the MUHAS innovation ecosystem and to increase the visibility and scalability as well as the sustainability of our young innovators and startup founders. Now, after this initiative, what do we expect? We expect it to have a sustainable innovation ecosystem, and that's what we are struggling for, to create an innovation ecosystem which is very sustainable in terms of financing, very sustainable in terms of acceptability, adaptability, and flexibility, very sustainable in terms of scalability, but also very sustainable in terms of practicability and exposure of our young innovators to the outside world. Addressing these challenges requires multi-sectoral engagement and multi-stakeholders engagement. And this can be done by collaborating with other already existing innovation hubs or already existing accelerator programs and already existing incubation centers. Building sustainability, it's not an overnight event. It requires a process, and the process requires a lot of stakeholders and a lot of measures to be done so that we can move forward in creating sustainable and conducive environment for our innovators to innovate for health. I believe in some years, say 5, 10, or even 15 years to come, we will be talking about other success stories of young innovators. And I think these success stories should be created from now by creating a very sustainable environment for our innovators to scale and to get the exposure that is required and to get the necessary skills, leadership, and policy and regulation measures so that they can move smooth in their journey. Thank you so much for listening. Again, I welcome you to the satellite session.
Thank you so much, Dr. David Joseph. Another clap for Dr. Davis, please. With that keynote address, I hope we've already begun to see the vision we're heading to for the satellite session now. Without further ado, I would like to welcome a presentation that is to tell us more of the innovation ecosystem. Here we have a person whose expertise is basically ideation, project management, as well as development of the projects. Here I'll welcome Mr. Jumanne Mtambalike, the CEO of Sahara Ventures himself. Welcome.
Where is mchana? Natumiaje? Au tubonyeze tu. Habari za mchana jamani. Wema. Profesa, madaktari, itifaki imezingatiwa. Sawa, sasa inaonekana Dr. Davis ameshazungumza kila kitu cha innovation. Mimi sina cha kuzungumza. So basically I'll just try to share to leave you with more questions so that you can discuss better in the afternoon. So my name is Jumanne Mtambalike. I'm the CEO and co-founder of Sahara Ventures. Our company mission is to build the innovation and technology entrepreneurship ecosystem in Tanzania. We work with different partners in the ecosystem. We work with private sector, we work with academic institutions, we work with research agencies, we work with the government. And we believe innovation and technology can be adapted as a tool to accelerate socioeconomic development, because you'll be able to address and solve some of the most complex issues facing our society today. One of them is this. So I'm a football fan. So kama unaangalia ligi kuu ya Vodacom, unaweza kujua ni mechi ya Azam kwa sababu ndo na jezi za blue, au sio? Yeah. But this was in 2013. This was in 2013. And this was an interview. This was an interview. Sasa sijui ndo long list au short list, sina makini. Lakini but if it was an interview na wameitwa manake ni short list. Sasa long list ingejaza mwanja mzima. Unaona? My point is we are facing a lot of complex challenges in our societies today. And our education system has been designed to create consumers of solutions instead of creators of solutions. And that's why everyone is complaining. The students are complaining, the management is complaining, the government is complaining, the private sector is complaining, and then we're all not offering solutions. So how do we transform our young people, especially our young generation, to be able and to be in a position where they become solution creators and not just consumers of solutions from abroad and other places? I think it's very, very important. And the initial assumption is that solution creators come from, the background has to be original in engineering, they should be computer scientists or technologists, but solution creators can come from many disciplines. These are the people who actually see the problem, decide to act, and also decide to act a bit differently. These are the people who actually ask themselves questions like, what if I do this thing in a different way? And they also ask themselves, what wows? If I decide to do it, what is the uniqueness I'll add into the solution that I'm creating? And then what works? What I'm designing, does it actually fit the purpose and solve the problem? The small gadget here looks very beautiful, but it's very complex to understand even how to press forward. So from a design perspective, this is a mess. Yeah? This is a mess, because you can have a very good user interface, but you can have very bad user experience. And that is the status of our health sector. So the experience we are having, we're not coming from heaven, we're living here. Tunapata matatizo, kuna siku ndugu yako anapata ajali, unaenda hospitali, unakaa mpaka usiku wa manane, unahangaika naye. Kwa hiyo you can feel the process of our health system. From the moment you reach to the hospital, unajua kabisa hapa ili mambo yaende lazima niende timu ya CRDB. Unaona, I also need to check kwenye database yangu nani namfahamu, nilisoma naye wapi, ili anisaidie mgonjwa atoke emergency. Amishwe chumbani sasa. So how do we fix those problems? It's very, very important. And those problems are not fixed by engineers. Those problems are fixed by people operating in the health sector. Very unfortunate, I'm not from the health sector. So I cannot fix those problems. So basically the world is also changing, and it's changing really fast. You cannot continue to say, I'm a doctor, I don't need to understand anything else. I was raised a doctor, I was raised a pharmacist, my sector is health. It doesn't work like that anymore. Most of the jobs that we know, they are going to be lost and new jobs are going to be created. Unaona? Yeah, so likely ukiwauliza hapa wazee wetu, unaona kuna watu wazima kabisa. Ukiwauliza watakwambia there's no way kipindi chao kimaliza chuo wewe daktari afu daktari una kazi. Yaani it's very weird. Unaona? Lakini siku hizi tuko na washikaji wengi tu. Yeah. Unaona? Ni madaktari lakini hawana issue, wanaendesha Uber. Unaona? Sio kwamba any issue kuendesha Uber. Unaona? Yeah, wapo washikaji wengi tunaendesha Uber. Unaona? Lakini my point is the world is changing, and it's changing really fast. And for a country like Tanzania, the problem is also even more sensitive. We need to pay more attention. The median age of Tanzania is 17.9 years old. More 15 of the fastest growing cities in the world are in Africa. 3 of them are in Tanzania. Who can guess what are those 3 cities? I have a gift if you get it right. Yes, I'll start with you.
I'm trying. I guess Dar es Salaam, Mbeya, and Arusha.
Okay, so it's Dar es Salaam, Mwanza, and Songea. I don't know why Songea. So the point is, and that's not me, it's World Economic Forum, by the way. It's an article, just write 15 fastest growing cities in the world. And then you say it by projections. By, I think, 2100 years, Dar es Salaam will be the 2nd largest city in the world if we continue with the same pace. Yeah, yeah, because those are facts. You can just Google them. You don't need to ask me. Professor Google is smarter than everyone, so you can just check. And the issue is, because of these changes, even the center of knowledge is changing. The other week I saw a person tweeting like the last time he stopped Googling about his health is when he realized he had some kind of cancer that cannot be treated on the back of his head. Because they used to do like their own remote diagnosis. So they get into Google and then ask, I have this pain in my chest, what does this mean? And then, and then the response was not so good. And then he said, okay, I'm stopping this thing. I'm not gonna do it anymore. So the point is, even there are new diseases that are coming up because of these changes that are happening. Some people are suffering from social media disorder. Some have some problem like TikTok syndrome. These are diseases which might not have been there, but they are coming because the world is changing. I did a thread on Twitter on new types of diseases that are coming because of digital transformation. And initially I thought it was a joke until I came to realize it was actual science fact and it was researched. Kuna watu wanaumwa ugonjwa ule hata kama apigiwi simu anahisi kama simu inaita hivi. Kumbe ni ugonjwa bwana. Unakosi umeharibu ubongo wako umefanya nini? Umeona wana? Yeah, so I'm telling you, I'm not from the health sector and your terminologies can be complicated. But the point is, the world is changing and it's changing really fast. So we as Sahara Ventures, we believe by supporting innovation, technology, and entrepreneurship, we can actually create a generation of Tanzania that is ready for these changes. Because you cannot fight against these changes. By 2030, Dar es Salaam will attain what we call a mega city status. We'll have more than 13 million people living in Dar es Salaam. And then if you look at the paper, which was published by Gemma Todd, I think when she was still, when they were still working with Ifakara, questioning the urban advantage. It's a very interesting paper. You can Google that and read it. So we think the health condition in urban areas is actually good, but actually according to our indicators, even worse. And I totally agree with that. Because ni wote ni tunaenda hizo hospitali za serikali, kwa hiyo tunazifahamu vizuri tu. Umeona? Kwa hiyo how are we going to create solutions that make our health sector actually user-friendly from the interface as well as the experience? What you're getting, what you're being served, the support you receive is very, very crucial, and no one can actually solve those problems for us. These are problems we need to solve ourselves. So as you also know, we are living in the fourth industrial revolution. So every sector is getting disrupted. There's a very interesting book, it's called Life 3.0. So they talk about all this digital transformation and what will be happening in the health sector. Last time I checked, they were trying to do head transplant. I don't know if they've been able to do it. Kwa hiyo, ukiwa unakaribia kufa ubongo lakini mwili wako uko vizuri, na mwingine mwili una shida lakini ubongo uko sawa, naamua tu nani abakie tu tena. Yeah, so these things are already happening. You can just Google head transplant. You see, sasa hivi they are also working on creating watoto nje ya matumbo ya binadamu. Unaona? Yeah, kwa hiyo wanaita external nini, jina limetoka, can Google it, but it's very funny actually. So basically kama ni superstar na hutaki kupoteza mwili wako, sijui bado wanataka endelee kuwa kama Jennifer Lopez at your 70s, no problem. They can just grow your kid in some pig or something outside. And then, mtoto akakuzwa huko. Sasa kuna question of faith, of course. I'm a Muslim. It's a serious concern if I talk about these things in front of my mom. But the point is, that's technology. That's where things are heading. Kwa hiyo watu wanapandikiza miguu ya binadamu, wanafanya 3D printing ya livers and kidneys and stuff like that. So the world is moving really fast. Kwa hiyo hatuwezi kupretend kama tuko kwenye dunia yetu pekee yetu afu kuna kitu kinachoendelea. But what is important is how can we narudi kwa Dr. David, how can we make our academic and research institution ready for what is coming? Because they cannot continue to operate in the similar way they've been operating in the past 2,000 years. Yeah, and it has to change. It has to change. So these guys, they came up with this concept, third generation university, where you have to think beyond just academic and research, and university to become a center of knowledge, and then you move towards thinking on how you are going to incorporate innovation and entrepreneurship on top of academic and research. So beyond just presenting papers and becoming PhD candidates and professors, we move to the next stage. So solution you've come up with, Dr. Musa, how do we transform them into meaningful solutions? Yeah, so Dr. Musa, can you wave? It's a very good friend of mine. Yeah, we started together again to Ilala. Mimi kwa Zania yuko Forozani. Sasa it's good. Kwa asubuhi leo ka present papers. Sasa what next? Nataka cheo tu msisi. The point is, papers and submissions are not just for making you to qualify for the next position at the office. They should be actual solutions that are coming to solve people's problem. And they don't have to be gadgets. They don't have to be products. They can be just framework. Framework tu ambayo inaonyesha kama mtu akifika basi pale emergency asianze tena kumpigia sio na mtafuta Dr. Farida sio nani, bado unajua tulisoma wote, hali ni mbaya hapo, unahitaji kumsaidia mtu tuingie ndani huko. It has to be as smooth process as possible, because that is what education is supposed to do to us. That's why we are coming here. We have to create solutions on problems that are facing us. You see, and don't get confused. Technology is just a tool. Technology is just a tool. It does what you tell it to do. So Jean Romet is a former CEO of IBM. She was asked, because they are doing deep research on artificial intelligence in the health sector, and she was asked, do you think there was going to be a day where a robot is going to replace a human doctor? Do you think? Huh? How many believe that there's a one day that robots are going to replace the human doctors? Yeah, so even the CEO of IBM says, no, I don't think so. So, and that's where the concept of augmented intelligence come in, instead of artificial intelligence. Like, how do you complement human capabilities with computer capabilities? So instead of replacing the doctor, if a doctor is able to do trials, like 20 to 30 trials per day, you complement it with a robot so that he can be able to do 1 million trials per day. So that you're able to accelerate the process of them being able to get results. So the idea of the technology is not to replace the doctors, but to complement them and to give them the superpower so that they can be able to reach and come up to solutions very quick. Instead of kusoma mapicha yale x-ray yale kama 10,000 hivi afu baadaye walikuwa jua kavunjika mara moja kumbe mara tatu bwana, because those are human errors and they tend to come, but machines don't do those mistakes. Lakini bado tunahitaji ile pole utapona binadamu kuengage na wewe, unaona? Yeah. So it's interesting kwa sababu the problem of the world are becoming more complex, which means you need interdisciplinary research. Wewe from the health sector peke yako uweze kusolve hayo matatizo. Lazima ukae na mtu wa computer, lazima ukae na mtu wa engineering, mkae mwanze kufikiria kutengeneza solution. Products za kwenye nanotechnologies, za kwenye nini zote zinakuja. Yeah, talking to Professor Hulda Swai, and she was telling me about nano, whatever. That's a very complex terminology. But ideally kuna vidude wanaviingiza kwenye mwili vinakuwa programmed vinaenda si kufanya vitu gani. Sasa wewe daktari bado kutengeneza remote ya control dawa kwa degree yako ya medicine sio leo. Unaona? Kwa hiyo ni lazima tufikirie how we're going to merge this two sectors. So Dr. David, we don't need to teach doctors how to code. We need to teach doctors how to work with coders. I don't know if you're getting my point. And those are the skills that are missing. So ingenuity, creativity, critical thinking, problem solving, collaboration, hapo ndio Watanzania tuna shida sana. Unaona bwana? Because those is what we call soft skills. But in our society, those are the hardest skills to have. Yani hizi mnazosoma mnapata degrees, hizi are the soft skills. Na utaka kuamini usubiri interview. Ndio utajua which is a soft, which is a hard. Umeona? Yeah, because people cannot explain themselves. They cannot even say what they do. Kimwambia mtu wait, anasema 72 kg. No, I'm just telling you to wait. So, and that has nothing to do with you having a medicine degree. It is just your emotional intelligence and other. So companies like Google, they are pushing this agenda of interdisciplinary research. IBM is also doing that. They're trying to see how the data that you guys are generating from the health sector are being used to solve some of the most discussing problem in the world. So, for example, now they're using their application to check looking for that image. They can actually use the phone to diagnose whether you have phone camera, whether you have diabetes or not. So basically, you don't expect daktari anze kukodi mpaka tengeneze application ambayo inaweza kuassess kama mtu ana diabetes. Sasa si atakuwa shafeli huko. Yeah, so ideally, how do you make these people work together? So universities are becoming more global. They're becoming more global, and you can work with anyone from anywhere. You can download a paper from anywhere, and you can try it. And it's a very good work. So I'm commending most of the students from MUHAS. To be honest, I'm really impressed with what you're doing. Kuna wengine wanafanya hizo saratani AI na nini, data hakuna, wanatumia data za Marekani huko. Umeona? Wana train models ile kwa ajili ya kuassess magonjwa na nini. Sasa mzee unaweza kujikuta kugundua una diabetes ya Marekani kwa sababu unaona. But the idea is we need to help them. We need to help them. So he was talking about an innovation ecosystem. An innovation ecosystem is not about only what is happening at the university. You need innovative institutions. You need an hospital which says Saratani AI, since they are working to create models for AI model to address cancer issues, then we should create a way to collect and package data for them so that they can use those data to create a more smart solution for our own environment. Wasiendelee tena kudownload data kutoka kwenye database ya MCC na USAID. Yeah, so it's very important, and this is what we need if we want to see innovation coming out of what we do. But also it's very, very important the mindset of the management and leadership of this institution also to change. Because if they continue to think the same, mimi mwaka huu hapa nitakamata basi mbili. Ni kazi. If you still have those professors and doctors who are looking kukamata watu, hatuwezi kumove. Unaona? Yeah, kwa sababu as I told you from the beginning, the goal post is changing every day. Kwa hiyo leo mkiwa hapa kesho mnafungia kule. Kwa hiyo huwezi kusema mimi kwa sababu mwaka 70 ili figo niliona linafanana hivi. Unaona? So we have to do it the same way we've been doing it. So the role of university and academic institution has also been changing down the years. Kwa miaka ya 1000 back in the thousands, hawa watu wanaofundisha wanafunzi walikuwa wanaitwa masters. Unaona? Wakina Archimedes sana Amos, wakina Jean Baptiste de Lamarck, wakina Charles Darwin. Sasa wana vijana vipi na Charles Darwin na maswala au nani Einstein na relativity formula endo kaja nayo wewe chili tutumie. Unaona? Kwa hiyo you couldn't question the masters, they own them, they come with them. Kwa hiyo sasa baadaye hao masters wakawa wanakufa. Sasa kifo anakufa na knowledge zao. Kwa hiyo akawa introduce mtu anaitwa lecturer. Lecture kazi yake ya kwanza kabisa ku research kwenye kazi ambazo master alikuwa anazifanya. Umeona? Kwa hiyo ikazaliwa sasa academic and research. Kwa baadaye wakawa na research kwenye scope kubwa zaidi. Kwa hiyo sasa ikaendelea hiyo for like 1500 years. Sasa hivi ukienda Stanford, ukienda Aalto, ukienda University of Cape Town, ukienda hizo university zote kubwa duniani, now they are moving toward innovation because university as a tool as a center where it actually address issues that are facing the community. So university actually address problems that are facing the community. University offer solution for the private sector. So we expect companies kuja kwenye chuo kwa ajili ya kufanya research and development. University become a source of new innovation and startups. University become a place where policymakers, they come and seek advice for challenges facing them. COVID-19 imetokea, utende pale MUHAS tukachukua solution. Maona wana? So that is supposed to be the university of the future. So when we talk about third generation universities and university thinking beyond just academic and research, that is basically what we mean. Hatuzungumzii mambo ya kukamatana. Unaona? Tunazungumzia having a university as a core of the innovation and entrepreneurship ecosystem in that specific sector. So if it's health sector and if it's MUHAS, then we expect MUHAS to be at the core of the health innovation ecosystem. New innovations, new solutions, whether it's gadgets, whether it's framework, whether it's papers, which actually shows how we are solving the problems. And not just a replica of papers that were published last year. You're getting me? This has to be things that can actually be linked to what the market needs. And in order for us to be able to achieve that, it's very, very important we nurture the culture of innovation within academic setup. We train our students to become problem solver. We train them to possess skills within what they already have, but also beyond what they already have to possess skills like, as I said, critical thinking, problem solving, communication, collaboration, emotional intelligence. These are very, very important skills. So they become beyond just doctors. They become human beings. You're getting me? Yani mtu anamchoma mtoto sindano amenuna, mtoto atakapa sindano anachomwa analia yeye basi. Unaona? And then but that person is a health expert. Kifika huko ukiangalia quality customer care, quality communication, saa nyingine mtu uelewe hata unaumwa nini kwa sababu anakuambia hawezi kucommunicate. Unaona, anaweza kuwa ndo nakufa hapa. Kumbe kakosea tu kidogo. So the point is, how do we equip those skills which are really necessary? The best way to do that is either challenge-based learning, CBD. So you create challenges for the students so that they solve actual problems. If there's issue kwenye sehemu fulani, you give them challenge-based learning. You can also give them MCL, but competence learning. So it's not just focusing on what they know, you teach them to collaborate and partner with other people from other fields so that they can be able to come up with those solutions. So what is actually driving innovation today? The cost in the health sector is rising really fast. As I talked to you in the past 15 minutes, digital disruption is happening massively, but also rapid evolution of science and medicine. If you read Sapiens by Yuval Harari, the Israel guy, you'll be shocked things ambazo anazungumzia kwa sababu your face will be questioned. Hivi vitu hivi na kuelekea huko sasa tunaanza ku-question umungu wa Mungu. Umeona? I told you about head transplant. Umeona? Na watoto kuzaliwa nje ya nini, but mule ndani kuna vitu vingi vya kutisha zaidi. Sasa we also talked about digital health and the way technology is actually disrupting the health sector. we might need to revisit some of our policies and regulations. Naona tungasela wamo, I don't know if we're still using the National E-Health Strategy of 2013. Because if you're still using that, then we're dead. There are new technologies that have come out that they're not even included in that strategy. So that's why we need people from the health sector who have cross-cutting discipline, so that we can even design policies and regulations that actually go with the current time. Huwezi kumwambia mtu no. Sisi tulikubaliana huwezi kufanya remote diagnosis. But everyone is wanafanya remote diagnosis depending on what unaumwa nini na hicho kitu unachoumwa kama kinaweza kufanyiwa kinafanyiwa. So kama it's written in the Bible or Quran, you can change it. So in order for us to be in a good position to change some of those things, then we need to change those who are making those decisions. So it's not a new thing. There's a lot of cool innovations that are happening. Za MUHAS zote nazifahamu, maana sikuweka hapa family ya wote nimewasaidia wenye sign of them. But there's like Chiaro assistive technologies, they're doing an amazing work. I know they're working with CCBRT right now. Wanatengeneza low-cost assistive technologies, a very good startup, it's a very disruptive startup. You can't imagine namna anavyo transform maisha ya watu. Unajua usipokuwa mlemavu huwezi kujua maisha ya mlemavu na changamoto anazozipata. Wanatengeneza devices mbalimbali ambazo ni low-cost devices, and these people can be able to afford those devices. Then you have the likes of Medicare and Medback. I think the strongest one right now, I think Mkononi is doing really good. Their numbers are okay. We're helping them to raise capital, that's why I know. So there's a lot of innovations that are coming from young students, doctors from the medical and the health background, and this is very, very inspiring. So my call to you guys, you still have time to come with a lot of innovation. Please don't complain, come up with solutions. Yeah, because if we all complain, then there will be no solutions. And then you also have young people who are also exploring AI and chatbot for the health sector, remote diagnosis using solutions like Ongea na Dr. Elsa, unaweza ukachat mule, ukauliza baadhi ya maswali yako. Ishangazi, if you want to know about sexual reproductive health, they have curated Ministry of Health content for information about the afya ya uzazi, unachati nayo tu. But the most important thing, I met with Dr. Geoffrey, I think I was in Nelson Mandela University last week, and we were talking about technology transfer and research commercialization. 2 years ago, I met this guy, and he had the same product. Alikuwa anauza, nikamwambia there's no way kuna mtu atanunua hiyo product, sababu ikitizama tu inatisha vibaya mno. Product packaging, yes, it is scientific. You've done research, the formulas are scientific and everything, but from a product presentation perspective, ni sasa kuuza asali kwenye chupa ya konyage. It's very confusing. Alafu nje ya msikiti. Ya sasa. So that is what I was trying to do, and this is what I'm trying to show you. Like cross-discipline partnership and collaboration is key, because that's the only way you can be able to accelerate your product from just a concept or research to actually go to the lab and create the intended purpose, which makes it very difficult also to help researchers raise capital, because they own patent, they own trademarks, they own copyrights. But again, the quality of the product, if you present it to an institution or commercial investor, it becomes very difficult because it's something which cannot be commercialized. So it's very, very important also as a university and students to work with external incubators, accelerators, and hubs so that they can help you to improve your product. It's good to see Tanzania Startup Association is here. They will tell you about what they're doing. So it's very simple on papers. Simply, universities, they compete for federal funding, waenda wanaomba hela ya serikali, and then wanawapa researchers, Dr. Musa kufanya groundbreaking discoveries. Once they have the discoveries, and then chuo, through what they call TTOs, technology transfer offices, they help those researchers to attain patents and copyright. And then, instead ya researchers, zile dawa zako zile kuzichukua kuzijaza kwenye mabegi unatembea nazo. Ni matumizi mabaya sana ya profesa. Unaona? Unaweza kumchukua profesa anje kutembea na madawa yako kwenye begi anauza. That is not commercialization. All anyone does it. Commercialization is basically, it has a patent, it has a copyright, it has a trademark, it has a product. You link them to someone who can actually commercialize. So let's say wewe una ubunifu wako hapa, una drug umekuja nayo. Instead kwamba umeshamaliza lab unaitia kwenye chupa kunyagi unatembea nayo unauzia watu. Hiyo sasa una shida na una tofauti na yule mshikaji Mmasai ambaye anauza na dawa zake katoka kijijini. Yaani mna tofauti kabisa, shule haijakusaidia. Umeona? So you basically go sit down with Nakiete farmers, you get into an agreement, you agree to sell them the patent, a portion of what you own. They do mass manufacturing. Whenever they sell, you get your commission. You stay on the lab. Because that's what you do good. Sio kutembea kwenye vituo vya barabara kuuza madawa. Sasa, and finally, you find entrepreneurs, you commercialize your product, you commercialize your innovation, and usichukulie kwa sekta yetu. Si tumekaa miaka 4 tunajifunza kukodi, wewe huwezi kukodi siku 3 tukatoa kodi tena. Unaona bwana? Kwa hiyo kodi, I don't think you're already a doctor now. I'm going to code an application. If it was that easy, it could have been a bit tricky. So finally, and I'm wrapping up, I didn't need this. It's exciting to do innovation. You don't have to be serious. It's fascinating because you are creating solutions. And when you see these solutions are being used by people, and they're impacting people's life, they're generating revenue, they're creating wealth, it's very good. A very simple story with Mkolone. I think now they do plus 1 million USD revenue. And the student from here, can you clap? So it's interesting. It's a startup, it's a very good startup, it's a good number, and then if they exit, they also get good money because it's a business, but their business is creating impact. Just imagine all the small pharmacies and ADO store, they're able to get their medicine in time, they can be able to manage their record, they can be able to track the data, they can be able to assess the trends, they can be able to depict how the market is going. You see, that is what we want to see. We love doctors and we love them to treat us. It's very, very important. But we don't need this situation. This is not a good situation to be in. Kwamba shortlist ya madaktari uwanja wa taifa ni 60,000 wameenda kwenye interview. This is scary. So you can actually create other avenues and solutions and create the impact through building a stronger innovation ecosystem. Thank you.
Thank you so much, Mr. Dumande. Before I proceed, I'd like to recognize the presence of the Director of Undergraduate Education, Professor Mbugi. Please wave so that I can see. I would also like to recognize the presence of Dr. Enika, Associate Dean, School of Medicine at MUHAS. Welcome. Now, from that great presentation, so far we've learned that we need to create a generation of people who are problem solvers and not problem observers, isn't it? Yes. So generally, I hope 10 to 20 years, we won't be seeing the situation we saw at Uwanja Taifa there, right? So we need to create a generation of doctors who can practice entrepreneur, a person who can employ themselves. There are so many opportunities. I would like to commend the students and all the people who are here today who have not integrated themselves into the innovation ecosystem to start looking into it. Because frankly, I'm a first-year student, but then I actually see there is so much in it that somebody outside the ecosystem doesn't see. You really can't know unless you're there. You don't benefit from something unless you put yourself in it. Okay? Yes, so So far, something interesting I've learned today, we're in the 4th generation. It was just last month that I knew we're in the 4th generation. I didn't even know these things are counted. But then, yeah, we're in the 4th generation, so we need to change the way we think, the way we view things, the way we practice. So this satellite session is specifically set to integrate your minds into the new world, the 4th generation world. We heard a speech from Professor Mbugi on the last symposium on data analytics, and they said, 4th generation university. I was like, what is 4th generation universities? How many of them being like, what is this all about? Yeah, so you don't get to learn unless you're in it, right? Yes, for the next session, don't allow me to speak too much. I'm setting down my mic, and I would like to welcome Atupele to continue as the fellow moderator for the panel discussion session. Welcome.
Thank you very much. Hello, everyone. Thank you, Ms. Lucy. Thank you. I am very honored to stand before you to moderate this session. Can you please turn to your neighbor and tell them it's time to start mining gold? Because we'll be mining gold from people's words. Okay, so without further ado, I'd like to call my very good panelists. And to begin with, we have our very own young innovator, an innovator who is quite interested in artificial intelligence, an operational manager of Saratani AI. I guess all of you already know the person, Sangudi. You're welcome to stage. Apart from that, we'll be also having our very own young miss. Yeah, I'd like to call her that. She is currently working at Buni Hub, and she's having an experience in working at Costech, but also she has been working with MUHAS in various fields, all regarding innovation. Ms. Promise, you're welcome on stage. And the next person, the heavy one, I don't mean the other ones are light, but this person, I'm very excited. Actually, I'm very excited for this panel. We'll be having the CEO of the Tanzanian Startup Association, Mr. Zahora, you're welcome on stage. And lastly, but not the least, we'll also be having the pioneer of innovation in MUHAS. Whatever you're seeing right now is one among the products of his hard work. I'm even scared to actually read the biography. You know, I should give him the respect, you know? So let me just read it according to how it's supposed to be said. He is currently, so he's a professor at cardiovascular pharmacology at Muimbili University of Health and Allied Sciences. He is also the earliest pioneers of innovation and a dedicated mentor and stakeholder to the MUHAS innovation ecosystem. Professor Maina, you're welcome on stage. So as I told you, we'll be mining gold. From people's words, we'll be getting gold. Okay, so from the far left, I would like all of you to please introduce yourself once again, because you know it's after lunch, people are already tired and perhaps they've already forgotten. So you can begin.
Yeah, good afternoon, everyone. Yeah, my name is Samud, fourth year medical student, but also operational manager for Saratani AI, co-founder and operational manager for Saratani AI.
Thank you very much, Mr. Sanudi. Next.
Na wasalimu kwa jina Muungano wa Tanzania. Kwa jina naitwa Promise Mwakale. I am partnership lead at Buni, Hub of Hubs, and the hub is there to provide support for the innovation ecosystem by creating a critical mass of talent in the innovation ecosystem in terms of early stage startups as well as freelancers. And we also help existing hubs for mentorship and linkages into different institutions that they don't have access to. But we provide mentorship for new hubs that are beginning. So from the idea scratch into them creating programs and existing.
Thank you very much. That was very brief. Next.
Okay. My name is Zahoro Muhaji, and I'm a CEO for Tanzania Startup Association, known as TSA. TSA is a membership-based organization which brings together the stakeholders of startup ecosystem. I mean, by startups, I mean startups which we've heard some of you here, Saratani, AI, and the likes. But also we do have incubators, accelerators, as a part of our membership. Personally, my background also is on entrepreneurship. Apart from being CEO of TSA, I deal a bit with academic. I sit on a governing body of College of Business Education, CBE. So I'm happy being here at university because it feels familiar. Thank you.
Yeah, my name is Oshi, a retired associate professor of pharmacology. I did my PhD in cardiovascular pharmacology, which is what you said in the introduction, but eventually, after coming to MUHAS, I have largely devoted my efforts in research in traditional medicines. So I have been working with the Institute of Traditional Medicine, Department of Biological and Preclinical Studies. I have worked, I would say, extensively in this area, but have also been privileged in collaboration with my colleagues to develop products at the Institute of Traditional Medicine. I'm happy those who have taken over after me have worked very hard, and our institute currently has 19 products.
Wow, quite impressive.
Which need a bit of what my friend Tambalike said. But don't laugh. Let me tell you, currently, the income, the upper limit of the income is around $10,000 a month.
Thank you very much, Professor Mayo.
Thank you very much.
You're welcome. They are already very enthusiastic. I told you we'll be mining, so better get ready. To begin with, from the far left, Mr. Sangudi, our very own young innovator. Mr. Sangudi, you are the operational manager of the Saratani AI. My first question to you, as a young innovator, what experience have you encountered? And I mean, including the challenges, of course, not only the good parts. So what challenges have you encountered so far with the MUHAS innovation ecosystem?
Thank you for the nice question or an input. And to talk about actually a story, and a lot has been said about the experience, like David, when he was speaking, like he was speaking through my mind. So speaking in that perspective, to start with the challenge, not just the beauty of innovation, maybe I can classify them into individual level, the team level, and the global level. So as speaking as innovator at an individual level, first of all, I've been here at MUHAS for 4 years. So at first, let's say in first year, in most of you are trying to do each and everything. Like everything that is exciting you, you want to be part of it. So in that perspective, you find yourself not just, you are learning a lot of things, but you are not specific into what kind of things that you want to achieve. So I may not call that it's wasting of time, but you are learning. So at the end of the day, you will shape yourself and come into a perspective that you are much more concentrated into building things and to come up with solutions. So at individual level, most that you will encounter is procrastination, as not only in innovation, but also in the studies. Like you want to do something, really want to achieve something, but the energy to go with it, you will find yourself you are struggling. So that is a challenge. The other issue around individual, like you want to innovate. Most of us, we have that perspective of innovating in digital health, but you want to innovate, but you don't have the technical skills, the technical know-how on how are you going to implement or to build your solution. And most of us, we are thinking in a programmer mindset. And Mr. Mtambalike said, like, we don't want a doctor that knows how to code, but the doctors that can know how to work with coders. So most of us, we fall into a trap or maybe just a getaway to start learning codes by ourselves. So you need to maintain the time for studies, but you need to maintain time for learning extracurricular activities because you want to know the technical how you are going to build your stuffs.
Mr. Samudi, to top up a question before you finish up.
Yeah.
You innovated certain AI at what year of your study?
Okay, we started building certain AI since I was in second year.
You can hear a very busy year for MUHAS students. So when he was speaking about the personal problems, he spoke something about procrastination, and I was quite impressed. Like, how did you manage to balance your studies, the innovation stuff? Before we go up to the other problems, we're still in the personal part. So how did you manage?
First of all, you need to make peace with the academics.
Students are taking that, right?
Yeah, if you want to be an innovator, you need to make peace with your academics. When I was in first year, I was a bookish student. It was all about GPAs and whatever. So when I started to get out of the academics, like to look around, that's where I knew that I need to make peace with my academics. So I need to make time for studying. I need to make time for innovation, but all the way that I need to maintain my GPA. So that's all matter. Yes.
Thank you. You can keep that.
Yeah. So on that perspective, because you are working in different ways to bring about the solution. So there is a time you'll be working in a certain idea, and at the same time you have other projects or other activities around innovation. So most of us, we don't know the time when we really need to pivot. Like these things is not going to be useful in the future. So we still continue working on the same project that at the end of the day, they might be fruitful or may not be fruitful. But you need to know that what you are working, is it going to solve the problems of the society, or you're just working on your own problem? So you might find yourself you're working on something, but you are working to solve your own problem, not the society problem. So you needed to know how are you going to pivot to look on something that can be much fruitful. Because certainly I wasn't the first idea. I was working with other ideas like Smart Afia Connect. That's why when I came to Certain AI, maybe my journey is also continuing. I don't know. Yeah.
Thank you very much. And before we move the mic to somebody else, I'd like to add another question. So what ideal situation do you perceive should be given to the young innovators? Most people really want to develop stuff, but they feel like the environment is not quite supportive. So what do you think we should put, or what do you think we should add so as the environment may be supportive for those young innovators to keep on innovating?
Okay. Before I answer that question, I remember one day I was talking to pharmacist Pastor Monishi, and he actually told me one thing. Like, Samudi, you're working on innovation. There's no time after school you say that now I'm serious working on innovation. The time that you have now at the university is the time that you can work on activities, but because when you graduate, you won't have that much luxury. So if you are learning skills, just learn them from now when you're in university. So you need to, like they say, fail fast, learn fast, right? So the ideal situation, you can say that I have to finish my studies first before I engage into extracurricular activities. It's like you just need to balance. You just need to balance your time. And academics are not obstacles at all. It's just you need to know like what do you want to achieve. And by the way, we have a very supportive university environment. When I'm talking about the Directorate of Research and Publication, it's very cooperative. But we actually need a physical place, like a platform. We need a hub, because most of us we are more of medical. We are more of medical students. We are more of health students, but we lack the technical skills. So I think if we instead of going extra mile, I'm a medical student, but also have to learn how to do programming. But if I have an environment that I'll meet the technical, that I'll be having the technical assistance that I need to implement my project, that could save a lot of time, because I have to think only on the innovation, then I'll have the assistance on how I'm going to implement my project. That's what is needed right now.
Thank you very much. A round of applause, please, for their brief answer. My next question will go to Mr. Zahoro. Mr. Zahoro, you are the CEO of the Tanzanian Startup Association, and we are having a lot of innovators here, one of the representatives in our very own table. So what has your association actually done to help these young innovators nurture their talents, keep on improving in their innovation and their stuff? What has your association done for these people?
Okay, thank you so much. As I've said earlier, our organization's membership-based organization, and the sole aim of having this organization is to actually represent interests and interests of startups to the other stakeholders, which together support the ecosystem. So basically, this means more on advocacy work and also lobby for our interest. Basically, our interest can be wider. Our interest can be policies, can be laws, can be regulations, which can create conducive business environment for these startups to grow. Because innovating, it's one thing, but if you want, as Jumanne was saying, if you want to commercialize, then it turns into a business. So business has its own principles. You can innovate something here or inside your room, but to take it to the wider market, for it to be a business, then it has to have another supporting environment, and which we felt for years. Our business environment has never been that supportive for innovative businesses and mostly startups, which most of students here are starting Saratani AI, and that alone happened by chance, by accident. It has its historical background, etc. I know a lot of people here are young, but I know Snehapa and Dean Pale atakumbuka, like our background as a country comes from socialism. We never used to have businesses, private sector. I know some of you can't relate, but even me, I can't relate. I was not there, but my dad always tell me this, that there were no private sector. There was no people owning companies and stuff. Everything used to be done. All business used to be done by government. Even owning small kiosks there, even selling beers, tax company, mabasi ya mikoani, everything has to be owned by government. Then come quickly in year 85, we change our mode of economy to free market. That's what you're seeing now, private sector. So then this push into private sector was more, I would say, was more advocated by other external factors, things like World Bank, etc., etc. And that's when firstly we had our private sector, and then we come with the laws and regulations which will be governing the private sector. So the thing is, these laws, when were created, were only based on traditional way of doing businesses, and then here we are with innovation. So with innovation, you always go against the traditional ways of doing things. So we found ourselves with a situation where we have a business environment which is not so supportive of innovative businesses and business startups. And that's where we thought, okay, now, like me and Jumanne, we're coming from almost similar background. We're both born in Kariakoo. That's why I'm there, son.
That explains a lot.
Yeah, okay. Me, I was born in Kariakoo market. Pale, Sokoni, Kariakoo market. There's no farm pale. I'm not shamba, I'm not nini. So the only way you will survive is selling words. There's no farm to farm or street to end up chunga. You have to be just that sharp with your words to survive. So anyway, so then we've been entrepreneurs, but we've seen how environment has never been friendly to us. And we thought, okay, what do? We cannot be sitting every day complaining that, oh, you know, I have my innovative idea, I've created this product, but, you know, TBS will not allow me to sell it. Or coming here and say, you know what, I have this medical innovative idea, but you know, I don't have an environment where I can live test my innovation to wider public. So we thought, okay, why don't we engage government? And that's the whole idea we come up with establishing this association. And our sole aim has been always engaging government to make sure that we have this conversation and make sure we create this conducive business environment for innovators. I'll give you one example. So currently, we are talking with the government to create startup policy. Wow, this will be a policy.
Okay, a very troublesome question on top of that. Okay, so you started speaking about the policies, the part I was really waiting for. So what are the effects of the national policies on the impacts of, on impacting the startups, especially these health sector startups?
Yeah.
Yes.
So we live in a country where constitutionally, we're a democratic country which lives in rule of law. Everything we're doing is basically governed by either a law, a policy, or regulation. From your birth, marriage, whatever you want to point on, there's a regulation around it. At what age you are allowed to drive a car, at what age you are allowed to start a primary school, at what age you are allowed to enter university, which qualification you should have. They're all somehow written somewhere. So technically, having good policies and laws and regulation is part of building the ecosystem. And if we don't have them, then actually we are negatively impacted. I'll give you a simple example. In Tanzania, back then, I have a case in my desk currently with one of our members. They've come, they want to start a business. What's the business? They want to do something like Uber or Bolt for Bajaj. But their Bajaj are electric Bajaj. Electric Bajaj. They went to LATRA, so-called, they said, okay, we don't know how to register you. So this is a Bajaj, but it uses electricity. So is it a motor vehicle something? Or is it an electrical equipment? Because it uses electricity. And this goes back to when first person came up with a Bajaj in Tanzania. Our regulation was so clear. What is a motorcycle? It's something with 2 tires. What is a car? Something with 4 cars and more. This one had fed wheels. And they were like, okay, we cannot give you a license. Nowhere is written. You understand? So they could not register their Bajaj here. So they had to force using it by illegal. Then they start to get more Bajajis. Then okay, Kumbe it's not a bad thing. It can be safe and people can walk around. And then the regulation came to allow Bajaj. So this teaches what? This teaches one thing. Innovation always comes first before regulation. So what if we have an innovative idea in medical, but they tell you, according to our regulations, you are not allowed to do so and so. But if I'm coming with something new, how do you expect the regulation to be there? That's why it's new, and the innovation is always new. So we have to have an environment where you can allow people, these students, to come up and say, I have this Saratani AI thing. I need not only to test here in MUHAS, I need to test it in hospitals, etc., etc., etc. But how? it has never been certified, maybe yet it has never been approved by whoever, Team DA, whoever has to give this approval. So we need to create an environment where these innovators here at MUHAS can safely go there and live test their products. And that's where you come up with things like sandboxes, which currently we've finished creating the framework, national framework, which is Autodesk for Minister of ICT. They are the one to sign it off, then it will be distributed to every other regulator and agency in government so that they can officially create those sandboxes, so that when a student here in MUHAS come up with something new, nowhere regulations are not yet to allow that, they can just safely go to the Ministry of Health, tap in that sandbox and given at least a permanent license or certification to live test whatever innovative ideas has come up. So those are kind of things we're working on.
Thank you so much, Mr. Zahor. I am sure this is a very good news for the innovators. Policies are no longer going to be the very big problem. Okay, so Mr. Zahor, I'm gonna come back to you later to Miss Promise now. Miss Promise, you're very competent with establishing innovation hubs in universities. And we as MUHAS, members of the MUHAS innovation ecosystem, we are thinking about having an innovation hub. But so what do you think? I mean, to what extent do we really need this innovation hub? To what extent will it really be advantageous to us? Should we just leave it, or why do we really need this innovation hub?
Thank you. First, I have to declare a conflict of interest. I have been at MUHAS for 10 years, and I think I've known MUHAS. I have actually grew up in MUHAS. I know Professor Moshe is looking at me because the first time we met, I was a 23-year-old. Oh, okay, I've told you my age, sorry. I have seen so much change at MUHAS. For the last few years, I've been at the Directorate of Research and Publications, and so much has transpired, so much has gone on, and it's been so much robust since my days, just seeing one single office of the officer-sponsored project. So as we're moving, and as Jumanne was talking about the third generation universities, these are things you need to incorporate. MUHAS needs to have a place where it can come together, where innovation can have a structure, where innovation can say, this is a person that is responsible for this. So it just needs to be like the same way that bioethics, I was also there for the beginning of bioethics starts. And now you see all these requests from nurses are saying, we have this, we want to teach ethics on this, we want to teach ethics on that. And then, there's a department of bioethics that will be there, and there'll be someone, there'll be head of department that you can consult into. So the same way, and I was happy to hear David saying that this will incorporate the IPR desk. So there's different methods of having innovation hubs. There's different ways, even with all the universities that we've helped establish. There's no two that are the same. There's some which the hub is part of the tech transfer office. There's some which the hub carries the tech transfer office. There's some where it's just a co-working space, but that includes their field trainings. So it's really about what works for MUHAS. But as MUHAS, we say premier center for health education, yeah? I think that's the motto. As a premier, there is really so much that can be done. One, you're the consumers. I mean, at the end of the day, the close relationship with MNH, this is the consumer. And if someone comes from MUHAS and goes to TMDA and says, can we have certification of this? Can we sandbox this? You're more likely to be trusted than someone from VETA, for instance. And that's just, again, I say conflict of interest, but it is that. So there's a brand of authority in that this is going to be ethical and it's going to be medically sound.
Thank you very much.
Thank you very much. Thank you very much, Ms. Promise. With your experience in working with COSTECH, and you've also told us that she has been here for almost like 10 years working in the DRP office and all that. So what model do you think would really fit for MUHAS? I mean, you've spoken about a lot of models and I was really trying to catch up. So what do you think, what model is going to really fit us at the premier?
Okay, so usually the beginning of an innovation hub is a situation analysis. And unfortunately, this is a weeks long and absolutely cannot be captured on this. And I cannot tell you what happens because as we mentioned, it's going to be what works for MUHAS. There is 4 pillars of an innovation hub. The people, that means the team, the people, which means the community, the programs, and the place. So at the end of the day, that is what makes what you need or what a hub can have on that. What would work for MUHAS, I know at least you guys have thought of what would be there or where it would be. All these are very dependent on what is it MUHAS. So it always starts with the situation analysis on what is there and what would be there.
And for those 10 years you've been here, what do you think is there?
I'll whisper to Dr. Sunguya.
Okay, fine. Dr. Sunguya, please help pass that to us. We really need that. Thank you very much. Okay, so on the matter of the innovation hubs, going back to Mr. Zahoro. Mr. Zahoro, who do you really think we need for this, to establish this innovation hub, just like how Ms. Promise has told us about the importance? Who do you think we need to engage so as to ensure sustainability of the MUHAS ecosystem, the MUHAS innovation ecosystem?
Okay, I think the biggest challenge has always been, first thing first, as I said earlier, I also sit on the governing body of College of Business Education, CBE. So we also have a similar challenge there. How do we keep this incubation or hub going? But first and first, I think for something to be sustainable, it has also to be independent. That's the first thing first, just also to be independent. And by independent means to be able by itself to run their programs. And I think also to have a clear impact. When something has an impact, even if it doesn't make money, people will come and, you know, always be ready to support. Because I think maybe you can start here on an innovation hub. AVC of the university will allocate a budget year 1, year 2, year 3. He'll come back to you, say, guys, I don't have unlimited money to give you, you know. So what's up? I don't see any impact. So you have to clearly show the impact. But so in order for all those 2 things to happen, you must really, really engage the people, the stakeholders outside the university. And this is the biggest challenge I see in not only here or at my college in CBE, but overall in the academic and research industry here in Tanzania. One of my good friends, former Minister of Trade, Professor Kitila Mkumbo, always has this saying. He says, he's from the University of Dar es Salaam. There he says, we academicians, we tend, anasema kwa Kiswahili, tunapenda kupeana, kuambukizana maarifa yetu na ujinga wetu umo kwa umo. Yani sisi wenyewe, yani whatever good they know, and bad they know. So I think we need to break that and engage more people from the private sector, people from, let's say, financiers, because that is what will bring that knowledge out there here, and that exchange will really create the lasting impact. Because I'll tell you, if we have MUHAS hub here, it goes having work with Sahara Ventures with Jumanne. Jumanne every year do have this big conference here in Tanzania. You have partnership with them. You are so assured that your students will have a platform to showcase their products every year to millions of Tanzanians out there. That alone, someone going there and saying, okay, I've seen some products or some innovative or some startup from Muhimbili Innovation Hub. That word out there, somebody will say, okay, next time when we have something, can we go to Muhimbili and, poach something from there? And that creates the traffic in the pipeline of further projects. I'll give you a small example. I remember I was invited here to come to be a judge in one of the events here. I came here. That first thing first, I was like, Muhimbili, startups, innovation. Wale madaktari. I'm like, okay, let me go.
Honestly, that's a challenge.
I was like, okay, let me go see. But I came here, I saw, seeing is believing. I was like, wow, this is actually very good quality startups. I remember the following day we had a visit of a US ambassador to our office. And when we were putting the list, I was like, there are some guys from Muhimbili, please invite them.
So a selfish question. So this question before we continue. So how many health sector innovation, specifically on health, have you helped so far? How many?
I think there are quite few. And the reason, as I said, people from academic background trying to live on their small cycle. They're not out there. And so I give you it as a challenge. When you have a hub, please, it should not be just a hub where every day people have to see fellow medical doctors. Make sure people like Jumanne come to teach, come to share experience. Make sure it's very open for our outsider to come. A lot of hubs have gone around the hubs in Iringa University, in Mbeya University. I've been around a lot of universities. First thing, one thing you go there, you learn is they're closed. They are closed. This is our hub. We have our PhDs. We know what we know. So there's little room for outsiders to come and share their experience. But as Jumanne said, you have to have other skills which are found out there in Kariakoo market to be able to, to get going.
Thank you very much. We will keep that into mind. Coming to Professor Mushi, it's been 10 years. That was just an advertisement. Yes. So it's been 10 years, Professor Mushi, since you publicly started supporting the young innovators. So what experience do you have during this, running the students' innovation as a very early pioneer of the MUHAS innovation ecosystem?
Let me say my involvement in these innovations, it was purely accidental. Yes, it was. Yes, I've been honest, that's very good. I was director for research and publications 2012 to 2015. In 2012, the VC, then Professor Kaya, went to the University of Nairobi as an external examiner in pathology. And while he was there, he was informed that the African Biomedical Engineering Consortium was going to have an international summer school and design competition in December. And he was challenged. He was challenged to participate, but also be part of that ABEC or African Biomedical Engineering Consortium. So he came back. His target was to invite, to tell the DVC, Professor Lamuya, to go to Nairobi and represent the university. But then Professor Lamuya had another commitment. So he picked the DRP, and that was me. So I went to Nairobi.
So the accident.
I participated in the summer school, essentially as an observer. And then at the end, they usually also have annual meetings at the end of the summer school design competition. So they asked who is going to host the next summer school. I volunteered. I volunteered to host the next summer school, which was in 2014. It was done here in Dar es Salaam. And MUHAS students participated, academic staff participated, D&T also, they participated. And we didn't really have innovations to showcase in that international summer school and design competition. So
to top it up before we continue, Professor. So you started speaking about the situation back then. I don't know if it's whether 2014, but it's somewhere near 2012 till 2015. So can you just briefly tell us the situation? Because I'm seeing a lot of innovations these days, and I don't really know if the situation was the same back then in 2012 or...
That is what I was going to tell you, because then in 2015, when we went to Addis Ababa, we went with students, two students, Asha Bilan and Sakina, who had a USSD, Integrated Management for Childhood Illnesses application, to help mothers and caretakers to make decisions at what point to take their children to the hospital. And this application was voted the best. So that was the beginning, and then next we went to Kenya. We had more of these. One of innovations which was presented from MUHAS was a digital ophthalmoscope using a cell phone. Using a cell phone, yes.
That is quite impressive.
Using a cell phone, that gadget also won. And then we went on to Cairo. That's where the innovation on Daktari Mkononi was presented. We had a bit of problems with one of the judges, but otherwise we were going to fare very well. But I know Daktari Mkononi has created something else. The Dawa Mkononi, I'm sure it is a product from Daktari Mkononi. I don't know how Daktari Mkononi is doing. No, Joseph. Yeah. Dr. Joseph, yes. Yeah, and Dograta Simtei, they actually presented this innovation. And then we have, after that, innovations started to pick momentum. They were, because what we would do was to announce on the website for people to write up proposals for their innovations, and then we would send them to the ABEC committee to screen them. And because funding was not a lot, they would pick only a few. These are some of those which managed to get away to ABEC. But we are not forgetting Mariam Muhammad Ali, who in third year developed an innovation. I don't remember the details now, but this, she took it to Germany in an international competition. It came out the best, and she was even funded. She was even funded to further develop it. I also linked her to a professor at Anhalt University, Professor Boris. He attended the summer school in Cairo. He was one of the facilitators, and we've continued to collaborate actually, and has been instrumental in supporting our program in biomedical engineering, right? So he volunteered to help Mariam Muhammad Ali, but I don't know where that has gone. But another important thing which I need to share is about Atish Shah, who is a medical doctor, who participated in all these summer school design competitions. And after graduating in medicine and doing his internship, he went on to do masters in biomedical engineering. Yes, and currently is an adjunct staff in the Department of Biomedical Engineering. Soon he will start teaching in the Department of Biomedical Engineering. But what is important, he has received 2 grants already. Right? One from USAID and another one from the UK. And these two grants were for funding his innovation on a bed for preventing bed sores. This bed uses a bicycle pedal and has pockets in the bed, inflatable. So using that pedal would differentially inflate the pockets, and that way would be able to turn a patient to different positions and prevent
Thank you so much.
Right now, let me finish that, because I have another important one, because he was awarded by the President of the United Republic yesterday in Zanzibar for developing a hand, right? He has developed he's actually designing an upper limb for amputees, right? And he presented it in competitions that were hosted by Benjamin Mkapa Foundation. Yes, and this project is also doing this project with the University of Strathclyde, where he did his master's. He got a research assistant's position. So his gadget is quite very well developed.
Thank you so much. That was quite impressive, to be honest. So now we don't really have to worry about the amputated hands and all that. Thank you so much, Professor Moshi. So with that in mind, I believe that the future is actually so bright. But we believe that we are not yet there. We have a lot of innovation, but we know that we are not yet there. We still need to have more, because these are cream students, so we believe they have lots in mind. So what do you actually think? What kind of innovation ecosystem would be ideal for MUHAS, and how can we incorporate it into academic curriculum? Because as we all know, MUHAS is quite a very busy institute. I mean, everybody is having a lot to do. The days are very, very packed up. So how can we incorporate, and what kind of the innovation ecosystem can we incorporate in MUHAS for us to also prosper like the people you just mentioned a few minutes ago?
Certainly, we need to build intra-professional teams. Tambalika said that is very important, to build inter-professional teams. We are very lucky that medical engineering is here. I'm hoping now they would become part of ward rounds. They will become part of clinical meetings to get firsthand the problems that the patients are facing in the wards, in the clinics, so that working together with the clinicians, they can start already developing solutions. But then, with these innovations, we cannot work alone. You said it correctly. We do not have money. We do not have money. We cannot take any product to the market. We need to start involving business people. We need to start involving industry, especially those which are engaged in production of health products, so that they start partnering with us, because you don't want to engage them at the end of the process. You want them to grow with the process so that they can develop interest very early, contribute ideas. Like you are developing a gadget and they have a knack of how this gadget should be, so that in the market it will be competitive. But again, there will be funding. They will be funding the innovation, because they're part of the process, and once they have developed interest, then they will fund it. But the other thing is we need an innovation office. We need an innovation officer at MUHAS who will be championing this innovation, who will be working, and just as a sole activity, working with the innovators 24 hours, 7 days.
Yeah. They're already here, they're hearing. Yes. So we need an innovation officer.
Yeah, but the other thing is, we need to be working with lawyers, protection, and I will tell you why. right from the development stage, if you don't start sorting out things at the beginning, you will be working on very high tides. You don't start writing partnership agreements when a product is already developed. You have troublesome people, they will run with the product. True, you'll be surprised how a person you trust can turn around to be an enemy. So my suggestion is to actually start working with lawyers, and institutional lawyers, yes, they will be there, but these are not the powerful lawyers that you find in private practice, because currently there is restriction. Lawyers in government employment cannot do private practice. That is the challenge. So you need powerful lawyers who can really do big things in the law environment to start protecting your innovations from the beginning. But the point is, you don't have money. So if you don't have money, you start partnership. You start bringing them in to become like patrons. Yes, so once they are patrons, you are already, they become your daily mentors, supporting you in legal hitches, and in that way, you will be safe. Don't wait until you get something to patent. That's going to be very difficult.
Thank you very much. Thank you so much. Okay, time is really limited and I have a lot of scribbled questions. So I'm just going to pass one question for each of you. Let's pass the mic to the left side. Mr. Samudi, we are in the presence of very heavy people who have influence and people can really help us with our ideas. So what do you think these people should do for you so as to improve your environment, to make your innovations better and the environment generally, the ecosystem better?
Without any second guess, we need an innovation hub.
Apart from the innovation hub? Apart from the hub?
Apart from the hub, I have nothing more.
Nothing more.
To add up what Professor was saying, Professor Mosh, based on the event yesterday, we were represented by two teams, and we were certainly I was the second runner, represented by Shaban Busega. Yeah.
Thank you. A round of applause for the Sartani Eye. Okay, so this question, it's one question, but I would really like to hear the answers from the two of you. Both Ms. Promise and Mr. Zahoro. All of you are experienced in helping young innovators, and I feel like I really have lots of questions, but Ms. Promise first. We are, as we said, we are having a plan on establishing an innovation hub. So what problems do you think we will be encountering? What, you have done a lot, so there are those possible challenges that we may encounter. Can you please try to outline them a bit and tell us the solutions very briefly?
I'm going to start with the main problem is going to be a mindset change. I know we keep hearing about how much money we need to have a hub, how much money we need to do this. But just in the beginning, when we were talking about database, in a knowledge economy, a database does not require money. It doesn't require, it needs human resource, and it needs somewhere to start. So establishing a database would be I think there's some hubs that exist simply for having, this is a database of who and matching who by who. For instance, there is the government's I&I policy, and that is the policy to identify and help innovators, innovations in traditional medicine. But the simple fact that you'd have, whenever there's development partners are making programs, they always go, how many health, how many startups working in health, how many agritechs, how many fintechs, how many edutechs. Just having that information and having a place to have that is already wealth. So a mindset change and having not seeing the stumbling block, but seeing where the solution is and what you can do about it is one of the biggest problems you're going to have. But then also recognition and having an official recognition on what the mandates or where you fall under or where you're placed in the organogram. That is something that needs to be stretched first.
Thank you very much. Mr. Zahor, as I said, my question would go for the two of you. Apart from the mindset change, what else do you think we are going to face during this establishment, the establishment of the Innovation Hub?
Okay. I think it's also what you should prepare, which I find it very, I don't know what to say about it, because this just came out to me yesterday on Twitter. I think the attitude of them students also, because I think maybe me and Jumani were cut from different cloth. You know, we grew up in Kariako, a very busy area where nobody is just waiting for you to make a decision. I mean, I used to go from my school, from where I live, to my kindergarten. This is when I was 3-4 years old. I come out of my home, I see like 5,000 people out there just roaming around. And I have to make a way to walk to my kindergarten school and get back on my own. In between, I face thieves. People want to steal my bag, want to steal my lunchbox, want to steal my money, want to steal my shoes, want to sell me fake watch, everything. So maybe I have a bit of set of different attitude, but one thing I've seen it happening is right now, it's the attitude issues with our youth. There's a lot of knowledge out there about anything you want to learn in today's world. You want to know how to fly a plane, you can go on YouTube. There's a videos showing that. But I always wonder, why do people don't access these free materials to learn by themselves? You know, someone come to me and say, you know, I want to know what's the difference between a seed funding and Series A. I'm like, that question, you have a smartphone, you can Google that. It can just, you know, information is just out there. So the attitude, people just want, you know, to be babysitted. And I'll tell you, in innovation and entrepreneurship, no one will babysit you. I personally, I'm a bit younger, I'll say, not that old. Yeah. I go in rooms where I'm almost the youngest. I sit on the board of Keep Yourself, Tanzania Private Sector Foundation, the apex body of private sector here in Tanzania. I'm the youngest. I'm a member CEO roundtable where all CEOs of all big companies, NMB, CRDB, TBL, meet every month. I'm the youngest. I sit on the board of public institutions, CBE. I'm the youngest. I'm surrounded by professors and PhDs. Everywhere I go in these rooms, but I'll tell you one thing. Nobody handed me that. I go, I knock the door. They didn't open, I pushed. If they don't push, I get into the window. But I got my way in, you know. So I think the attitude, the hub can be here, but I went to one university, I don't want to mention the name. There's a hub there. We went there, we want to talk to people. We brought some experts to meet the students. And trust me, in the lectures, teachers had to go beg the students who are just sitting outside there. Like, hey guys, come and listen. You know, this is beneficial to you. Trust me. And I'm like, why are you begging them? I'm like, listen, I would rather talk to 5 people sitting here who are willing to listen than going out begging people. So I think having an innovation hub is something, but please prepare yourself mentally when this uptake is not that much as you expect. This thing example. I think for you students also, this is a challenge. Please, your attitude will make a difference. Don't sit there thinking, there's a lot of those, like this guy, that guy there. I don't know them. This guy just shoot me some message from Twitter. I don't know where, hey, we're from Wimbidi, blah, 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 I wanted to blah, blah, blah. And then here I am. But that attitude to go get it, Yeah.
Thank you very much. A round of applause for my panelists. When I was looking at the audience, I felt some people burning holes to my head, like, Atu, you're having questions also. So I am welcoming questions and answers from the audience. You're all welcome. We only have 15 minutes, so please utilize this to the best. Thank you.
Habari za mchana. Mimi naitwa Manuel Gilima na tokea COSTECH, nimemwakilisha mkurugenzi mkuu kwenye mjadala wa mchana leo. Cha kwanza, kama COSTECH tunapongeza waandaaji wa session hii, conference hii ya siku mbili. Of course mwaliko wenu tuliupata kwa kuchelewa kidogo, almost tu jana kama mchana hivi. Sasa kwa kuona umuhimu wake, imebidi angalau tuatendi hii single session. Tuone kinachojadiliwa hapa. Kwa sababu sisi kimsingi hiyo ndio kazi yetu ya msingi. Na nimefurahi kukutana na nyie. Of course kiangalia tulipokuwa na sasa tunakoelekea, tunapiga hatua nzuri. Nimeona vijana wengi. Samudi nimemwona pale alikuwa kwenye Maksato this year, msomfahamu, na ameingia finali na afiko kwenye list ya wanaosubiria kupewa fedha. Kwa hiyo wakati mwingine unaweza kuona alikuwa na ule ubunifu wake wa saratani eye, ilikuwa ni kitu kizuri sana. Nafikiri watu wote walioona walifurahishwa. Kwa sababu tunaangalia sasa hivi sisi kama COSTECH kuencourage vijana wetu wa Kitanzania na wabunifu wetu kutengeneza vitu vya kwetu, hasa kwa mfano kwenye idara ya medicine kama nye. Hatuna vitu vingi vya vifaa tiba na nini, vingi tunaagiza nje. Kwa tungependa tupate wabunifu wengi ambao sasa tutaanza kutengeneza vitu vya kwetu na kuipunguzia serikali mzigo ule wa kuagiza vifaa tiba kutoka nje. Kwa hiyo ndio maana tukikuta vifaa tiba ubunifu kwenye sekta ya afya ule unaoleta tija, actually huwa si kama COSTECH tunafurahia sana. Kulikuwa na huyu, kuna mwingine alikuwa na mkanda salama, zilikuwa bunifu nyingi fulani za afya, alafu zote zilifanya vizuri. Kwa hiyo kwenye hilo nawapongeza, ni hatua nzuri. Nafikiri wanafunzi wengi ambao mmehudhuria mchana wa leo kwenye session hii, nafikiri Samudi ni nani nzuri. Unaweza mkapata reference kwamba hamna bureaucracy kwamba si utafanyaje. Ni hizi tu, hilo lilikuwa ni moja. Lakini sasa si kama COSTECH tunafanya nini sasa kutokana na changamoto tuliona profesa ameelezea pale, nilikuwa namsikiliza. Pamoja na kama alivyosema promise hizi quantum innovation spaces, mchakato wa kuanzisha, kuna vyuo vimeanzisha UDSM na sehemu zingine wameanzisha innovation spaces. Lakini wakati mwingine kama tulivyosema, wanafunzi wengi hawapendelei kujiunga kwenye hizo innovation spaces kama wana panelists walivyojadili kwamba inabidi tuweze kuwasaidia angalau kubadilisha zile mindset. Fikiri kitu kizuri. Lakini sasa hivi kwenye this financial year nafikiri na nyie mnao, lakini sisi tuna mradi wa hiji kwa miaka 5. Moja program kwenye ule mradi ni kuangalia hizi technology transfer offices kwenye hizi high learning institutions. Unajua ni mradi wa high learning institutions. Sasa si kama COSTECH ambao ni tunafanya coordination kwenye mambo ya science na teknolojia na ubunifu. Kwa hiyo tuna fedha tulizotengewa kwa ajili ya kuangalia technology transfer. Kwa maana kwamba sasa hivi unakuta kwenye vyuo vikuu, hata nyinyi hapa mnafanya tafiti. Zile tafiti sidhani kama kuna mtu mtaalamu hapa na graduate bila kufanya tafiti. Weza ni undergraduate au ni postgraduate. Lakini unfortunately ni kwamba baada ya zile tafiti mnazofanya, matokeo leo mnapeleka wapi? Profesa huko pale najua mmeafungia tu hapo. Lakini kilichokuwa kinatakiwa na nchi za wenzetu wanachofanya ni kwamba zile tafiti zikishapatikana matokeo yale, tuna link sasa hizo na industry na different stakeholders kwa ajili ya kufanya zile dissemination. Yale matokeo ya utafiti yachukuliwe kama ni kwenye industry, product zizalishwe, output ipatikane. Lakini sisi kwa muda mrefu, sio tu Muhimbili na sio vyuo vingine pia, tuseme ni kwa nchi nzima, tafiti nyingi zimekuwa zikifanyika zinaishia tu kwenye makabati. Sasa moja wapo ya project ile ya HIT ni kutransform hizi GTOs, Technology Transfer Offices, ziweze kufanya kazi, ili angalau sasa kuona namna gani matokeo yale sasa yanaweza kutumika, na namna gani tunaweza tukalinki na industry, namna gani tunaweza tukalinki na different stakeholders ili kufanya dissemination ya zile research results. Kitu kingine pia ni kwenye kuanzisha hii, alisema profesa pale kwamba tunataka tuwe na wanasheria kwa ajili ya kulinda zile bunifu zetu, alisema profesa. Lakini Tanzania tayari tuna system nzuri ya kulinda. BRELA wapo wanalinda kwa maana ya zile bidhaa tangible, lakini kuna KOSOTA ambao wanalinda zile like machapisho, muziki na kadhalika. Hizo systems zipo, lakini wabunifu wengi hawako aware. Kwa hiyo katika programu hii ya HIT pia tutakuwa watasimamia pia kuhakikisha kwamba kunakuwa na focal person kwa kila university, IP focal person, intellectual property focal person, ambaye sasa yeye watakuwa knowledgeable, watafundishwa, watafanyaje. Lengo ni kuwasaidia, kwa sababu kama innovation spaces zinaanzishwa na wabunifu wanakuwepo, sasa mara nyingi kwamba inatakiwa wafundishwe, waambiwe kabla hujafanya chochote inatakiwa ulinde, kwa sababu sheria inataka usitangaze kabla hujalinda. Sasa mara nyingi kwa sababu ya watu wanataka fandi, wabunifu wetu akishaelewa tu kidogo anaenda kwenye vyombo vya habari anatangaza, bana mimi nina kitu fulani tu nimekaa pale nyumbani pale smart, ikiangalia tu baada ya siku mbili unaangalia ubunifu wako tayari uko mahali fulani. Sasa vijana wengi wamekuwa wahanga wa kupoteza haki zao. Kwa ndio maana inatakiwa hawa wafundishwe. Kwa hiyo ile project itafanya hayo, pamoja na kuestablish wa focal persons, lakini watapewa IP trainings ili waweze kuelewa. Kwa mwisho wa siku pia kuhamasisha kwamba vyuo waelewe kwamba kuna angalau kufanya kulink industry na university kwa ajili ya disseminate the results. Kwa ufupi sisi nimejaribu kuelezea tu kidogo sisi COSTECH tunafanya nini ili kuwezesha kwenye hiki tulichojadili mchana wa leo. Asante sana.
Thank you very much, COSTECH. We really appreciate it. Kwa sababu Mrs. Zahoro is a bit in a rush. So for those who are having questions directed to Mr. Zahoro himself, can please shoot them up because he has to catch a flight. He's leaving, people. He's leaving. The great man is leaving. So.
Thank you so much. Good afternoon, everyone. My name is Gloria. I'm a medical student at Muhimbili. Thank you so much for the panel discussion. I really learned a lot. So my question is, how long does it take for a health innovation to be applicable or not to be safe to use? Like, for instance, for a drug to be accepted, it has to go through trials, clinical trials and all that. So, and as you all know, that health sector is very sensitive. So if you introduce something like a drug or something that has to be used to a human, it has to go through a series of how can I say, tests or like investigations for it to be applicable and people to accept it as something safe to use. So like saratani eye, yes, how long will it take for it to be like applicable to be used? Thank you.
Thank you for your question. I'm afraid that is very technical for me to understand because how long can it be applicable? I think if it deals with health, it has to go through health protocols. Personally, I'm just an entrepreneur, just a businessman. I don't know much about how health industry works, on which stage they have to go through, who has to certify them, etc., etc., etc. That it will be tricky for me to understand the procedure. But I can tell you, just in case Saratani AI has everything it needs in terms of certifications from the health or a proper green light from the health people, how long can it take for them to be out there and be used? It depends on how fast they can be, but data from how the business operates in Tanzania are like this. 7 out of 10 new businesses die on the first year. 7 out of 10. So only 3 will survive. Then in 3 years' time, 9 out of 10. So technically, after 3 years, most likely, Saratani AI and all these other friends of his, if there were 10 startups today from MUHAS, which have already got a green light to go on the market, 7 will die in first year. That's why ukipita mitaani, you see the vibanda vyetu vile kimeandikwa bucha la nyama, lakini ukichungulia ndani unakuta kuna fundi cherehani. That means a guy with bucha la nyama paid the rent for 6 months, rent to bucha la nyama, biashara imemshinda, ameshindwa, then fundi cherehani has taken over 6 months. And if you come back next year, you will find kinyozi saloon in the same frame. That's how you might not see it. With that example, I think now you clearly get the picture. That's how business environment is out there. So 7 will die on the first year. Then we go in next 3 years, 9 out of 10. So technically, one business survived 3 years. So if you tell me how long will it take for Saratani AI when the day it's on the market, the answer will be in 5 years. We'll know. It's either he has made it or is already dead. And it's also good to fail, but you have to fail fast and cheap, we say. Fail fast, this is not working, drop it, go into another idea, and make sure it's cheap. Don't fail in a way that you have mortgage, urithi wako benki, umepoteza kila kitu. So just make it your failure very cheaper, and that's why I encourage you guys to do all these business ideas or innovative right now when you are to university. Why? Because now you can afford to fail. You're still a student. Hauna majukumu. You're not paying rent somewhere. You're most likely living on a boom ya serikali. So you can take all the risk. You can take all there are things you cannot just do at my age. I still have a lot of bills to pay. So failing to me is very expensive. But right now is the right time. So I think that's how long it takes for business to. And if you get to the 5th year, it's more likely you'll anyway survive longer as you can. Yeah.
Thank you very much, Mr. Zahar. Any last question to Mr. Zahar before he leaves? Thank you.
People say if you have innovated something, you have a product.
Don't expect to start getting profit very early. That is the basis for waiting until the 5 years he is mentioning. Last 2 weeks, I was at Mliman, University of Dar es Salaam. There were a lot of innovations there, and some are successful. Some have failed 3-4 times before they started making. But when they start making, they have a lot of money. They are rich people. They are rich people. So mine is not a question, but I wanted to add to him.
But I also saw your hand in a question, so you can shoot it out.
Yes, I have something here. If I can continue. Yes, I wanted first to clarify or add to Professor Moshi's explanation. In the coming organogram, there is a new organogram which is highlighting on having 3 DVCs, DVC academic and DVC research and innovation, where there will be also director of research and innovation, and there will be innovation unit there. Also, the Directorate of Research and Publication, they already have the IP office, Patience, you know, I think. So all those are being taken on board. Now, one of the challenges that we have been facing, Professor Moshe will testify, Samudi said it very well, because when Tambarike was, I entered when Tambarike was presenting, he said we have to help students to have networking with others. But where people have been failing is how to balance, and he responded very well actually, to balance between academics and innovation. And even that balancing between academic and innovation is by itself innovation. Yes, but I'm planning this for academics and this for my innovation. You can put even 1 hour that I will work in my innovation, but I have an exam tomorrow. And how you fix that is also innovation. Professor Moshe, we had one student from pharmacy who started to innovate something, I think 3 or 5 years ago. And he was just failing in the class. But then the dean says, but this guy is very bright. Then I asked him one day, if he was bright, he would be passing here. So that is a response to what Sangidu said, that you know that you can do something better in innovation, but how do you balance these things so that you can move along with them? Then, I'm sorry, the person in the middle?
He's promised.
Mr. Zaoro. Mr. Zaoro said you need also to do some research. If you have got your education here, you are able to link your innovation, and while you are doing your innovation, you can research others, how others are doing, or what else is missing, which I can do to improve what I'm innovating. But if you just bias to the innovation, you go somewhere, then you get stuck. You cannot move. So going around and reading here and there, networking with the others will enable you to do better for our students. Yes, so as our academic village here, I think we need to establish that counseling unit to work to counsel students who are failing to achieve. I think even those who want to innovate something, if they can go to the counseling unit also, they can advise them how they can handle both. Okay, or just get experience. You can see Dr. here is an experienced university member. You can go with your innovations. Then you say, okay, but I'm in the 3rd year. I am waiting for my exams. Can you advise how I can balance? I know she might not be an innovator, but she can help how to balance academics and your innovation so that you can perform better. That's all for this time.
Thank you very much. Okay. Before the next person, Ms. Promise wants to ask something.
First, I would like to congratulate the presenters for very innovative presentations. The first time I got interested in the issues of innovation was when some students were presenting their innovations. And I remember very clearly one student named Castori. He presented something on AI technology. And I was very much fascinated by that. That's why I wanted it to be here again today. And so, maybe Samudi. I got the idea, but I heard you saying you have innovated the technology Saratani, AI Saratani or something like that. So I am gathering that, I haven't had the details yet, I'm gathering that it is a diagnostic kind of AI technology. And so, and I was wondering, can this technology be exploited, for example, for developing preventive strategies for some specific diseases, to stimulate health-seeking behavior in those communities out there? Just you exploiting the same ideas. And I just wonder when we get rolling that the MUHAS students can really get into the communities with that technology instead of thinking of treating only or diagnosing only, but also work very hard to innovate on strategies to prevent and to encourage health-seeking behavior. Can you react on that a little bit?
Okay, thank you, Dr. Gasalasi. She's actually my teacher in second year parasitology. The moment I remember her, I was sitting in class and she was teaching us and I wasn't taking any notes. And actually it was all of the sudden asked, Samudi, can you repeat what I was saying a moment ago? Yeah, so to answer on the question, actually artificial intelligence technologies, they are of wide application. With Saratani AI, for instance, now we are doing cervical cancer screening, not the diagnosis. And actually to enable early detection of women with cervical cancer, precancerous lesions so that they can get treated. But there are other application of artificial intelligence, and one is Shaban is working on that. It's called Mama Plus, and this it helps to predict the chance of a woman of developing preeclampsia before even it happens. So you look at the parameters. You look at the parameters on that. So you look on the parameters before, and you predict that there must be a chance this woman will get preeclampsia before delivery. So the interventions can be done earlier. So that is one particular example. But AI can be utilized in whatever area of your specializations that you are working with. Yeah.
Thank you very much. Thank you very much. Thank you very, very much. This discussion has been very hot, people. I told you we are going to be mining, and I believe you've gotten enough gold. So with regards to time, I really wish we could continue, but oh yeah, Miss Prom. Yeah.
I just have one challenge to Professor Mwangi. Instead of actually managing innovation versus academic, is there a way we can reward innovation? An example, in China, the moment you have a patent, you get a master's. If you can come innovate and have your innovation patent, if you have that patent, you get your master's. So can we reward it?
Changamoto. Yeah, I think, with universities, we work with regulations. And all the discussions here, we discussed, and people said of changing attitude.
but also changing how we run our things. So if we convince the Directorate of Postgraduate Education to reward people who have innovative ideas and grant masters or even PhD, then they...
Okay, so we already have our ambassador.
But then they have to put conditions for getting those masters or PhD due to innovation. And for sure, because that directorate and that unit is going to be established, they should have, they must plan how to handle innovations at a relatively higher level, which is rewardable.
Thank you.
Again, the other thing is, if you look at what is happening around the works that the students are doing, it's very compelling that the way we teach should change. It's getting increasingly scary to go to class. It's true because there's a lot of knowledge out there. You go with your textbook, your lecture notes have come from a textbook. And what you find is that students have already read a paper that was published yesterday. This is becoming very challenging, but again, I think we need to start changing all the way down to kindergarten. How do we mentor these kids as they come up? Because that's where you also get teachers. You do not bring change through dinosaurs like me. It's true. I'm telling you, it's very difficult. You need very agile people to embrace the changes that we already see in the academic research and innovation ecosystem. So, like for example, it's high time we change the type of teachers who teach in kindergarten and primary school. We need to start infusing teachers with extensive knowledge of psychology to start nurturing and bringing up innovators, understanding people or kids who have talents. So it's becoming a complicated environment. But again, also fieldworks. Fieldworks, what do we give students to do in fieldwork? We need problem solving. Students should be assigned when they go to the field to also identify challenges and come with proposed solutions towards developing innovations. So you see how this ecosystem is changing, the whole environment is completely changing. We are coming to an age where it is the students who are going to be leading the learning rather than the teachers leading the learning. And we're going to be learning, it's going to be a two-way traffic, learning from each other. That's what I see in the learning environment.
Thank you very much. This discussion is not going to end, but we really have to wrap it up. So to finish up, I'd like to thank each one of you for your contribution. Thank you for your time. It really means a lot to all of us. Some people came without even knowing what is the innovation ecosystem, and I'm sure they're getting out with lots of ideas and very highly motivated. So having said that, I'd like I and my panelists to step down and leave the mic to Sikitambara. Thank you.
The applause wasn't enough. Can you give them another round of applause, please? As our previous moderator said, we really did mine gold, didn't we? Not only gold, diamonds, tanzanite, and all sorts of minerals. So far, this satellite session has been about exploring the MUHAS innovation ecosystem, the past, present, and the future. What I have learned is that this innovation ecosystem won't only involve MUHAS, it will also teach us to integrate medical students with other careers, with other people specialized in other things, engineering, accounting, commerce, and all those things. So this innovation ecosystem will not only be based for Muhimbili, but also for other people as well. Having said that, before we finish up, I would like to stress on something that Mr. Jumanne said and the panelists discussed as well. We'll be soon, we hope, to establish the Innovation Hub here at MUHAS, but then the Innovation Hub would be nothing if it has no one to use it, isn't it? Yeah, it would be nothing if it has no occupiers they have, right? Yeah, and Mr. Jumanne during his presentation, as well as Dr. David, of course, he said some of the initiatives done by the students was preparing a platform where students can present their ideas, a platform where students are challenged to come up with solutions for the healthcare system. Allow me to present to you the hackathon. The hackathon is an event where students are given challenges where they're supposed to think critically in teams to come up with solutions for the medical system. And that is one of the methods that Mr. Jumanne said we need to create innovators, people who can solve challenges. And how do we solve these challenges? We give them challenges for them to think critically and come up with solutions. So one of the ways to bring up innovators is by giving them challenges for them to solve. If you remember the presentation as well as I did. So far, I would like to welcome you to the hackathon. It will be hosted in August, we hope. It's one way of showing you that the health system is also changing. So we're trying to integrate these kind of technologies to the students so that they can very well be incorporated into the ecosystem for innovation to solve the challenges that exist. Allow me to welcome the closing remarks. And this one is the chairperson of the Muhimbili University Student Symposium for Debate himself. He and his organizing committee prepares the hackathon that I was just telling you about. So he himself will come to tell you very well of what we're planning to do, and he'll be the one closing the session today. A round of applause as we welcome Mr. White Frank.
Good afternoon. Good afternoon, Mr. Lee. It's okay. Yeah. Okay, so to our special guests, I invited ones and attendees. My name is White Frank, and she said I'm chairing the Muhimbili Symposium for Debate, right? I'm actually co-chairing it with Dr. David. Anyways, first of all, may I extend my sincere gratitude and thanks to all invited guests. And before going to any closing things, may I acknowledge the presence of Professor Mbugi. Professor Mbugi has been with us in the last analytics symposium, and we really appreciate that. And I'm glad he was taking notes. And I was about to ask Chief, what's up? He was just saying that the organogram is going to change and the innovation is going to be included, and we're actually very grateful for that. Thank you, Prof. And on the other hand, may I also acknowledge the presence of the representative from COSTECH, Mr. Gilimwa. This wave. Yeah, I've been at COSTECH since 2018, working with Boni Hub, and I've received a lot of mentorship from Boni Hub. And since then, I've been known Ms. Mwakale, and I'm very grateful. I am who I am partly because of Boni Hub, so I understand the importance of having hubs, and that's why we are fighting so hard. It's not fighting. I'm sorry. We're working so hard to push this agenda of having more innovation now. Okay, so to cement some things, maybe before we announce this session closed, we have learned a lot of things here around, but here are some few tips that we are pushing also as our agenda. when we are advocating about technology and the adaptation of technology, we don't mean to change our priorities. I was talking to a certain doctor and he was saying like, quite frankly, this is really time to discuss about technologies where we have a lot of infectious disease, we have a lot of non-infectious disease, and the burden of disease is so huge out there. And you guys were discussing about artificial intelligence, like, are you guys crazy? But something important to note here is technology is not here to change our priorities. Technology is just a tool to reach to our priorities. And it's not about changing the vision or the focus of where we are going, it's about sharpening it, right? So when we advocate about technology, we are far from changing priorities. We are far from saying, please don't deal with infectious disease, please deal with technology. There is nothing like dealing with technology. Do you guys get me? It's actually dealing with infectious disease using technology. It's actually dealing with non-infectious disease using technology. It's actually improving our diagnostic capabilities using technology. So it's all about using technology to achieve what we have planned and to achieve our priorities. And as we're going to work for establishing the coming hub, hub is not here to revolutionize the systems. It's here to make the system evolve to become the better system to accommodate us all, because the world is changing so fast. And therefore, when we are talking of having a hub, we're not talking of changing a system. We are talking about fostering the evolution of the system, because in the future, MUHAS won't be only the research and publication and whatever the academic university. Our aim is to make MUHAS a hub of technologies and solutions, a place where even when the government, when the external stakeholders, when anyone else outside there wants to do some stuff, thinks about MUHAS, wants to get solutions about health systems, thinks of MUHAS. And we have a lot of students, they call them cream of the nation, so exclude me, but the cream of nation, of which they're not supposed to just come here and pay for fee and get bachelor and leave. We have to utilize those brains. And the best way to utilize them is to create a pipeline of values, a place, a system where they can come, they can be nurtured, they can get the resources, they can utilize their brain, they can get solutions, and they can make MUHAS great and greater more than how it is now. That's our work as people from MUHAS innovation ecosystem. And maybe the last thing, we are ready to collaborate with all external stakeholders, and we have been with Brother Jumanne Mtambalike here from Sahara Ventures, and we have Ms. Probis, who is from MUHAS Costec, kinda. And thank you, we have people from administrations, and together, by that collaboration, we can establish a friendly model to run the coming hub, the friendly model to be inclusive to our students and actually to make the ecosystem sustainable and to make that ecosystem productive, to make that ecosystem looks great, and to have that standards of Muhimbili University, the premier of health, as we always know. Last but not least, I may extend my thanks to the organizing committee. My people, please stand up. You know, it wasn't easy, so it's okay if I really appreciate stand up, but please wave. Yeah. So wow, I was actually supposed to mention their names and actually to mention their little CVs so that you can get to know these people. But if you see all this great work, is because of this, ladies and gents here. And if you have anything connected to technology, innovation, okay, meet us. And also, may I extend my sincere gratitude to the Directorate of Research and Publications. It has been very helpful, the Directorate, to us, and also to the organizing committee of the 10th MUHAS Scientific Conference for offering this chance to students to organize this satellite session. We're really grateful. I don't see anyone here, but I know you're going to tell them that those guys say thank you, right? Yeah, and I also may extend this also to our panelists. Thank you for coming. Professor Moshi, we call him pioneer of all these stuff around. Yeah, he has been working a lot to help us. Ms. Makale, thank you. Thank you for coming. Thank you for Bunihab. And Mr. Samudi from Saratani AI. Yeah, he's my personal friend. So thank you. And also for the presenters and panelists who are not here yet. By saying that, may I say that this session is closed for now and meet you next year in the same venue, I hope. I hope we'll have, yeah, okay, yeah. Same venue, better topics. And probably we'll have more and great things to talk about. Maybe we'll talk about a lot of solutions around that we have achieved for the year. And just welcome when you see a satellite session for innovations and technologies, feel like I must be there. And by saying that, this is closed, and maybe we're heading to the closing ceremony for the conference. And you're welcome. Well, I'm glad. Thank you, and welcome. Okay, as we're waiting for the closing ceremony, we can have some photos outside. And yeah, we can have some pictures. I understand I have friends with good phones, so they can do that thing.
For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institute. That has provided For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared with the stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS scientific conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, the solutions that we think should be pursued in order to address them. The policymakers, for example, have been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
My focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, and on the treatment strategies. So by doing so, we've been conducting a number of studies which are informing the National Malaria Control Program and the Ministry of Health of the best treatment options and also the best diagnostic options which can be used in the country. Over time, at our department, we have developed collaboration with other research institutions, but we also strengthened our working relations with our local institutions. So throughout this period of 10 years, we've been able to contribute to the teaching at MUHAS, but we have also developed research infrastructure. We've been able to provide opportunity for students to learn on molecular techniques.
For the past 10 years or so, it has been a great opportunity and a transformative time. We have shifted the paradigm to make other colleagues understand that it is not only the quantitative that matters, but also the voice of the people, which is important. So in the other way, we are telling the policymakers, you don't need to change the regime because scientific results have shown no additional benefits in changing the regime. Weak capacity of the health system management as a function of governance contributed to most of the challenges we had. So in that matter, when you strengthen the governance component, you are empowering decision-making and the system. We have a specific master's program, which is a day program, Master of Arts in Healthy Policy Management, which has trained many people in this country. It is the only Master of Arts in Healthy Policy Management of this university, but again, perhaps the more specialized in this country when it comes to issues related to policy. If you conduct research and it is not disseminated in a proper way to the people who make policy decisions, is as good as if the research was not conducted. Our department has been working collaboratively with the Directorate of Continuing Education and Professional Development of this university, where our role is to translate the difficult scientific language into popular science and write policy briefs and make them available to the policymakers. You may have read about this sickle cell disease. One of the policy briefs that has been written was in making the hydroxyurea. Although it is classified as a cancer drug, sickle cell is not cancer. And this medicine can properly work to relieve some of the complications that are related to sickle cell. If we make it available only cheaper to our population, we will relieve the complications and will help our people. So the National Health Insurance Fund included it in their package. It was not there before.
The scientific conference is one of the important platforms for undergraduate students because it gives us an opportunity to collaborate between students from different faculties. For example, as we studied Saratani AI, it was difficult for me as an environmental student to make it by myself, but we collaborated between different faculties, including students from medicine, students from medical laboratory, from nursing, and we come up with Saratani AI.
Saratani AI is the artificial intelligence-based system that uses artificial intelligence to do the cervical cancer screening and diagnosis. The problem of cervical cancer in our country is very huge, and it's due to late diagnosis together with the shortage of pathologists.
So through Saratani AI is going to make cervical cancer screening more accessible because it will not need the presence of specialists. Even a medical doctor can use it in order to avoid screening cervical cancer. So also Saratani AI is more accurate, is an accurate of about 95%, which is higher than a normal pathology. And also it is able to identify indicating clinical presence of cervical cancer within seconds. So through Saratani AI, we are striving to have
wide accessibility of cervical cancer screening services, and also is going to fasten the process of cervical cancer screening. Instead of waiting more than 3 weeks, you can use Saratani to make the screening so to make the result to be available even after 3 or 4 days.
The MUHAS Scientific Conference has become a very good platform for our students to engage ourselves in research and innovation activities. And it has been a very good platform for us because we have the chance to showcase our ideas.
It gave us an opportunity to showcase our innovations. And through that, we got a lot of input that enable us to improve our innovations.
We have got a lot of invitation to other big conferences, like we have been to Chi Innovation Awards, and we presented our idea, and we have got the sponsorship, which has helped us to develop our model and to succeed on what we're doing. On 2021, I won an award during the Tanzania ICT conference, the 5th Tanzania ICT conference, and I was awarded as the best innovative student in ICT, and it was awarded because of the innovation, Saratani AI.
So the last MUHAS Scientific Conference helped me to understand the real problems that are facing the community because of the findings that were presented by different researchers and scientists. We are working in the project called Mkanda Salama, and the Mkanda Salama is the project that came immediately after seeing that the major cause of maternal death is PPH, postpartum hemorrhage, that causes about 28% of death of women in Tanzania. So after seeing this problem, we designed a local device called Mkanda Salama that is wrapped around the stomach of women, and then it can help to reduce bleeding immediately after delivery. So this mechanism of Mkanda Salama is that it's doing an aortic compression by compressing the aortic so that to reduce the blood flow after delivery, but also is doing the massaging to contract the uterus. So this device was tested at Ifakara Institute, where we found that 80% of women that used Mkanda Salama were saved. And we will present the results at Tanzanian Health Summit, and the results are published at the EMC Journal. In May 2022, during the Innovation Conference of Tanzania held in Dodoma, also we emerged as a winner in the best innovation in the level of university. So far now, Mkanda Salama is at level where we just want to conduct a large clinical trial across Tanzania so that we can have the findings that will help us to test our product and make our product be applicable in different healthcare facilities.
So as we're celebrating the 10 years anniversary of MUHAS Scientific Conference, I am so proud of it. It has helped a lot, especially as students, and it's a call to other students to engage in research and innovation because the platform is there. It's just a matter of themselves to engage, to go and show what their capacities, what they can innovate in solving a lot of problems and issues that face our communities.
For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared to many stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS scientific conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, and the solutions that we think should be pursued in order to address them. The policymakers, for example, have been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
My focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, and on the treatment strategies. So by doing so, we've been conducting a number of studies which are informing the National Malaria Control Program and the Ministry of Health of the best treatment options and also the best diagnostic options which can be used in the country. Over time, at our department, we have developed collaboration with the other research institutions, but we also have strengthened our working relations with our local institutions. So throughout this period of 10 years, we've been able to contribute in the teaching at MUHAS, but we have also developed research infrastructure. We've been able to provide the opportunity for students also to learn on molecular techniques.
For the past 10 years or so, it has been a great opportunity and a transformative time. We have shifted the paradigm to make other colleagues understand that it is not only the quantitative that matter, but also the voice of the people, which is the qualitative. So in the other way, we are telling the policymakers, you don't need to change the regime because the scientific results have shown no additional benefits in changing them. Weak capacity of the health system management as a function of governance contributed to most of the challenges we had. So in that matter, when you strengthen the governance component, you are empowering decision-making in the health system. We have a specific master's program, which is a day program, Master of Arts in Healthy Policy Management, which has trained many people in this country. It is the only Master of Arts in Health Policy Management of this university. But again, perhaps the more specialized in this country when it comes to issues related to health. If you conduct research and it is not disseminated in a proper way to the people who make policy decisions, is as good as if the research was not conducted. Our department has been working collaboratively with the Directorate of Continuing Education and Professional Development, where our role is to translate the difficult scientific knowledge into a popular science and the right policy groups and make them available to the policy. You may have heard about this sickle cell disease. One of the policy briefs that has been written was in making the hydroxyurea. Although it is classified as a cancer, sickle cell is not cancer. And this medicine can properly work to relieve some of the complications that are related to sickle cell. If we make it available on a cheaper way, to our population who will relieve the complications and will help them. So the National Health Insurance Fund included it in their package. It was not there before.
The scientific conference is one of the important platforms for undergraduate students because it gives us an opportunity to collaborate between students from different faculties. For example, as we studied Saratani AI, it was difficult for me as an environmental student to make it by myself, but we collaborated between different faculties, including students from medicine, students from medical laboratory, from nursing, and we come up with Saratani AI.
Saratani AI is the artificial intelligence medicine system that uses artificial intelligence to do the cervical cancer screening and diagnosis. The problem of cervical cancer in our country is very huge, and it's due to late diagnosis together with the shortage of pathologists.
So through Saratani AI is going to make cervical cancer screening more accessible because it will not need the presence of specialists. Even a medical doctor can use it in order to have a screening of cervical cancer. So also Saratani AI is more accurate, is an accurate of about 95%, which is higher than a normal pathologist. And also it is ability to identify indicating clinical presence of cervical cancer within seconds. So through Saratani AI, we expect to have wide accessibility of cervical cancer screening sector, and also going to fasten the process of cervical cancer screening. Instead of waiting more than 3 weeks, we can use Saratani AI to make the screening sample the result to be available even after 3 or 4 days.
The MUHAS Scientific Conference has been a very good platform for our students to engage themselves in research and innovation activities. And it has been a very good platform for us because we have the chance to showcase our ideas.
It gave us an opportunity to showcase our innovations. And through that, we got a lot of input that enable us to improve our innovations.
We have got a lot of invitation to other big conferences, like we have been to Chi Innovation Awards, and we presented our idea, and we have got the sponsorship, which has helped us to develop our model and to succeed on what we're doing. On 2021, I won an award during the Tanzania ICT conference, the 5th Tanzania ICT conference, and I was awarded as the best innovative student in ICT, and it was awarded because of the innovation Saratani AI.
So the last MUHAS scientific conference helped me to understand the real problems that are facing the community because of the findings that were presented by different researchers and scientists. We are working in the project called Mkanda Salama, and then Mkanda Salama is the project that came immediately after seeing that the major cause of EPS, postpartum hemorrhage, that causes about 28% of death in Tanzania. So after seeing this, we designed a local device that is wrapped around the stomach of that can help to reduce so this mechanism is doing aortic compression by compressing the blood flow. Also is doing the muscle to contract the uterus. So this device
kama vitatumika vinabaki hapo. Bila vile vya kule na
represent the results of Tanzania research and the result published there. In May 2022, during the Innovation Conference of Tanzania held in Dodoma, also we emerged as a winner in the best innovation in the level of university. So far now, Mkanda Salama is at a level where we just want to conduct a large clinical trial across Tanzania so that we can have the findings that will help us to test our product and make our products to be applicable in different healthcare facilities.
So as we're celebrating the 10 years anniversary of MUHAS Scientific Conference, I am so proud of it. It has helped a lot, especially to us students, and it's a call to other students to engage in research and innovation because the platform is there. It's just a matter of themselves to engage to go and show their capacities, what they can innovate in solving a lot of problems and issues that face our communities.
For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been shared to various stakeholders, and these have actually contributed to influencing policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS Scientific Conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, and the solutions that we think should be pursued in order to address them. The policymakers, for example, have been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
My focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, and on the treatment strategies. So by doing so, we've been conducting a number of studies which are informing the National Malaria Control Program and the Ministry of Health of the best treatment options and also the best diagnostic options which can be used in the country. Over time, at our department, we have developed collaboration with the other research institutions, but we also have strengthened our working relations with our local institutions. So throughout this period of 10 years, we have been able to contribute in teaching at MUHAS, but we have also developed research infrastructure. We have been able to provide the opportunity for students also to learn on molecular techniques.
For the past 10 years or so, it has been a great opportunity and a transformative time. We have shifted the paradigm to make other colleagues understand that it is not only the quantitative that matters, but also the voice of the people, which is the content. So in the other way, we are telling the policymakers, you don't need to change the regime because scientific results have shown no additional benefit in changing the regime. weak capacity of the health system management as a function of governance contributed to most of the challenges we had. So in that matter, when you strengthen the governance component, you are empowering decision-making in the health system. We have a specific master's program, which is a day program, Master of Arts in Health Policy Management, which has trained many people in this country. It is the only Master of Arts in Health Policy Management of this university, but again, perhaps the more specialized in this country when it comes to issues related to health. If you conduct research and it is not disseminated in a proper way to the people who make policy decisions, is as good as if the research was not conducted. Our department has been working collaborating with the Directorate of Continuing Education and Professional Development of this university, where our role is to translate the difficult scientific language into a popular science and write policy briefs and make them available to the policymakers. You may have heard about this sickle cell disease. One of the policy briefs that has been written was in making the hydroxyurea. Although it is classified as a cancer drug, sickle cell is not cancer. And this medicine can properly work to relieve some of the complications that are related to sickle cell. If we make it available only cheaper to our population, we will relieve the complications and we will help them. So the National Health Insurance Fund included it in the package. It was not there before.
The scientific conference is one of the important platforms for undergraduate students because it gives us an opportunity to collaborate between students from different faculties. For example, as we studied Saratani AI, it was difficult for me as an environmental student to make it by myself, but we collaborated between different faculties, including students from medicine, students from medical laboratory, from nursing, and we come up with Saratani AI.
Saratani AI is the artificial intelligence-based system that uses artificial intelligence to do the cervical cancer screening and diagnosis. The problem of cervical cancer in our country is very huge, and it's due to late diagnosis together with the shortage of pathologists.
So through Saratani AI is going to make cervical cancer screening more accessible because it will not need the presence of specialists. Even a medical doctor can use it in order to give the screening cervical cancer. So also Saratani AI is more accurate. It's accurate about 95%, which is higher than the non-technology. And also it is ability to identify indicating feature for presence of cervical cancer within seconds. So through Saratani AI, we expect wide accessibility of cervical cancer screening and also going to fasten the process of cervical cancer screening. Instead of waiting more than 3 weeks, we can use Saratani AI to make the screening information, the result to be available even after 3 or 4 days.
The MUHAS Scientific Conference has been a very good platform for our students to engage themselves in research and innovation activities. And it has been a very good platform for us because we have the chance to showcase our ideas.
It gave us an opportunity to showcase our innovations. And through that, we got a lot of input that enable us to improve our innovations.
We have got a lot of invitation to other big conferences, like we have been to Tree Innovation Awards, and we presented our idea, and we have got the sponsorship, which has helped us to develop our model and to succeed on what we're doing. On 2021, I won an award during the Tanzania ICT conference, the 5th Tanzania ICT conference, and I was awarded as the best innovative student in ICT, and it was awarded because of the innovation Saratani AI.
So the last MUHAS Scientific Conference help me understand the real problems that are facing the community because of the findings that were presented by different scientists. We are working in the project called Mkanda Salama, and the Mkanda Salama is a project that came immediately after seeing that the major cause of maternal death is PPH, postpartum hemorrhage, that causes about 28% of death of women in Tanzania. So after seeing this problem, we designed a local device called Mkanda Salama that is wrapped around the stomach of women, and then it can help to reduce bleeding immediately after delivery. So this mechanism of Mkanda Salama is that it's doing aortic compression by compressing the aortic, the blood flow after delivery, but also is doing the massaging to contract the uterus. So this device was tested at Makara Institute, where we found that 80% of women that use the Mkanda Salama succeed, and we present the results at Tanzania Breast Summit and the results at published at the EXC journal. In May 2022, during the innovation conference of Tanzania, also we emerged as a leader of the best innovation in the level of university. So far, now Mkanda Salama is at level where we just want to conduct a large clinical trial across Tanzania so that we can have the findings that will help us to test our product and make our product be applicable to different healthcare facilities.
So, as we're celebrating the 10 years anniversary of the MUHAS conference, I'm so proud of it. It has helped a lot, especially to us students, and it's a call to other students to engage in research innovation because the platform is there. It's just a matter of themselves to engage to go and show their capacities, what they can innovate in solving a lot of problems and issues that face our communities.
For the past 10 years, we have had the opportunity of staging annual scientific conferences at this institution. That has provided us with the opportunity to share whatever we are doing in our research activities. In HIV vaccine research, where I've been heavily involved, we have also been able to demonstrate that it is possible to engage our communities. Apart from HIV vaccine research, we have been conducting investigations of HIV in relation to mother-to-child transmission. And the information that we generated has been many stakeholders, and this has contributed to influence policies on prevention of mother-to-child transmission of HIV. Two of those studies contributed to the WHO guidelines for prevention of mother-to-child transmission of HIV, particularly in developing countries. When it comes to scientific dissemination, this is an area that I think the MUHAS scientific conference has provided us a strong opportunity of telling people what we have been doing, what we have found, what the challenges that we have encountered, and the solutions that we think should be pursued in order to address them. The policy methods, for example, have been able to take some of our recommendations and put them into implementation. The scientific conferences have given us a very good opportunity of sharpening our research skills. The MUHAS annual scientific conferences have given us a very unique opportunity to identify ways of communicating science to people in general, in a language they can understand, and be able to explain the findings that we get in a manner that policymakers can translate them into implementable solutions.
my focus over the last 15 years has been on malaria research and the neglected tropical diseases. So when it comes to malaria research, this is a very broad area. So we are mainly focusing on parasites, on diagnostics, and on the treatment.
A very good evening to all of you. Welcome very much to this closing ceremony for our 10th MUHAS Scientific Conference. This will be a very brief session, and my role this evening is to invite key people who will address this congregation as part of the closing ceremony. So may I now take the opportunity, with all due respect and protocol observed, to invite the chair of the conference organizing committee, Professor Melkisedek Thomas Leshabari, to give the recommendations and summary emanated from this 10th MUHAS Scientific Conference. Kwa hiyo kwa makofi mazito tumkaribishe mwenyekiti.
Mr. Vice Chancellor, dear colleagues, dear colleagues, dear delegates to our conference, I'm very happy to be with you again for a closing note. I'm really pleased to see the numbers which eventually attended our conference compared to what I said at the beginning. Mr. Vice Chancellor, dear colleagues and delegates, we had a total of 582 delegates who registered for the conference. And among these, 576 were here physically. We had 359 who attended virtually, including 500 who attended our conference via YouTube. I'm really happy to see this. And the number of abstracts which were received were 171, out of which 60 were already presented, and we did have 105 which were posters, and many of us were able to see them outside during free sessions. And as part of our conference, we had satellite sessions as well as oral presentations. And there are a number of very interesting things which are coming up from some of the research activities which are going on by members of our community, either academic staff or students or colleagues who are working in the health sector and participated in our conference. And among very interesting things which came up in the satellite sessions, for example, we see that, and this is very painful, particularly for people of my age, child violence appear to be a problem. And this is probably due to these children being exposed to violence, and that violence is probably coming from parents, and they may be particularly in the city, they may say these things in the neighborhoods. So what does this mean as a university, particularly those of us who are interested in research? We need to look into what kind of interventions should we put in place in order to address some of these challenges which arise from the way we are raising our children at family level, at child socialization. It appears also that it's quite possible if we increase our interventions empowering women in gender empowerment, it may lead into better outcomes, or will be contributing as a health community, a health university, towards attempting to address some of the health challenges our society is facing. We also see that one of the things which came up, which is interesting, is that at family level, when a mother dies, this carries a very significant impact to the family. And probably this is expected given the role of the mother in our societies. And given this kind of observation which is coming out, there is need for ways, because we are researchers, both our undergraduate, postgraduate students, as well as those of us who are academic staff and colleagues in NGOs and other institutions. These are the areas we need to really look into and start thinking of what kind of interventions we think should be developed, either by ourselves or by talking to people who we think can assist in order to address challenges of this type. One thing which is very interesting, and to me I'm not surprised, is the fact that almost half of the pregnancies in this country are unwanted or unintended. They happen by accident. I don't know. And when I heard this, I just said, well, I think this should not be a surprise, because if you ask me whether when my father and my mother had sex, the sex which led into me, was that sex really intended to have me? Or was it just an accidental pressure accident? Or could it be probably they could have taken one of them, or both of them were drunk, and in the process they ended up with somebody like me. So I don't know. This is interesting. Of course, while we want to plan families, we should think of what we can do to make sure that we get babies because we want them, and that they don't just come by accident. Another very interesting thing which came out again was that almost 50% of new infections are from KPs. And unfortunately, again, the focus on this, we are aiming at bringing HIV to an end by the year 2030. And we see, when we see KPs contributing this much of infections, it means there is really a need for us to direct our thinking in terms of, if we are targeting 2030 as the time when probably will epidemiologically should not have a worrying HIV infection. And we see population subgroups which to some extent are not against some of these intentions. We may have to again think of what strategies do we have to take in order for us to be able to look into the population subgroups which, for one reason or another, are not in line with our intentions to bring HIV to an end epidemiologically. And in so doing, come up with strategies which probably when assessed in 5, 10, or 20-year intervals, we see trends of these changes. Because having a goal of ending HIV by 2030, and yet after every 5 years, the trend is the same or increasing,
That will not be taking us towards the goal. And it will be upon us to really look for strategies to come up with ways of assisting our government, or the ways of assisting the society to attain the goals which were set for dealing with infections. Regarding NCDs, there are also very interesting things came out. 1 in 10 adults have diabetes. What we don't know is what proportion of adults generally have even bothered to check if they have diabetes. And myself might be a very good example, because I almost died. And when I was diagnosed to be diabetic, the physician who checked my blood sugar level almost collapsed. Even though I've been consulting him and several other physicians for more than 5 years before that was discovered. So maybe it's a need of alerting our general population to really check. It's not an expensive test. It doesn't take long and so on. So I think there is need for us again as people interested in health to look into what can we do to make people more responsive for their blood sugar levels. And there is evidence that apparently obesity and overweight is increasing in our country. And that could be partially due to socialization, again, in which in many situations, when people fatten up, they think this is very good. They think when you have a big tummy, it's a status symbol. And we may have to think of ways of doing this in order to control this type of problem. And the best way of doing this is to look into, first of all, how can I get education to the general population, as well as our health facilities trying to diagnose some of the problems which they may not be attending when people go for care. Mr. Vice Chancellor and colleagues, again, when it comes to what came out from the presentations, there are also very interesting things which we see. We see that psychological distress is quite a problem among our healthcare workers. And one should not be surprised, given that during the HIV/AIDS, during that time, we had quite a burden on them. But during COVID, it was a distress for them. If it was 5 times to some of us or the general population, it was 50 times among them, because they are taking care of people who are sick, themselves are very few, they don't have resources, and consequently, it's not surprising when you see some of the distress facing them. Again, it appears that people giving care to children with mental illness end up with terrible distress, almost a quarter of them, and almost a third had a very low resilience. There are presentations which show that female genital mutilation accounts for about 10% of over 10-year-olds. Cognitive impairment appear to be a problem, and Mr. Chairman, Mr. Vice Chancellor, remember during the COVID epidemic, we had all sorts of plants which have been ingested as treatment, and some of them, there are times when I used to tell my colleagues that if all these trees were medicines, then many of us will not have such high morbidity and mortality in the society. But our colleagues in traditional medicine appear to have come up with some medicinal plants which are useful, and I think with those kinds of efforts, research, it will be really nice, and we're looking forward that some of the activities which our colleagues are leading into this kind of discovery will be something useful. And should any other epidemic flare up any times in the future. I hope we will not see the confusion which we ended up with during the COVID epidemic. And Mr. Chairman, ladies and gentlemen, I'm happy to say that this is the briefing I would like to give, and I'm looking forward that with this, in our next year's meeting, we'll see a lot more presentations, a lot more colleagues from institutions within Dar es Salaam, and we'll try to probably see if we can even have colleagues from the other health-related universities coming to join hands with us in order to jointly think of what our institutions need to do in order to deal with the health challenges our society is facing. Thank you very much.
Thank you very much, the chair. I think the way he presented the clubs are not enough. Yes, now they're enough, but they are not organized. So I think we will clap 3, 2, 1. So we have the first set of 3, the second of 2, and we'll conclude with 1. So I will count up to 3. We will start. So 1, 2, 3. Thank you very much. You can see we're in a scientific conference. So allow me to take this opportunity to invite the chair of the scientific subcommittee, Dr. Edward Nkingwa Kija, to come and lead us in the award session. Karibu. Kwa makofi basi tumkaribishe.
Thank you very much.
Vice Chancellor.
Vice Chancellor, distinguished guests at the high table, fellow academicians, faculty members, ladies and gentlemen. It is my great honor and pleasure to present the awards to our colleagues who have distinguished themselves and performed very well during this scientific conference. And it is also my pleasure to say that for this year, we have increased the number of awards that we usually give. We usually give 2 awards, but for this year, we have increased the number of awards from 2 to 10. So without further ado, I would like to call the first winner, who has won for Best Abstract in the sub-theme of non-communicable diseases. And this is none other than Harriet Hiera. Harriet Hiera, yes. Thank you very much. I will not try to organize the claps. Thank you very much. The second winner for the Best Abstract in the sub-theme of cross-cutting issues and research, this is none other than Martin Dudziak. He's here. He attended online, so we'll have a representative collect the award on his behalf, and then we'll make communication for him to receive it. the chairperson of this parallel session. Yes. Thank you very much. The next winner is the best abstract in the sub-theme of antimicrobial resistance and traditional medicine. And this is Sungwa Matodo. Who is here? He's not here. Any representative from the traditional medicine? Thank you very much for representing Sungwa Matodo. Fourth winner is the best abstract in health system research sub-theme, and the winner is Godwin Pancras. Is also not here? Okay, any representative to collect the award on behalf of Godwin?
Yes.
Yes. Thank you very much, Professor Mugi. Professor Mugi's student will collect the award on his student's behalf. Thank you very much. The fifth winner is the best abstract in the mental health research sub-theme, and the winner is Lorato Rama. A big round of applause for Lorato, please. The next winner is the winner in the best abstract in the sub-theme of child health research, and the winner is Tiwonge Msonda. Tiwonge is not here. Can you have a representative? Thank you. The next category is the winner of the best abstract in the sub-theme of maternal newborn health, and the winner is Phineas Sospita. Phineas is not here. Representative, please. Thank you very much. The next category is a big round of applause for the representative. The next category is the winner of the best abstract in the sub-theme of communicable diseases. And the winner is Hane Ochieng Lichwak. Representative? Yes, Dr. Mucho. Dr. Mucho is not Hane. So those were the winners. Okay, big round of applause for the also are the winners for the sub-theme categories. Now we have overall winners, and we have two winners. So the first one is the winner who had the best poster, and the winner is Francis August. Thank you very much. Big round of applause for Francis, please. And last but not least is the overall winner of the best abstract among all the abstracts that we have received. The best abstract, and the winner is Harriet here. Big round of applause for Dr. Harriet. So, Vice Chancellor and the distinguished guests, ladies and gentlemen, that marks the end of the award giving ceremony. Thank you very much for listening to us.
So thank you very much. Thank you very much, Dr. Edward Nkingwa Kija, for this very well completed session. Another round of applause to all those who have won the awards. This time I will not organize them. But I think we will be doing justice if we requested the award winners to have a group photo with the high table. So I would like to invite all of them to come and stand behind the high table so that we get photo for this very important event. And the representatives. So kindly please march forward with your trophy. For the interest of time, I request that you don't take much time. So thank you very much. You can now go back and take your seats. So now we are very close to the end of the closing ceremony. And my role is not to say anything to please you, but to invite the people who have good words. And in a very special manner, I would like now to invite the Vice Chancellor of this university, with all protocols observed, to give closing remarks and officiate the closure of this 10th MUHAS Scientific Conference. That means, once he has spoken, I will not have an opportunity to take this mic again. For that matter, I request that we clap for ourselves for attending this conference. So with due respect, Vice Chancellor, karibu.
Habari za mchana. Jamhuri ya Muungano wa Tanzania. Jamhuri ya Muungano wa Tanzania. Nawashukuru sana watu wote ambao mko hapa. When we officially opened this conference, we did not recognize some of the people who have been very important on development of MUHAS as the university when it was still growing as the faculty at the college. But also there are some people of whom I missed. Therefore, like when I'm standing here for the first time, hearing all the good things, maybe even myself, I was unintended. I'm not quite sure because it's more than 50% of the pregnancies or the children which are born in Tanzania unintended. Even myself being one among those who thinks that when you have a big tummy is the status. I'm not quite sure also if I don't have mental health because of the stress of the work and how happy I feel today. Thank you so much, all those conclusions. And these people of whom they've contributed a lot to us at MUHAS. The first one is Professor Andrew Swai. Professor Swai has been here for a very long time. Most of us were students in internal medicine, had different administrative positions, including the director of postgraduate studies and the research. By then it was combined into one and not two when I was doing my master's degree. Secondly, Professor Kaushik Ramaiah had been at Hindu Mandal for 40 years. I'm sure a few days back was his anniversary at Hindu Mandal, but contributed a lot in diabetes mellitus in Tanzania and beyond. Whatever you see here, it was the start of the Professor Swai, Professor Kaushiki, establishing a clinic at Muhimbili National Hospital, which grew over, and the services has gone to the other regions within the country. Professor Kaushiki has participated in most of the disseminations, seminar, symposia, and the trainings that MUHAS has trained all, I can say almost all of the students who are taking masters in internal medicine. Then there's somebody who is not here, who came a bit late when we are opening the conference. And this is Professor Rucho Rosato. Professor Rucho Rosato is almost 90 years old. He's an Italian by nation. He decided after retiring to come to Muhimbili, University of Health and Rural Sciences, to strengthen training in hematology and blood transfusion. He's a renowned figure in the world in research. He's a renowned figure in services. The last time he visited my office was the 8th of this month, when he told me we have to strengthen diagnostic equipments in our facilities so that we can cope training and service delivery in our hospitals. And I'm sure that's very, very important if we want to take further hematology and the hemato-oncology to the next level. The last one is Miss Grace Palanjo from Mwalimu Nyerere Memorial Academy. She was here when we are opening the 10th MUHAS conference. And it's good, she's a daughter of our teacher. And not only our teacher, the leader of this university, as the head of department for so many years, the Dean School of Medicine, and the first Vice Chancellor of Muhimbili University of Health and Allied Sciences, Professor Kinzali Palanjo. Karibu sana, Grace. This is MUHAS. I know Mwalimu Nyerere Memorial Academy is growing very fast, and soon will be one of the major higher learning institutions in Tanzania. After that, may I take this opportunity, first of all, at least in front of the Acting Deputy Vice Chancellor, Academic Research and Consultants, Professor Erasto Mbogi, and the Acting Deputy Vice Chancellor, Planning, Finance Administration, Dr. Rod Kisenga, the Chairman of the Organizing Committee, the Chair of the Scientific Committee, heads of government and other institutions, developing partners, the official governments here present today, the distinguished delegates, academicians, scientists, students, ladies and gentlemen, without forgetting our colleagues who disseminate all the information from the media, that I'm very happy today to have listened to all of you in this scientific conference, which had been much more vibrant. When I looked how things have gone through the process, the arrangements under the organizing committee, the participation of the participants, for those who traveled very long distance, coming here, staying for the 2 days, the number of whom participating physically, but also virtually and through YouTube, tells me that this has been the highest success which we had for the past 10 years. We have to be very happy for what has happened. Asanteni sana sana kutoka kwa watu. For these 2 days, we have been working very hard. I'm sure that your aim had been to achieve the objective of this conference. But I can say these efforts have not been completed if the recommendations are not yet reaching the implementers and the policymakers. We know some few had been here with us discussing, exchanging different implementation lines of which they can be successful in our context. But I urge the organizing committee through the Directorate of Research and Publication to ensure these recommendations reach all implementers and policymakers so that we can change of the way we implement, we make our policies, and at the same time ensuring that what we are doing at MUHAS is reflected within the Tanzanian context and beyond. But that means, by saying, we change research and the innovations which we have into commodities of which we can market, and then we do the marketing. That's a very important for the next generation of this university. My colleagues, we have been here learning for these 2 days. I'm quite sure you have significantly increased your knowledge, your competencies in your respective professions and disciplines, but as well, this knowledge and the competencies will contribute to improving the way we conduct the teaching at our universities and the higher learning institutions, engage in research, and the most important, delivering of the services to the Tanzanians. MUHAS, we have been conducting this annual scientific conference for the past 10 years. The aim is to showcase the research activities conducted in this university, but as well as providing a platform for other researchers and other health stakeholders from within and outside the country to disseminate their research activities. I would like to commend efforts done towards achieving this and urge our researchers to continue taking the reading law in research and research dissemination in Tanzania and across the regions. To me, I can say this year has been very good year. Seeing Professor Swai here, it's not easy. I remember the contribution which had in research in this university. By then, we are not equipped as we are. I remember we are printing dissertation in the typewriting. And the ease can make you repeat a page. I know the young generation that does not understand me. is you repeat a page, and sometimes you can repeat pages if it is the whole sentence. But technology has changed over, and we have seen our young generation coming with artificial intelligence at the aim of ensuring that the quality of the services are delivered in this country. I've been following very, very closely on innovations of our students who has won in different exhibitions within the country and outside the country. I'm saying we have to be proud of them. More than that, of importance to me, I'm sure that we have as well, we, the old generation who are still here, to try to change much as possible the way we teach our students. From memorizing to innovative way of learning and doing things. So, if we go that way, we are going to change this university. We are going to utilize the available technology in teaching. We are going to equip this new generation, healthcare providers, policymakers, into the world of which they can fit anywhere in the world. Please, let's try to help them reach their ambition. I've attended the session on communicable diseases. It's among the sessions of which most people, they have attended. It was full, and it was the last one. Thank you so much, Professor Kaushiki, for all efforts in ensuring that the session has much contribution, even beyond of which we thought. NCD is increasing. Therefore, we have to explore more on how can we ensure that we prevent NCDs in our country and beyond our borders. It contributes significantly to morbidities and mortalities. At the same time, the burden, to the financial burden to the government of the United Republic of Tanzania. Solutions has to be discussed on preventions, including raising awareness to ensure that lifestyle is improved. The government of the United Republic of Tanzania, through the Ministry of Health, have recognized this as the problem and has dedicated an NCD week every year in November. And this has run for the past 3 years. And in recognition of university strength in research and research dissemination, the Ministry of Health have once again registered Muhimbili University of Health and Our Sciences to lead the preparations of the 4th Non-Communicable Diseases Scientific Conference in November 2022 during the NCD week, which this year will take place in Mwanza City. Hatutawaangusha na tutashirikiana na wadau wote ambao tumekuwa tukishirikiana nao. The NCD conference is another platform for you scientists to contribute your knowledge, to contribute your innovations, but at the same time, for implementers, clinicians, and all policymakers to mingle and come up with the solutions to the problems in this country. I'm sure for the private sector, the time to promote also the innovations and the new medical supplies and products so that we can address the issue of non-communicable diseases. Karibuni sana Mwanza, mwezi wa 11. Ladies and gentlemen, I should not let you start my words. We've been working very hard for the 2 days, aiming to achieve the objective of the conference. But most important for you, we are sure we at MUHAS, we have reached what you expected from us. Mtatusamehe sana kama kuna mtu atakuwa hakufikia kile ambacho alitegemea akipata. Lakini kidogo tunajua tumejitahidi, tuendelea kujitahidi na tutakitoa. I take this opportunity to once again thank all presenters, conference participants, session chairs, rapporteurs, conference organizers, and all those who have been working behind the scenes to make this conference a success. I would also like to thank the main sponsor of the conference, the Swedish government, through CIDAM and the other government partners who supported the research projects whose findings were presented during this conference. As we conclude this conference, I wish all the delegates who have come from near far, wish them pleasant, safe travels back home, and request your colleagues who did not attend the conference this time around to join us in the 11th MUHAS conference next year. Most important for you is that all of you who have attended this conference, you will receive the certificates. These certificates will be awarded digitally, as we are trying as much as possible to use digitals in everything. With great pleasure, I declare that the 10th MUHAS Scientific Conference is officially closed. Jamhuri ya Muungano wa Tanzania. Jamhuri ya Muungano wa Tanzania. Tokea kwenye hapa kazi tu na kazi lazima iendelee. Asante.